Good morning, everyone, and welcome to the New Hampshire House of Representatives Committee on Health and Human Services and Elderly Affairs. We have several bills noticed for this morning and this afternoon, as well as an executive session in between. But before we get to any of that, please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you very much. The first bill to be heard this morning is House Bill 1278 FN, and I'll recognize the prime sponsor, Representative Wendy Thomas.
Thank you, Mr. Chair and members of the committee. This is going to be an interesting day. We've got a lot of cannabis bills to bring forward. So I am Representative Wendy Thomas. I represent the town of Merrimack, along with 7 other representatives. I'm here today to introduce House Bill 1278, which is relative to qualifying medical conditions for purposes of therapeutic cannabis. As a legislature, we keep identifying conditions allowed under the New Hampshire Therapeutic Program. Since I've first worked as a rep, we've tackled insomnia, opioid usage, and anxiety. We keep adding new conditions as they become known. And how are they known? We read books and we talk to patients. I've actually connected online with 2 authors of cannabis books this past year. And ask them questions about their research that they've done. They let us know how the program works and how cannabis works. I started in the therapeutic program 5 years ago because of chronic pain. For me, it was a car versus a bike accident when I was a kid. Since being in the program, I've also used cannabis for insomnia, eating issues, gut issues, PTSD, and anxiety. I have found relief from all of these symptoms, some of which are not covered in the program. I talked to many people about therapeutic cannabis. They want to get into the program. They want to see if cannabis helps their condition. No one in the cannabis program uses cannabis to feel high or inebriated. I spoke to a caretaker in Maine, and she shared with me a wise truth. If you're getting high on therapeutic cannabis, you're using it wrong. However, the biggest concern I hear is, will I qualify because I don't fit into the current patient model? These are all examples of cases that would not qualify, but which should, in my humble opinion, for the therapeutic cannabis program. I'm having surgery and I understand it will be painful for a few months. Cannabis can help with that. I have IBS, but not Crohn's disease. Cannabis can help with that. I have long COVID. I have a procedure done regularly that gives me anxiety. In my case, that would be dental work. I'm getting older. When I work out, I'm really sore the next day. And I've also heard many times over, I have serious period cramps. The recent HHS report on descheduling cannabis identifies additional uses that cannabis has been found helpful for. These conditions include ALS, autism, wasting, cancer, chronic pain, Crohn's disease, epilepsy or conditions causing seizures, glaucoma, HIV/AIDS, multiple sclerosis, Parkinson's disease, persistent severe muscle spasm, persistent severe nausea, PTSD, and spasticity. Chronically ill patients are not interested in being zoned out on the couch. We have had enough of that, and we want the coach to put us back into the game. So why are we potentially denying New Hampshire patients relief just because we haven't gotten around to getting their symptoms or condition into law and on a qualifying list? I understand that many physicians are not interested in anything about cannabis. However, there are many physicians who are willing to learn about how this plant can help their patients. They are willing to look at reports and read literature that gives new information about possible uses. They are willing to let their patients try something different that has been demonstrated to work. Recently, the Therapeutic Cannabis Medical Oversight Board voted 7-1 to support this bill. I'm going to let the Honorable Jerry Knirk expand on that one. And there's a repeal portion to this bill that I'm going to let Mr. Holt speak to that. If this bill does not pass, at the very least, you will see me here next term advocating that long COVID, situational anxiety, menstrual pain, and gut dysfunction be added as symptoms to this program. Let's stop trying to practice medicine and let physicians treat their patients as they see fit. I'm happy to take any questions.
Any questions for Representative Thomas? Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. You sort of addressed this, but given the way the medical cannabis law works now with specific conditions only, I'm wondering if you've had talks with physicians about their preference in terms of having a lot more subjectivity as they would have if your bill were to become law, and whether they feel more comfortable being able to qualify people based on categories, or whether they would be more comfortable having a great deal more discretion as your bill would give them.
The physicians that I've spoken to that embrace therapeutic cannabis, and thank you for the question, that embrace therapeutic cannabis and that go out of their way to understand it are very open to prescribing it for additional symptoms that are not on the list. The case that comes up to mind is that so I had massive, I think I've testified before, I have cancer. And so I've had 3 massive cancer surgeries. The last surgery that I had, which was a revision to take care of complications I had from previous surgeries, the physician prescribed opioids 2 weeks before surgery to make sure that I had it in hand for use afterwards. It was not an ongoing prescription. It was a one-time prescription. I've talked to physicians that have said they would like the opportunity to prescribe the cannabis program for post-surgery pain as opposed, I mean, we can prescribe opioids, but we can't right now prescribe therapeutic cannabis, which has been proven by that HHS report to help with pain. So it's cases like that. There's also cases, and I haven't spoken to a lot of physicians. I've spoken to my primary physician, who is very open to this. I've spoken to some surgeons who are somewhat open. But a lot of them have said that especially now that HHS has proven that it is a medicine that works, they would like to be able to use it in other instances.
Follow up.
Thank you. So I should know more about this than I do, but I don't. So are you saying that in anticipation of a surgery, which will probably cause a great deal of pain, that is not a legitimate use of medical cannabis now because the person is not in pain yet?
Correct.
Or it's short term?
Correct. The qualification is chronic pain, and I think chronic pain is defined as it's either 3 or 6 months, and I believe the Honorable Jerry Knirk can, is it 3 or 6? All right, it's a defined amount of time. So if, for example, I'm having an artificial knee joint or a joint put in, that's going to be painful for a certain amount of time, and then it's not going to be painful. So that situation is situational pain. It's not chronic pain.
Representative Leon.
Thank you, Mr. Chairman, and thank you so much for bringing this bill to us. I assume you probably are aware that there's a discussion in changing the schedule federally from Class 1 to Class 3. But as a Class 3 drug, it would be most likely treated as any other FDA-regulated drug, which may actually have implications in the recreational market, which would foreclose any opportunity for people to seek out recreational cannabis for what is actually a medical need. Do you think that this bill would actually allow us to protect more people if cannabis starts being treated, their access to cannabis is actually restricted if, as a Class 3 drug, the FDA starts to intervene?
Yes.
Sorry, I know that was a big question.
You know, I mean, the rescheduling, it's about time. It's about time. We all, you know, those of us that are in this field, we know that cannabis works. We know that there are less biological effects on the body. It is more, if you're in pain, it is more healthier for your body to take cannabis. Your liver and your kidneys are going to thank you, as opposed to self-medicating with alcohol, which is what a lot of people do now because we don't have access. I have access to cannabis, but a lot of people don't have access to cannabis. As far as more people being open to the or have access to the program, if you look at the financial note, towards the bottom, it says, though indeterminable, the department estimates the bill may result in up to a 10% growth, increasing revenue by $70,000 per year, which would function to lower the application fee. So this bill, not only would it help physicians treat their patients, it would also help the patients in that it would lower costs. So I don't know if that answered everything.
Thank you, it did. And I apologize for peeking around a couple corners, but working as a medical device analyst for a long time, I know that sometimes the FDA does interesting things. So that's why I wanted to ask you about that, and I appreciate your answer.
Yeah, thank you.
Other questions? Representative McKay.
Thank you, Mr. Chairman. I had the privilege, or I'm not sure what it was, of being chairman of the committee. I think it ran for 4 or 5 years. So I wondered if you've talked to Mr. Holt and also the gentleman that's sitting right behind you, who's the chairman of a continuing committee. In other words, the work has been going on for quite a while, so I wondered if you have involved yourself with those two gentlemen in preparation for this legislation.
You're talking about Mr. Holt and the Honorable Knirk?
Yes.
Of course I have.
Thank
They're
you.
They're brick walls in this, not brick walls, that's the wrong analogy. They're very important resources in this field, yes. Brick wall. I didn't mean to call you a brick wall, my apologies.
You meant foundation.
I meant, yeah, whatever, yeah.
Colors, yeah.
Solid,
Good. That sounds better.
impermeable, yeah. Always reliable, whatever that is.
Invaluable resources.
Valuable resource. Thank you. Thank you, Mr. Chair.
Other questions? I actually have one, Representative Thomas. You had mentioned long COVID, and what were the other conditions you were talking about? If you don't mind repeating them.
Oh, sure. Long COVID, situational anxiety, which that means if you have a regular procedure, like if you have a cancer scan or if you have dental work, a lot of people get anxiety and doctors prescribe Valium for that, and we could prescribe cannabis. Menstrual pain is a huge one. Ask any college female what they use for menstrual pain, and almost all of them will say cannabis, or that they know that cannabis helps. And gut dysfunction, which would cover IBS and gut dysfunction that is not Crohn's disease. And that's just a very short list. That is a very short list. There's so many things out there, and if you'll indulge me 1 second. These are the books that I read about cannabis, and every time I see a new symptom, I write it down.
Looks pretty thorough.
Yeah, yeah, yeah. Some people read novels. I read cannabis books, but it's so important. And the thing is, it's people use cannabis the way people use alcohol. So alcohol was invented for us to sort of recreationally feel good, right? But when my babies were teething, what was I told? Rub whiskey on their gums. So we've learned, we've adapted, we've found a new use for alcohol. When I was young, and I was sick with bronchitis or something, my mother would give me something that she called grandma's recipe. It's hot tea, lemon, honey, and Crown Royal whiskey. So we've learned to use alcohol in different ways, and people have learned to use cannabis in different ways. And once again, and this is why we can never get rid of this program, it needs education. We need to teach the patients how to use cannabis. And if you are using the therapeutic program to get inebriated, you're not doing it correctly.
Thank you. Other questions? I'm seeing no other questions. Thank you. Also signed up to speak is former Representative Jerry Knirk.
Thank you, Mr. Chair. Yes, for the record, my name is Jerry Knirk, and I'm the chair of the Therapeutic Cannabis Medical Oversight Board, also known as TCMOB. And TCMOB is comprised primarily of providers and is statutorily charged with medical oversight of the therapeutic cannabis program. Representative Thomas has already covered a number of the issues about things that cannabis it works for, and there's a lot of evidence, strong evidence in addition to anecdotal. And our program serves about 13,000 patients. Most of them are between ages 50 and 70. Yes, TCMOB did vote 7-1 to support this bill. Now, to understand the importance of this bill or the impact of this bill, it's important to understand the rather cumbersome process of certification to be able to use cannabis as a therapeutic cannabis patient. Since it is a Schedule I drug, it cannot be prescribed by a provider. So therefore, the provider has to certify the patient as having both a medical qualifying condition and a qualifying symptom. The statute then confers protection upon the patient for the use of cannabis for that particular condition and symptom. Knowledge of the use of therapeutic use of cannabis is growing a great deal. It's been hampered because of it being a Schedule I drug, but in any case, it's still growing. And bills are filed every year to request new conditions be approved. And one of the primary jobs of TCMOB is really, in a way, to act like the FDA. We don't really, but we sort of like that. We review bills and see whether there's sufficient evidence of benefit of cannabis to allow the condition to be placed into statute, and then we recommend it to the legislature, who then acts upon it. So the point is, HB 1278 offers an alternative process for certifying. And that's important to realize. It doesn't just say a whole bunch of other conditions are good. It doesn't say that. But it offers an alternative process, allowing more provider discretion, but with clear safeguards in place. The provider still does not directly prescribe cannabis, because we can't, but they then certify that a patient has either a condition or a symptom for which, in their clinical opinion, they feel that the benefits of cannabis would outweigh the risks. There's been discussion in the past about just getting rid of this list of qualifying conditions and symptoms and just make patient certification at the discretion of the provider. That's been discussed in the past. But we have to realize that not all providers have a good knowledge of the therapeutic use of cannabis, and they don't have an FDA to guide them as to what, whether it's reasonable or not. So this bill is a very good compromise in that it allows some provider discretion for those who are knowledgeable about therapeutic cannabis. The way I've been looking at it is it really sets up a two-tier system for certification. Providers who really have a very limited knowledge of the therapeutic use of cannabis would still use the standard approach of consulting a list of statutory conditions and symptoms to certify a patient. That route would still be present in statute. The new tier would be available for the providers who do know more about therapeutic cannabis. They feel that they can make a reasonable, appropriate decision as far as the risks and benefits of cannabis, just as they make an informed decision on the use of any other medication, including the off-label use of FDA medications. So, in other words, if you don't know a whole lot, you can look at the list and say, yep, you've got chronic pain. I'll certify you got that. The state says that's okay. You're protected. The person who spends a lot of time and is really kept up on that literature can say, you know, it's not on that list, but I really think it's a good chance this will help you. And in your case, the benefits outweigh the risks. And so I'm going to certify you. So it's an alternative approach. A couple of minor issues, but important though. If we look at the bill on lines 4 and 5, the word that is used is or for this standalone qualifying condition. But the word in statute currently for regular is and. Now, the point is that when the program was designed, you had to have a condition and you also had to have a symptom. And sometimes it's hard to link a condition and a symptom together. Sometimes our prescribing is basically symptom driven. So, for example, they say you have a stuffy nose. We don't go to all kinds of detailed testing to try to figure out exactly whether you got a cold or you got a flu or whatever. We just prescribe a decongestant for the stuffy nose. That's a symptom-driven prescribing. So this bill allows, in a way, a symptom-driven prescribing. So let's say you have some anxiety. We don't have to delve into all the reasons why you do. You could be certified. There are safeguards that are really quite good in this bill as well. It limits provider discretion to certification of adults 21 years of age or older, and that's really quite appropriate given the risks of cannabis in kids.
Mr. Konerko, if you could start wrapping up, please.
Yep, I have 2 sentences, I think,
Okay.
left. Limiting provider discretion as well to debilitating or terminal medical conditions or symptoms also assures it will only be used in impactful conditions and symptoms and not capriciously. So bottom line, in summary, TCMOB urges passage of 1278 to enable provider discretion in certifying patients to streamline the certification process. And I'd be glad to take any questions. Thank you.
Thank you. Representative Merchant.
Thank you, Mr. Chair. And also, Dr. Konerk, the Honorable Dr. Konerk, it's nice to see you back here in the chamber.
Thank you.
In regards to providers, one of the things I think I heard was the level of knowledge the provider may have dealing with cannabis. Is there a possibility then to create a certification of those providers who have that knowledge? And if they have it, let them at that point in time not have to deal with a list. And at that point in time, if you have somebody who doesn't have that level of knowledge, certification, whatever we call it, then you go into a list of what you have, what you can and cannot do. I'm just trying to look at it and saying, how do we take some of the barriers out of this? If the provider has the appropriate knowledge, then why are we micromanaging it?
Well, from the beginning, the program has not required a provider to be certified. And the reason partly is it would add a cumbersome bureaucracy. We'd have to develop some kind of testing procedure to determine competency. In many respects, you think about it, any provider is already, if they're already licensed and they already are, they also have a DEA license, they've already demonstrated a level of competence in terms of understanding and thinking about medications. And we certainly do that if we prescribe an off-label use of an FDA-approved medication. We're looking at, the FDA isn't backing us on that because the company didn't go through the years of testing and hundreds of millions of dollars, but instead you're saying, look, we got pretty decent evidence that it works in this, and they make that judgment. And in general, I would hope that for me as a spine surgeon, I wasn't going there and doing all kinds of off-label prescribing for psychiatric medicine. I shouldn't, because I didn't know that stuff. I'm not trained in that. So as a result, you would hope that the provider would use their usual discretion of saying, I know enough I can do this, or I don't know enough I can do this. But I think certification just adds more administrative burden.
Thank you. Thank you, Mr. Chair. I concur with what you're talking about, Dr. Knirk. However, by creating a list in the statute and what we're doing here, we're creating another level of bureaucracy. So I'm trying to find out how to minimize that level of bureaucracy. I know we're creating another level of bureaucracy, but is one less onerous than the other? That's what I'm trying to get to.
Well, I think one of the things about this, in this bill, it doesn't require that we have a bureaucracy to assess whether that provider's decision is appropriate. That is not in the bill, which I think is okay, because again, we don't do that for non-FDA approved drug off-label use. But instead, we have a responsibility. And if some provider is really going off the wall and doing some pretty weird things, just as they would for standard FDA-approved medications, the board, their disciplinary board, would look into this. That's where anything would go. But that have to be pretty egregious, as it would have to be for regular medicines.
Thank you.
Representative Missouri.
Thank you, Mr. Chair. Thank you, Doctor, for taking my question. Here it says the TCMOB voted 7-1 to support this bill. Just curious, what was the reasoning that one person did not?
Yeah, let's see. I'm looking quickly at my notes, and I do not recall. I'm sorry. I do not recall why that person voted against. Sorry, and I don't even recall who it was. My apologies.
Representative Shapiro and then Representative Leon. I'm sorry, you had a follow-up? I'm sorry.
Would
Just a
it be
moment.
possible to get that information?
May I consult with?
I'm just really curious to know that.
I don't know. I don't know if Mr. Holt plans to testify or not, but
He does.
that's right. That's okay. That's who I thought it was, but I wasn't sure. He confirmed for me that the person who voted no actually did not participate in the discussion. He didn't say anything about why he felt that way. He just voted no. So I was pretty sure that I just didn't want to state something I wasn't certain of.
Okay, Representative Shapiro and then Representative Leon.
Thank you, Mr. Chairman. To piggyback on the previous question, you had pretty good consensus, but not complete consensus. And if you don't know what that person's reasons were, certainly you've encountered, or maybe you've encountered other, not prescribers, but what's the proper word? You've encountered other people who were able to qualify people who are resistant to this idea of more discretion, more subjectivity. If you have,
Yeah.
what would the argument on the other side be?
I think oftentimes it just rolls down to saying, well, we don't have the FDA to really kind of give us the backup. We don't have as much data as we would like. And we certainly agree with that. This is something that's proactive. I mean, any provider really ought to be looking at the data before they start giving people medications. And if it's pretty weak, they might want to think twice about that. And that's true in cannabis as well. I think it's important to realize running this particular board, TCMOB, is really like herding cats, because I've got people who are basically almost anti-cannabis to people who are very pro-cannabis, and trying to get even close to unanimous is a real task, and it takes a lot of work. So, but that gives us strength, because it means we don't just all kind of lockstep go the same way. We end up trying to compromise with what we come up with on our recommendations, because we have to. Because if I walk in here with a 4 to 6 recommendation, that didn't mean a whole lot to you.
Representative Leon.
Thank you, Mr. Chairman, and thank you so much for coming back and all your involvement in this. My question has to do with the bill that we passed last term about the off-label prescribing, where for the FDA-approved drugs, somebody would have protection from an inquiry from the licensing board if they prescribed a FDA-approved drug off-label. It would be my understanding that the medical board has no such restrictions on looking into any recommendations that people have for cannabis, so that if it appears that this is moving out of control, the medical board would would probably be the appropriate place and they're fully enabled to do so. Is that your understanding too?
Well, that's my understanding too, is that if somebody is really going off the wall, that the medical board would be just like they would for anything else. If people are doing inappropriate surgeries or they're doing prescribing of FDA drugs inappropriately, that's the medical board that would say, wait a minute, this is not the standard of practice, not even close.
Thank you.
Yes.
Yes, Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. With respect to the 21-year age restriction in the new edition, that doesn't exist in the existing schedule. Since you're kind of creating two-tier, those providers who are familiar versus those who are not, would you not want to have that available to folks younger than 21? So if you could dive a little bit deeper into the thinking as to why that restriction is there?
Well, we do have a restriction for minors in the program already, and they require a second certification. So if you're seeing a specialist who says, gee, I think you would be you benefit from the use of therapeutic cannabis, you have to get a secondary certification from a medical provider. It currently says from a pediatrician. We have a bill in the Senate which is trying to change that to be a provider who provides pediatric care, so it could be a family practice person, because in reality, a lot of people don't have pediatricians up in the North Country. So there is, that's why we only have about 10 kids certified in the program, because there are rather robust safeguards, and we feel that that is a setting where you want to have, in a sense, the approval of TCMOB in the legislature that it's okay to prescribe in that setting. But even there, we have battles internally in TCMOB about, what we still allow for kids. So this is a provider discretion. We are comfortable with the idea that we would not provide discretion for that age group under 21, be a little more rigid on that.
Follow up.
So even with a secondary recommendation, no go.
Well, that's currently how this is written, and it's what we agreed with. I think that certainly could be an amendment that could be placed, saying that it could be at any age, but anybody under 21 requires certification by a provider of pediatric care. That could be placed in as an amendment, but I think the demand for that will be relatively small. I'm not sure.
Thank you very much.
Yes.
Other questions? Seeing none, thank you.
Okay, thank you. Oh, actually, may I say just one other quick thing about the Schedule 3? We've been talking about that for decades. We've been talking, to wait for that doesn't make sense. I think it's okay to move to this. If it becomes moot, great.
Also signed up to speak is Representative Heath Howard.
Thank you, Mr. Chairman and committee members. I really appreciate you having me here today. So I really support this bill because of my own personal experiences. When I was 16 years old, I broke my back. I had an L4 burst fracture, and 2020, I had one of those rods actually broke, so I had to have a secondary surgery to take all of that hardware out. And through that, I dealt with a lot of chronic pain. I still do, and I am currently I'm a part of the therapeutic cannabis program. And that was a challenge for me to get on. It was a long process dealing with pain management doctors over at Wentworth Douglas. They did a good job of making sure that I was following the proper procedures and were taking proper care before moving on and going through the cannabis route, because I have refused any opiates. I prefer not to take them if I can. And it's something where luckily we have changed the requirement to remove the secondary testing of medications before you move on to the cannabis program. And I think that there are potentially a number of other people suffering from other conditions that are allowed in other states, but we haven't necessarily proved them here for our qualifying conditions. And going through and allowing providers to make the proper decision for their patients and what would fit them best, I think would serve the state well. That's all I have. Thank you.
Okay, thank you. Any questions for Representative Howard? Okay, seeing none, thank you. Also signed up to speak is Michael Holt from the Department of Health and Human Services.
Good morning, Mr.
Good
Chair,
morning.
members of the committee. My name is Michael Holt. I'm the administrator of the Therapeutic Cannabis Program. I've been involved with the program since its inception in 2013. Thank you for the 2 minutes that I can take to add some clarity to this bill. I wanted to point out that there's another provision in this bill that hasn't been discussed. This is the repeal. This is line 9, where the proposed bill would repeal RSA 126X2VA relative to limitations for a visiting patient. So this bill would remove those restrictions for visiting out-of-state patients. In 2021, the state law changed to allow out-of-state patients to access the New Hampshire dispensaries. And currently, the law says that a visiting patient can have 3 visits per year at a New Hampshire dispensary, and after which they need to show medical documentation that they have a medical condition on the New Hampshire list. So when this law was proposed in 2021, a parity issue was raised. New Hampshire has a smaller restrictive list of qualifying conditions than many other states. And more importantly, New Hampshire does not have what's being proposed here, which is a catch-all, an any condition catch-all that provides discretion to providers broadly for certification of any condition. So the concern was raised in the Senate that it would not be fair to New Hampshire citizens if we allowed an out-of-state patient who is certified in their state for a condition not on the New Hampshire list, say anxiety, to access the New Hampshire ATCs, when New Hampshire citizens couldn't access the program with the same condition. So they put in this parity clause that says you get 3 visits before you have to show that you have a New Hampshire condition. So this bill as proposed would add such a catch-all any condition, creating parity with other states. It's very common for other states to allow certification for any condition based on provider discretion. New Hampshire does not. So if the bill as proposed moves forward to allow any condition, it removes this parity issue. So I just wanted to give the committee the knowledge about what that repeal provision was about. I'm happy to answer questions about that or anything else with regard to the bill. I would say one thing, the department can operationalize this new 2-tiered certification system without issue by amending the written certification. Thank you.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. Dr. Knurk mentioned a 2-tier system, and you just mentioned it again. So what is the purpose of having a 2-tier system, and what potential downside is there to having a 2-tier system? If the medical providers are going to have this great discretion, why have the conditions remain in the statute that are there? Why not repeal all the specific conditions and just have provider discretion?
Well, that is not the bill in front of us.
Right.
I'd be happy to talk about a different model. The legislature has, in the past, reviewed a bill that would have repealed all the conditions and given providers complete discretion with no guidance whatsoever, and that was killed a number of years ago.
Right.
And so, based on that legislative history, a model that keeps the current system but adds another way for certification, I believe, by the sponsors, was the way forward at this time. The current system is inadequate. It prevents people from accessing the program, even if their providers see value in trying this alternative therapy. And so the current system restricts access, it restricts provider discretion, and so that's why we need at least this additional process for certification. I'd be happy to consider other models, but that model that you're proposing was killed a number of years ago.
Follow up.
Follow-up.
Thank you for your answer, and I was asking for an opinion on which is preferable, but you're probably not the right person to ask that question to.
I'm in favor of whatever models allow access to as many patients who want to try this alternative therapy and have the support of their physician or their medical provider to access the program.
Thank you.
Representative McKay.
Thank you, Mr. Chairman. Mr. Holt has been involved with this for years. And in fact, he was probably the only person in the department that did this work for a very long time. So he should be commended for that. The one question I have is that this process will produce $70,000 a year, and that $70,000 goes outside of the department. The department has, it says, where is it? Apply to the program, there will be a application received by the department. The department estimates the bill under, it sounds as if it lowers the cost for the people providing the marijuana instead of increasing some staff function. So if the 70,000 is staying in the department, then I'm curious as to how that is being spent and whether that's giving you some support out of that 70,000.
Well, first of all, thank you for the generous words. I have been working on the program for about 10 years, and so thank you for that. With regard to the fiscal note, the LBA recently changed their processes, whereby when we do fiscal notes for proposed legislation, we can no longer say indeterminable without having a range. So part of this information is specifically in response to LBA rules for us to provide an estimate when we really do not know what kind of fiscal impact this could have. And so, so that's one thing. I believe that this will result in many more patients being certified for the program, but I also believe that this proposal will reorient patients currently on the program. The next year for certification, a doctor will use this second tier to certify. Anxiety, for instance. Many people are being certified under PTSD when they have anxiety and perhaps don't have a diagnosis of PTSD. So it's hard to say how much this is going to improve the revenue. That being said, this program is 100% self-funded through patient fees and through ATC licensing fees. And so whatever revenue that we get, the state gets from patients, if that is less than our costs, we will bill the ATCs for the difference. So that's what this is trying to describe. I will say with regard to patient fees, 2 years ago, the law changed to allow providers to issue certifications up to 3 years. We did not raise our fees. Our fees have been $50 for a card since day one, and now under the new law with a 3-year certification, the fees are still $50. $50 for 1 year, $50 for 3 years. So we're at a place of stability with the program finances, and so I would not characterize this bill and this language as suggesting that money will go outside the system. It's more of a description about how the system works, where when we don't receive enough revenue from patients, we're allowed to bill the ATCs for the difference.
Thank you very much, because it concerned me that there's been such a lack of support for this program that the money would be going elsewhere, and if it's not, I'm very pleased to hear that.
It's a dedicated fund. All the money stays in the system. We've been working for years to stabilize the program. We have sufficient support in the department now under the Division of Public Health Services, and to the extent that we were able to essentially reduce patient fees by 2/3 based on that, that recent legislation that allowed 3-year certifications.
Thank you.
Thank you. Other questions? Seeing none. Thank you.
Thank you.
The last person signed up to testify this morning on House Bill 1278 FN is Matt Simon from Greenleaf Cannabis.
Thank you, Mr. Chairman, Honorable Committee. For the record, my name is Matt Simon. I currently work for Granite Leaf Cannabis.
Sorry.
No problem. We're one of the 3 alternative treatment center companies in New Hampshire, a nonprofit focused solely on serving New Hampshire dispensaries in Chichester and Merrimack. And we support this bill. My comments will stem more from my involvement 10 to 13 years ago as the legislature was debating and ultimately passing this law in 2013. A lot of the rhetoric surrounding the bill was based on the idea that if a doctor believes a patient can benefit from cannabis, then who is the state of New Hampshire to stand between the doctor and the patient? And the law that we ended up passing did not give doctors the discretion to determine if cannabis might be right for a given patient. We instead used the system that we created, which I'm fine with. And I would echo everything that former Representative Knurk said and the sponsor said about creating this 2-tiered system. We're not breaking the thing that's been working for 10 years. What we would be doing by passing this is simply allowing doctors to be doctors, do their jobs. If they have a patient who doesn't have something on the list and they believe it's a unique case, it does create a higher threshold. They have to attest to their opinion in writing and say that they believe that the benefits would outweigh the risks for the patient. So I support the bill as is. I think it's great. I want to comment briefly on the rescheduling issue since there were a number of questions about that. I've been reading everything that I can find on the prospect of rescheduling. Of course, we don't know whether it will happen or not. It rests with the DEA currently, but let's say that it is approved, as many of us hope. Everything that I've read suggests that rescheduling is not going to have any impact on state level therapeutic or quote unquote recreational cannabis regulation. That moving it to Schedule 3 would have a number of benefits. It would make research somewhat easier. It would likely lead to the development of new drugs that would be put through the FDA approval process. But the FDA is not in the business of approving plants. And the idea of putting whole plant cannabis through the FDA approval process, my understanding is that's very unlikely to ever happen. So changes will likely occur, but it's not expected to change anything with regard to state level programs. And as one example I could point out, Congress passed the Farm Bill in 2018 legalizing hemp. Hemp has been federally legal for 5 years, and there still are no federal regulations for CBD or any other hemp-derived cannabinoid. We've been waiting 5 years and nothing has happened yet. So I would agree with the comments that we can't wait for the federal government. We have to try to pass the best laws we can to benefit the citizens of New Hampshire. And I would be happy to answer any questions.
Thank you. Any questions? Representative Leon.
Thank you, Mr. Chairman, and thank you for those comments. When I raised that issue, I viewed that this is actually de-risking New Hampshire patients. If we do approve this, would you agree that if there are other restrictions, because this is being done through doctors, and that's the way that pharmaceuticals are dealt with, that would de-risk the access to these patients? And if you can't have a firm answer, that's all right.
Yeah, no, thank you for the question. I don't believe there's any risk to patients to begin with, so you can't de-risk zero, but thank you.
Other questions? Seeing none? Okay, thank you. Also signed up to speak is Heather Stockwell from RAD, New Hampshire.
Could you
Good
push the
morning.
button for the microphone?
I have to push it?
Yes.
And do I have to hold it?
No, once
All right.
once the red light goes on, you're all set.
Thank you for that instruction. Yeah, I'm Heather Stockwell. I work at Rights and Democracy. I'm the healthcare organizer. I've been doing this work for approximately 6 years now, and I talk to people about their healthcare every day. I'm also a patient, and the reason I'm speaking here today over other people that work at Rights and Democracy is that I have the most knowledge about this. I too read a lot of articles and books about cannabis, and I have for longer than 6 years. I, like millions of Americans, did before this program use what is considered recreationally. I would use the term adult use. I now know that I'm gonna pause there for a second. I'm not a medical card holder yet in the state of New Hampshire. And that's why I'm speaking today, because I have faced barriers in getting that card. And part of that is really because of the provider side of things, because they are so not knowledgeable. In fact, I go into appointments having more knowledge than my own provider on this topic. I have many qualifying conditions. I should be able to get a card. Some of them are chronic pain conditions, but I also have anxiety as well as insomnia. These are both things that I could be treated for, and I really want to talk about the anxiety part, because the first line of action really for anxiety from providers is to give you what is known as a benzodiazepine, I believe it's pronounced. There's a lot of evidence that this is a very addictive and quite strong drug. And I have chosen not to go that route unless I really feel that I'm incapable of doing something. But I can be capable of doing things with the anxiety if I had a cannabis card, if it was easier for me to get. I really appreciate the fact that this would lower the cost and that the committee has worked to lower those costs, making $50 a year. Now it's $50 for 3 years. That is another barrier to patients. The cost of medical cannabis is not cheap. And so getting a card and having that barrier of another $50, a doctor's appointment, maybe several doctor's appointments, starts to rack up, especially when you might also be managing other health issues. You might have to have surgery, right? There are a lot of costs associated with some of these medical conditions, and keeping those costs down for patients is certainly a big concern.
Could you start wrapping up, please?
Yes, sure. I think that's really the last point that I wanted to make. I personally, in the past, before we had this law, I used cannabis to quit smoking. I see that there are so many positive uses for this, and if you're looking at things in terms of like harm reduction, cannabis is, in my opinion, less harmful than so many of the other substances that we allow doctors to prescribe. And it's really time for us to see through some of the nonsense that we have created, consider the FDA, scheduling and things like that. So I really appreciate the time that you've taken to hear me out here and hear a patient side of things. And I'd be happy to take any questions if anyone has any.
Any questions? Seeing none, thank you very much.
Thank you so much.
No one else has signed up to testify on HB 1278 FN, so I'm going to close the public hearing on that bill and open the public hearing on HB 1240 and recognize the prime sponsor, Representative Heath Howard. Also, I'd like to point out that all of the bills should be on the side table, but if members of the committee need those or any others, they can see Karen Davis in room 201, and she'll be happy to furnish those. Representative Howard, welcome back.
Thank you. Thank you, Mr. Chairman and committee members. So the purpose for HB 1240 is because, for me, I somebody very close to me has dealt with anorexia. And anorexia is one of the deadliest deadliest mental health disorder, killing anywhere up to 5% of anybody who's diagnosed with it. And we need to be ensuring that anybody who has anorexia is eating. It doesn't matter how they get food, it's that they get it. And the states of Maine, California, New Mexico, North Dakota, Illinois, Maryland, Nevada, Pennsylvania, and Oklahoma all have similar legislation on record. And as we've already kind of discussed in the recent FDA report that was released, we had seen that in their findings, they had used a study from the University of Florida, where in Florida, there is only one exception for treating anorexia with cannabis, and that's for patients dealing with cancer. And I apologize, but there are limited studies on the effectiveness of cannabis on treating anorexia, but they did find that there was moderate success in treating anorexia with cannabis in this, and it was part of the reason why they decided to recommend it to be rescheduled as Schedule 3. So not only can cannabis help provide an appetite for patients dealing with anorexia, but anorexia is a mental health disorder, and there's a lot of anxiety that goes along with it. And of course, we already recognize that cannabis can help people dealing with this. So it kind of helps people on two fronts. So if we can help provide cannabis to some of these people and help them actually obtain, hold food, then we can actually help save lives. Thank you. I'm open for any questions.
Questions for Representative Howard. Representative Palmer.
Thank you, Mr. Chair. I'm too short. Thank you, Mr. Chair. Thank you for taking the question. I'm just curious about whether Bill 1278 would cover this.
Yes, so it would. I mean, I would prefer HB 1278 over this bill, but as we know, sometimes bills can often end up being shot down and ITL'd, so it's always good to kind of cover our bases.
Representative Leon.
Thank you, Mr. Chairman, and thank you, Representative, for bringing this to us. We heard before in the previous bill's hearing that there's the issue of having both the underlying diagnosis and the symptom. Would we need to add anything to those symptoms so that these patients can actually get the relief that they need? Or is that already covered in the symptoms that are listed?
That would be best answered by somebody else.
Okay, thank you. I just want to make sure if we do it right.
Yes, of course.
Thank you.
Other questions? Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. And I'll just say that it's fine if you can't or don't want to answer this. But I wonder if you had considered limiting the covered eating disorders to anorexia, since some of the other disorders include binging, and I wonder if using medicinal cannabis in that case would have a paradoxical and maybe negative effect.
Yeah, so I mean, I would be open to an amendment. As we know, the other eating disorders listed in this bill would actually benefit from medicinal cannabis. But I mean, as I had mentioned, with eating disorders, it is a very mental, it's a very mentally focused problem, and it's a mental health disorder. So if somebody does have binge eating disorder, they may benefit from it, and I think that would be best left to the provider. Thank you.
Other questions? Seeing none? Okay, thank you. Also signed up to speak is Representative Wendy Thomas.
Thank you, Mr. Chair. You guys are going to be sick of seeing me by the end of today. But I'm here for a good reason. I'm Representative Wendy Thomas, again from the town of Merrimack, and I am in support of this bill. I want to give you, I'm going to take this off. I want to give you a personal example of how cannabis has helped an eating disorder. In November of 2020, I came down with COVID. And I developed long COVID. And so for a year and a half, I had no smell. I could not smell food. I couldn't taste food. I had no appetite and no thirst. This was called long COVID induced anorexia. It was not a mental condition, but I could not eat food. There was no desire to eat food, and food actually made me feel ill. Many of you that have served with me before, many of you didn't even recognize me. I lost 80 pounds. And that was because of malnutrition. I literally could not get the food into my body. It wouldn't stay in my body. I couldn't absorb it. 3 years out, I still have diminished smell, taste, appetite, and thirst, but I can override it now and I can force myself to eat. I went to many dispensaries. I went to some in Maine, I went to some in New Hampshire, and I asked the people who worked in the dispensary what strains help with appetite, because those are the people that know, the people that work there, the people that use this. You know, the big sort of joke about cannabis is you smoke a joint and then you sit on the couch and eat Doritos for the rest of the day. I looked forward to having munchies, as they're colloquially called. Never got munchies. I'm probably the only person in the world that didn't get munchies from cannabis. However, the diesels and the kushes, which are specific strains of cannabis that lean towards the indicas, they calmed my gut spasms down enough that I could eat food. It would stay in my body enough so that I could absorb the nutrition. So here is a clear eating disorder that was helped with cannabis. Since almost a year ago, I've gained 15 pounds back. And I'm probably the only person in the world, the only woman in the world who is thrilled about gaining 15 pounds. I believe it was Representative Leon, eating disorders are not currently covered, which is why we would need this bill. However, if you passed the previous bill, you would never need to hear another one of these bills again for a specific condition. And as far as the question for binging, that's where education comes in. If you've got a patient who's binging and they want cannabis for an eating disorder, that's probably not an appropriate patient or condition to prescribe the order for. However, along with binging usually comes some kind of anxiety or some kind of medical condition. So it might be, but this is where education for the providers is going to be very, very important and must be ongoing.
If you could please start wrapping up.
I'm all done. Thank
Okay,
you. I'm
great.
open for questions.
Thank you. Any questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So, even if 1278 were to pass, following up on some of the testimony on the previous bill, because there are providers that are maybe not current on all the literature, having this pass into law would still be benefit because it would explicitly state that this is there. Am I correct?
I believe you are correct, because if we pass this, it would go on to the form. And the physicians that are not familiar with cannabis are going to rely on the conditions that are outlined on that form. So it will give them an idea. But if you are familiar with cannabis, you're going to look at the form and you're going to say, okay, what I want is not listed on this form. I'm going to do it this way.
Thank you.
You're welcome. Thank you for the question.
Other questions? Seeing none, thank you.
Thank you.
Also signed up to speak is former Representative Jerry Knirk. This time, try for the 3 minutes, okay?
Yes, actually, this one timed out at 2 minutes, though I'm going to respond to some other things. So again, I don't have to reintroduce myself, except say for the record, Jerry Knirk, Chair of the Therapeutic Cannabis Medical Oversight Board. So indeed, excuse me, HB 1240 does seek to add a broad spectrum of eating disorders as a qualifying condition for the therapeutic use of cannabis. TCMOB voted 6-1 to not support this bill, as there's not enough evidence to take a position at this time. The board feels that there may be some merit and some people may benefit, but the literature does not really support its use. Here's the key thing. It's important to understand that eating disorders are not simply a lack of appetite. They're complex psychiatric disorders, often requiring multimodal long-term psychiatric therapy. And as was alluded to earlier, anorexia nervosa can be a fatal disorder. And one of the things about sort of the psychiatric part, for example, part of the disordered behavior of anorexia nervosa is a sense of empowerment that comes with resisting hunger and the temptation to eat. And so treating anorexia nervosa is far more complex than just stimulating appetite. Cannabis does have appetite stimulating effects, and that's primarily from the THC. And we do utilize that to treat patients with diseases or treatments such as chemotherapy, which can cause a loss of appetite. That's already in statute. But they're not psychiatric disorders. Those are suppression of appetite due to other things. And what I was looking up quickly here before coming up, and when you look at that "and" piece that we spoke about earlier, it's important to understand that there's a catch-all which is existing here, and that is at the end of the conditions is one or more injuries or conditions that has resulted in one or more qualifying symptoms under paragraph 2. In other words, if the person has an undefined condition that the provider certifies leads to one of the symptoms in list 2, and this is what's currently in statute, they can qualify, and in list 2 is cachexia and chemotherapy-induced anorexia and wasting syndrome. So, for example, the comments about loss of appetite secondary to long COVID, you could qualify by saying you have long COVID, and as a result, you have an appetite suppression. You could qualify under that. Now, this again is one of the areas, though, where provider knowledge is really a problem. Some providers will understand that. A lot of people have no clue. So there are some limited small studies on the use of therapeutic cannabis in anorexia nervosa, and one of those was quoted earlier, but that was one of them. There are a handful of studies, but the results have been mixed. There are also, some have shown a small amount of gain, like a kilogram of weight over the course of a month. That's not trivial, but it's that's all. And there are also some potential harms in using cannabis in eating disorders, including compensatory disorders of purging and binging. Also, it's important to understand that in the group that have anorexia nervosa, there are relatively high co-occurrence rates of substance use disorders. Now, as a result, that would suggest that the use of cannabis for an eating disorder may put patients at an increased risk of cannabis use disorder.
Please start wrapping up if you could.
Yes, I'm actually down to 2. Oh, actually, a comment earlier. A comment about the standalone aspect. The question was asked about symptoms and conditions. That will not apply because this is put in as a standalone condition, and therefore it does not fall into that rubric of needing condition and symptom. So basically, until better data is available, TCMOB does not support the use of cannabis to treat eating disorders. So we would urge going with ITL on this bill rather than passing it. Thank you. Any questions?
Any questions for Representative Kunert? Representative King, Seth King.
Thank you, Mr. Chair, and thank you, Doctor, for taking questions. You supported HB 1278, and we've also heard from other testifiers on this bill that if 1278 is passed, this bill becomes sort of moot because these conditions will be covered in 1278. How do you square the fact that you're for 1278 but not for this bill, even though this bill is sort of encompassed by 1278? Thank you.
Well, this would put it in not as a provider discretion thing, but simply as a statutory approved standalone condition. So therefore, the person who does not have much knowledge and says, I'm not really sure, but I'm looking at this and it says that it's okay to do it for anorexia nervosa, they would be able to do it if this passes. If this does not pass, but 1278 passes, they could not do that. But the person who says, I know a lot about this, I actually treat eating disorders, I'm a psychiatrist, I mean, that's a key thing. They would know a lot about this. And I think in your case, it might be worth a trial, then they could certify. So that adds that, again, higher level of provider discretion in the person. I mean, providers really need to have a certain element of responsibility that they know what they know and they know what they don't know. Again, would I, as a spine doc, prescribe this? No. For this disorder? No. But if I were a psychiatrist and I already treated that patient, I have an established relationship, and I think it might be worth a try, they could do that under 1278, but they could not do it as is currently.
Other questions? Seeing none. Thank you.
Okay, thank you very much.
Also signed up to speak is Dr. Joe Hannon. Good morning.
Good morning. Thank you, Mr. Chairman, members of the committee. My name is Joe Hannon, and I'm in support of this bill. I didn't speak on the previous bill, but since it's come up during testimony for this, I'd like to say that I do believe that things should be left at the discretion of people that are physicians and prescribers. The previous doctor was a spine surgeon. I was a foot and ankle surgeon. Neither of us would be generally prescribe something for anorexia nervosa or other related disorders. However, I do believe that even though when I was in the legislature, I voted on a lot of these things, I didn't feel, even as an elected representative, that it was my, I wouldn't say duty, but I didn't feel just because I was elected, I knew better. And just because I'm a doctor doesn't mean that I necessarily know better for everybody or other doctors and patients. I do think it should be left up to the individual physicians and prescribers and the potential patients. There are definitely studies out there that show that there is some evidence for lots of different conditions. Recently, the FDA, we heard about their rescheduling recommendation to be a Schedule 3. They've indicated there's credible scientific data to support to substantiate the use of marijuana in the treatment of pain, anorexia related to certain medical conditions, and nausea and vomiting, such as chemo-induced vomiting, with varying degrees of support and consistency of findings. So they did find evidence in their review. Also, they also said none of the evidence from the systematic reviews included in their analysis identified any safety concerns that would preclude the use of marijuana in the indications for which there exists some credible scientific support for its therapeutic benefit. So, as talk about, these are not people that are trying to necessarily have an agenda. These are FDA scientists who were told, what do you think? And this is what they came up with review of some of the literature. We've heard this quote, the founder of modern day toxicology, Swiss physician named Paracelsus, heard this quote yesterday, so I thought I'd bring it back up again today. The dose makes the poison. Everyone wants to know, well, how much do you give? What is an effective therapeutic dose? If a child has attention deficit disorder, they get Ritalin, say 10 milligrams 3 times a day. That may be the appropriate dose, and that'll calm that child down, even though it's a stimulant drug. If you give it to someone, an adult, they might get jittery or get anxious. So it depends on the patient, depends on the individual, and depends on the condition. If you give that same child, instead of 10, you give them 100 milligrams, you're going to notice a difference in their behavior, and it's not going to be calm. It would probably make anybody a little more agitated, to say the least, and anxious. So everything is potentially a poison. Everything, water, cannabis, you name the substance, it could probably kill you in the right dose. The fact is, we can't legislate what someone should take for attention deficit, for diabetes. If the legislature came in session and said, we're going to determine how much insulin you need to be a diabetic, and this is the chart that's been approved, and if you deviate from that, we'd kill a lot of people. So I think it's really important to leave this to the people that have gone to school, have gotten a DEA license, and these people write prescriptions for much stronger and more dangerous therapies than this. And I do believe, I agree with my colleague that, it's important the prescriber knows what they know and knows what they don't know. And I've never, when I was prescribing, I never looked at the law to say, oh, that's how I should do this. Not once, never looked it up. And I'm a bit of a wonk when it comes to policy. So,
thank you, Dr. Hannon.
Yeah, thank you.
Are you taking questions?
If you have any.
Any questions for Dr. Hannon? Seeing none. Thank you very much.
Thank you very much.
Okay, no one else has signed up to testify on House Bill 1240, so I am going to close the public hearing on House Bill 1240? Okay, may I please bring it forward? I'll let you state your name. I'm afraid I can't read it. Yep, my handwriting is much worse, but I'm more familiar with my own handwriting, so.
Thank you for letting me speak. I'm Representative Hope Damon, Sullivan District 8. I serve on Ed Committee, which is where I was, and Chairman Ladd reprimands us for for punctuation all the time. I'm here to support this bill. I spent my career as a dietitian. Probably 50% of my patients were people with eating disorders. Over the course of 40-something years in that work, I developed relationships with many patients from seeing them for an extended period of time, as you do with folks with eating disorders. And it became apparent in many cases that some folks considerably benefited from being able to use marijuana. It was not something that I, as a practitioner, ever initiated discussion about. Most of the time that I was in practice, medical marijuana wasn't legal in New Hampshire. But when it would come up in therapy and discussions, and a patient would describe how much more able they were to manage their eating disorder behaviors, it's pretty hard to ignore that benefit. I think these patients deserve to legally obtain what is helpful to them, used in a wise and thoughtful way, and I fully support this bill. As I was thinking about testifying on this, there were two particular patients that came to mind. One was an anorexic man. He was probably about 40, if memory serves me correctly. A very smart, very engaged person. I won't speak to his profession to be sure I respect confidentiality. But his capacity intellectually was very high. And he was dying. He was totally unable to feed himself adequately. He refused residential treatment. His parents tried to get guardianship of him. They did not succeed. It was really the stuff that keeps you awake at night, his treatment team. How were we going to help him? And another member of the team suggested that he try marijuana. And that man is alive today. I wish he was here to testify. And if you met him on the street, you would have no reason to surmise the ordeal that he went through to get well. It really was an extraordinary turnaround. I'm not suggesting that marijuana would do that for all people with eating disorders by any means, but it was really a life-saving measure for him. The other case that came to mind, particularly much less dramatic, but also very valuable, college student, young woman, binge eating disorder that became bulimia, so she was making herself sick many times a day. Beyond the medical issues of that, it was completely distracting from her well-being and her ability to be a capable college student. And similarly, obviously, lots of college students smoke marijuana or utilize it in some other way. Certainly. Suffice to say that in fact, was also a solution for her. So I thank you for hearing my remarks, and I strongly urge you to support this bill.
Thank you, Mr. Chairman, and thank you, Representative, for sneaking away from education to testify on this. I appreciate it. My question would be, we had another bill about allowing doctors to have more latitude in people 21 and older. Do you see this as necessary to go into the statute separately so that teenagers and others who are under that age have the ability to access this? Because I know a lot of teenagers do have serious life-threatening issues around anorexia.
Thank you for the excellent question, and the answer is yes. Specifically because, as you noted, there is such a high incidence of eating disorders in teens. And we know that with eating disorders, the sooner that you effectively treat it, the less likelihood that it becomes a lifetime condition. And if we are not as effective at early treatment, the long range is much harder to manage. And the fatality rate, anorexia is the psychiatric diagnosis with the highest fatality rate of any. Clearly, that's not what we want.
Thank you, Mr. Chair, and thank you. If I could have just two questions, because so with respect to the prior legislation, which I don't know if you were here for, and the 21-year age restriction.
I was not.
Yeah, so, but based on your experience as a dietitian, you would possibly recommend going back to amend that to allow people that are younger with maybe a second opinion to do that, so that you could intervene at an earlier period?
With the caveat that I have not read that legislation, so I want to be careful that I don't speak without being informed. What you're saying sounds to me like it makes sense, that a person who is 15 or 16 with a restrictive eating disorder or binge eating disorder could very much benefit. And I appreciate your suggestion of you'd have two providers weighing in on that. That makes sense.
And then my second question is not related to that, but the TCMOB did not come out in support of this because they talked about the literature is not comprehensive enough, or it's not, it really doesn't put a stake in the sand, per se. Is there anything, from your experience as a dietitian and your exposure to maybe literature that they may not have seen that may kind of counter that? Because you're talking specifically about anorexia and bulimia, which there is a certain amount of, what's the word? I'm not a doctor. Mental aspects to it. So are you aware of anything that might kind of counter those prior comments or add to that?
I have been retired for a year, retired in December 22. So I haven't kept up in this past year, something about being a rep on Education and Housing Committee. So I don't know if there's newer research. Prior to that, I would say it was limited and very small case populations. It's much more anecdotal and I would say talked about a lot in the eating disorder treatment community. I don't know who else you've heard testify of other professionals in eating disorders, but I can certainly reach out to some folks and ask them to provide some input to the committee, post-hearing. Eating disorders are not a topic that attract a substantial amount of research money. And so it has been a very long, slow process, as in my opinion, not only related to marijuana, just in general, how we understand those conditions.
Thank you.
Certainly. Thank you very much for your time. Y'all have a good day.
Thank you, Mr. Chairman, and committee members for having me back yet again. All right. So, as we've already already discussed with regards to medicinal cannabis, it does a good job of helping people with anxiety, and we know that because of how we already prescribe it for people suffering from PTSD, which is defined as an anxiety disorder caused by traumatic events, and we do prescribe other medications to handle anxiety, like Xanax, which is a benzodiazepine. And we know that benzodiazepines have been involved in 12,500 deaths in 2021 alone. And that's from the National Institutes of Health. the states of Delaware, Nevada, New Jersey, New Mexico, North Dakota, Oklahoma, and Pennsylvania all have anxiety as a qualifying condition in or similar legislation. And as I have already mentioned with some of the previous bills, I do genuinely think that cannabis as a treatment for anxiety is something that would be beneficial to a number of people. It's not going to be the solution for everyone, just like certain benzodiazepines will not necessarily be the solution for others. But there is there's significantly less risk of overdose, as we know, because nobody's overdosed on marijuana, and alone, I should say. And it can be beneficial for that regard alone. We know that there are different ways that and triggers that people have for anxiety, and it's important that we try to approach their issues from a patient level and let providers decide what is best for them. And providing this as a qualifying condition will give providers that opportunity to assess their patients as needed. Thank you.
Thank you, Mr. Chairman. Thanks for taking my question. This is actually an observation. In the state of New Hampshire, we don't prescribe cannabis. We certify people that individual has a condition, and then based on that, the Cannabis Commission okays or HHS okays it.
Yeah, I apologize for using the wrong terminology.
Person to answer this, but I'd like to know if there are any data on cannabis in people in adolescents, because the first bill that we have, would already address it for those who are 21 and older, and I'd like to know if there's any data in this younger age group for anxiety and cannabis.
Unfortunately, I'm not the person to really answer that, but as I've already stated, HB 1278 would have addressed the language of this bill.
For adults, yes.
Yes.
Thank you.
Sorry? But apparently she knew, apparently I'm talking loud enough. Representative Thomas, please come forward. No, she was just saying my microphone was off.
Oh, okay. All right.
Your microphone is on, so you're all set.
Thank you very much. Representative Wendy Thomas from the town of Merrimack. I used to work at a dispensary, a cannabis dispensary in New Hampshire, and the two major symptoms that were helped by cannabis were insomnia and anxiety. You cannot heal if you cannot sleep, and you cannot heal if you can't calm down. Now, not all anxiety is created equal. I am not an anxious person. However, I should qualify that. I was not an anxious person. A cancer diagnosis changed that. After 2 years of dealing with long COVID and all of the issues with that, I was diagnosed with cancer. The cancer concerns kicked off anxiety that revolved around my family, my kids, financial concerns, continued pain, relapse, and who will love my dog like me if I die. This is situational anxiety. It is not because of an event, although one could say that a cancer diagnosis is an event, but it's considered normal anxiety when I would talk to a physician about it. They would say, of course you're anxious about cancer, that's normal. And so based on that, I would not be qualified for the therapeutic cannabis program because of my, quote, normal anxiety over cancer. Cannabis, which I do use for this anxiety, allows me to back off the cliff. It allows me to stop thinking all of these horrible, catastrophic thoughts. And it allows the anxiety to be quiet enough to allow me to sleep. And as I said before, once you can start sleeping, you can start healing. So cannabis allows me to keep my anxiety at bay, and in therapeutic doses, I've heard from so many patients that have found that therapeutic cannabis also allows them to keep their anxiety at bay. I'll take any questions.
Thank you. Any questions for Representative Thomas? Seeing none, thank you very much. Also signed up to speak is former Representative Jerry Knirk.
So once again, Jerry Knirk, Chair of the Therapeutic Cannabis Medical Oversight Board. So yes, 1349 does seek to add generalized anxiety disorder to the list of conditions, and TCMAB voted 7-1 to support this bill as it is written. Anxiety disorder is a complicated disorder and often treated with an integrated program of multiple modalities, including counseling and cognitive behavioral therapy, exercise, and medications. But we know that medications do have some really significant side effects, and those were commented on earlier. Even the use of FDA-approved medications for anxiety generally are for short-term interventions and not good long-term interventions. Anecdotally, cannabis has a lot of evidence about relieving anxiety. It was commented earlier that a lot of patients do that. In our patient survey, anxiety was listed by many of our patients as the symptom for which they really use their therapeutic cannabis. Now, there have been some studies, and the studies have shown that particularly CBD alone can help with social anxiety. That's like public speaking. And that can help without changes in cognition or sedation, which is good. Low-dose THC, or a combination of low THC and CBD, can reduce anxiety without producing significant side effects. So that's pretty good. But we have to keep in mind that THC in higher doses can significantly worsen or actually de novo cause anxiety and increase the risk of cannabis use disorder. So cannabis does need to be used cautiously, preferably avoiding high THC. TCMAB feels that cannabis is acceptable to use to treat anxiety, especially as part of an integrated program. The standard approach that the ATC follows they already follow this if they're taking care of somebody with anxiety, and they follow this generally, but they would particularly do it here. They would keep the THC concentration low. They would start at an overall low dose and slowly titrate the dosage to get to the desired effect without the unwanted side effect of intoxication or euphoria. Now, another good reason to pass this bill is that currently, as commented earlier, many people treat their anxiety using cannabis which is purchased on the unregulated recreational cannabis market. The use of unregulated and unlabeled cannabis introduces the risk of a patient getting high THC cannabis, which, as I just commented, can actually cause more anxiety. So therefore, it'll be far safer for these people to be certified to use therapeutic cannabis in order to be able to access tested, labeled, contaminant-free cannabis under the guidance of an ATC. Basically, it's a harm reduction maneuver as well. So we do urge passage of 1349. I'll take any questions.
Thank you. Any questions? Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I just wondered if you could address the question that was asked earlier, because I know the Therapeutic Cannabis Board has a statement on cannabis use under the age of 25. Could you comment on that relative to this population?
Yeah, basically, here's the issue. Cannabis has 2 times in life that it is really problematic, and that is in the uterus and during adolescence. And the reason is we are having an enormous amount of change in our neurologic system, and cannabis interferes with the pruning of synaptic connections within the brain and developing new ones. As a result, use of cannabis during pregnancy or in adolescence can cause significant risks such as psychiatric disorders and psychosis and schizophrenia, learning disorders. It can interfere with the ability of people to concentrate and learn, and that can be long-lasting, not just during the time of use, because you're changing the neurologic system. So as a result, we battled for months about whether or not to still allow kids to use cannabis for epilepsy, and we only have 3 on the program. So, we really take this seriously, and we are very cautious about it because these risks are significant in kids, and we think that there may be an occasional child where it could be beneficial, like, for example, like uncontrolled seizure disorder still may benefit because that's a pretty problematic issue for the parent and the child both. But in general, to really limit its usage in kids.
Okay,
Is that answered well enough? You know as much about this as I do.
Other questions? Seeing none. Okay, thank you.
Thank you.
Also signed up to speak is Dr. Joe Hannon.
Long time no see. Thank you, Mr. Chairman. Joe Hannon again, and I'm in favor of House Bill 1349. There are many reasons why I think this needs to be approved. For one, this has been done in a few other states. Specifically, the most recent state was Pennsylvania in 2019, added this to the list. It created a lot of controversy in the media because, you know, the media takes things that happen in politics and science and makes headlines. But the people that looked at this, there was at the Drexel University, they have a medical cannabis research center. And in April of last year, it wasn't a published report, but they did their little review of the recent literature on and things about anxiety and cannabis use. Little background: they found that about 31% of the population has anxiety disorders, but less than half of them ever seek any treatment. One of the most common treatments that people do get is cannabis, usually at adult recreational or illicit sources to treat. The reasons why they looked at why people want to use cannabis instead of other pharmaceuticals or no treatment at all, which is what most people wind up doing. The stigma with anxiety disorders, the bureaucracy and the red tape of going through the insurance process, prior approval, getting treatment, all kinds of things. The costs, even with prescription drugs that are covered by insurance, it's often not very inexpensive, to say the least. The side effects of a lot of medications for anxiety and other psychiatric disorders, not everyone appreciates some of the side effects. I'm not going to list them all, but they can be more than annoying, to say the least, for some patients. As you heard previously, they looked at what doses, and we talked about this before, what doses are important. Lower doses have been shown in a lot of the research that they looked at to be effective and helpful for people with anxiety disorders. And CBD, the non-psychoactive part of the cannabinoid, is effective in all doses. However, we did hear that high doses can lead to anxiety and other problems. That doesn't mean that cannabis can't be used for anxiety. You need the right dose. And I think it's important these patients go through the medical system, and that's why I think it's imperative that this needs to go in, even if we don't do pass the everything bill or let the doctors decide kind of versions. This is important. It'll increase the numbers of patients that qualify, and it'll take them out of the shadows and actually get them into some form of treatment. Now, no drug by itself is a treatment for everything, or any kind of anxiety disorder. You don't always do one thing. For diabetics, we don't just say, here's your insulin, that's all you get. We talk about diet, we talk about nutrition, exercise for diabetes. The same thing with psychiatric disorders, especially anxiety. There are other things, other talk therapy that may be helpful also in conjunction with pharmaceuticals. But when we give someone Prozac, we don't say, here's your Prozac, good luck. I mean, some people do, but you need to have other modalities. But this is a great start. Last thing I'll leave with is, when I was doing surgeries, I would always prescribe one sleeping pill, just one, told the patient, take this tonight. And I almost never got called for complaints. The patient slept through the first night, and that's the worst night. If you ever had any procedure, minor procedure, usually the first night is the worst. You don't sleep, you're anxious. All pain and anxiety is worse at night. I give them one pill, and my anxiety greatly decreased. I was able to sleep. And I was able to enjoy my Saturdays, because I usually do these on Thursdays or Fridays. So I think it's very important, not just for the patient's anxiety and well-being, but also the physicians and the prescribers.
Okay, thank you. Any questions? Representative Leon.
Thank you, Mr. Chairman, and thank you, the Honorable Doctor, for coming and doing this. My question would be, are there people that self-medicate with alcohol for anxiety, and how does the harm of that compare to somebody going through the therapeutic program and having low-dose THC through an ATC?
Great question. I'm someone who's been in recovery. Alcohol was my favorite, I guess you could say. It's been quite a while, since '91. and I never took low dose alcohol. It didn't exist. I mean, it probably did. I just didn't see it in the stores. But you know, as far as alcohol being used to treat a disorder, I think in someone who's had a lot of experience in the recovery community and working with substance use for many years, I think it's safe to say that the drugs aren't always the problem. It's the drugs are a symptom. They're something that people self-prescribe to treat what they're feeling. And I think it's very important that just because something can be harmful doesn't mean that it also can't be helpful. You know, alcohol actually had medical prescriptions during alcohol prohibition. I was showed, the former head of enforcement for the commission years ago showed me a picture of one of his prescription pads or picture of a prescription for alcohol for the state of New Hampshire for medical purposes. I think Winston Churchill got one when he hurt his back in the United States during a car accident. He was hit by a driver in New York City, and he had to get a prescription for his medical condition. So he was able to drink while in the United States during Prohibition. I don't know if that was the ideal treatment at the time, alcohol, but it was, you know, better than going through the DTs. But I think it's very important to allow the people that know what they're doing to at least say this is an option and that it's okay. I think, like I first said, the stigma associated with a lot of mental conditions and psychiatric conditions and addiction and other substance use problems is one of the biggest reasons why people don't seek treatment and try to self-medicate. This kind of takes it out of the shadows. This says, hey, it is something that can be used, but we want you to talk to someone at a medical dispensary and try and get some knowledge and some education. If someone came in, I've never been a bud tender, I don't work in a cannabis shop, but if someone came in and said, what should I do? From my limited knowledge, I would say, from the studies at this place, I would say you want low dose. And they always say start small and, you know, start low and work your way up. I've visited some dispensaries and had tours, and I've never heard anyone say, you know, oh yeah, we tell people take the big one, big gummy bear, take the big joint. That's not what they talk about. Even in the recreational or adult use places, they tell you, you know, if you're new, start slow. And it's the same thing with medicine. If someone has a medical condition, you know, we don't usually give them the highest dose available for something. We try to give this. Everything in medicine is you want the lowest, you want the safest acceptable dose that produces the most benefits with the least amount of harmful side effects. And I think this is one of those things that we know from the limited studies, and I say limited because the federal prohibition has kept us from studying this to a really serious degree. But there are enough studies out there to show that it does work in low doses for many people. I'm not saying this works for everyone. I'm not saying this, if you have anxiety, you should go out and start, you know, using cannabis. But I think you should talk to your provider, talk to your PCP, your primary care doc, your mental health provider, and at least start the conversation. And if that conversation goes further, at least this would allow them the opportunity to treat themselves legally and, as far as society is concerned, legitimately. You know, we don't want to push this underground because that's why people get more addiction problems. I drank like a fish, and I was underage, so the law didn't stop me. And it didn't stop most people. It still doesn't stop people now. That we see, as no one in here thinks that prohibition has stopped people from smoking or using cannabis, or even during prohibition. Some people drank a little less during prohibition, but they drank more, and they drank more dangerous products. I think it's important to bring them into a safe environment and get something that is regulated and approved. And I'll stop talking because I know I can keep going.
Thank you.
You're
Other
welcome.
questions? Seeing no other questions, thank you very much.
You're welcome.
No one else has signed up to testify on 1349 FN, so I am going to close the public hearing on House Bill 1349 FN. At this time, we are going to take a brief recess, maybe 15 minutes. Yeah, Representative Shapiro, is that what you were asking?
Yep.
We're going to take about a 15-minute recess and then go into executive session for several noticed bills, beginning with 1520 FNA. So again, we'll reconvene around 11:35. Could I have the Republican members and substitute members come forward, please?
It's almost better if you don't.
Well, more, but.
Yeah, right?
Legislative stuff, I mean, actually, all the.
Yeah, you're sticking around. Leaving here for the Holy Rock.
Oh, so it's.
I continue at some of the other. Yeah.
Thanks a lot. Good to see you again.
For the second bill, were you supposed to follow the oh, yeah, the board, yes.
Yeah, it was really. For example, saying only a treating psychiatrist. Yes. Those occasions, treating
But we're gonna meet across the board.
So, 30 sure.
Yeah, Right.
Why are we letting
It's not in
why are we letting you're gonna do it, because you're not, no one, you're not gonna do it license. Okay, you can prescribe it, but only if the legislature tells you. Medicines that are all
not overregulated.
Oh, they found an interesting study. That's wasting its time.
Yeah.
And they didn't do that. They didn't give it a try. They never would have.
Well, they're using metformin for long COVID.
They've actually found that.
It'll be interesting to see.
Yes.
But also about anxiety, eating disorders. Research is eating disorders. Actually, he's known this for years. I think about it every stream. But they actually found the receptor that triggers eating response.
Oh boy.
That's cannabis related. So that's why they kind of have a feeling. Now they know why. It's really recent. They don't know why.
Yeah.
But they also looked at, we know that in Colorado states, certain things.
Actually, I'm at least right now.
Ice cream, sales, and but
Right.
you think that Colorado
No.
getting losing, they had a significant drop in general statewide for obesity rates. Their obesity rates dropped.
And so.
So how does that happen? They don't know. I mean, they just found out the receptor is easy. But the last thing is diabetes. They also found people who are users
that you have right now.
I don't know why yet. Studied it. But there's so much out there. You have to let them do it.
I mean, exactly. I mean, I wish Hope Dan would
Yeah,
a little
that
bit,
would-
'cause, you know, she is a wealth of knowledge on this. I mean, being a dietitian for as long as she has been. And, you know, I mean, you know, she mentioned a patient who, you know, was suffering from bulimia and then, been in and I think that right there, it's just like this person would have been excluded initially if we strike that out.
So many people are still so afraid. Right, exactly, that's what I'm gonna read. We will all have. We're like, oh, trying to look at Mondays and Fridays every day. But they'll stop. I mean, if it's uncomfortable, they'll stop. Right, right. Yeah. No one wants to do that. That's what you can't have. It's easier to get in and out. They do it because they are. Now they're still having to live in their process. Now, is this the whole way for that? But it was used to interpret it. I know. Everything I have to say is basically.
I mean, realistically, Delaware, they have depression as what they're qualifying symptoms, but yes, but there's a caveat. Yeah, it's only for high CBD products. So like, it's low THC, high CBD.
Yeah.
And
That's
so,
actually a good product for a lot of people.
yeah.
Well,
Yeah,
that's
exactly.
what if they say, oh, I see these on just right.
Like just to say, I can imagine CBD is really just say action. Pick one day for greater potential for, healthcare is not a right success, but people are going to get better results of most of it.
Right. Yeah.
I did use but
Yeah.
same people, like there are some people, like I know people in China, it's a fucking problem.
Well, some people are backwards. Sativa and indica are reversed.
Well, I mean, to be fair, there's debate over whether or not we should be using those classifications.
Well, sativa leaning, indica leaning, yeah. Right.
You switch the labels, they probably be gonna.
Yeah.
Yeah.
It's psychedelics and it's very important. And a lot of like you're anxious like doing
Right. Obviously, we all do.
Yeah, I mean, it's, I think that 1278, yeah, I mean, they seem to like 1278 because it's fast.
And that's why most people would go. Obviously, it wasn't necessarily you. But it's funny, the FDA. See the FDA review yet?
No, actually, I haven't seen that.
It's a long, I read most of these.
I skimmed over I'll be honest, I didn't read the whole thing. I just scroll left and look through for like anorexia, bulimia, eating disorders.
Sharon, have you seen this book? This is recommend. It's kind of weird. It's like a scrapbook, but it's actually very interesting. Maybe we can get that.
Hi, Wendy.
So are you gonna testify?
I will for Vita.
Okay, excellent.
Very close to this.
I think, yeah.
in second year, he's
All right, yeah. Even
Yes, exactly.
and I get that. The physician's always gonna be a little more cautious now. No, no, this is like I didn't get up there and say this is 4 times. I said it's been shown to help low dose. Low dose is a bad idea.
Everybody needs to know the process. I mean,
absolutely.
well, yeah, I mean, I've had a number of issues, but it was where.
Yeah, no, it's not.
I didn't know.
I mean, it's there, it's like a strap.
Yeah, no.
So I went up today and I
So bad.
and they suggested here.
I don't think I'm doing it.
Yeah, I mean, that's.
They found a provider. They're all heel fractures. So it's
From
it's not been
To be
great.
fair, they released it on like the 12th, so
Yeah.
it was not.
First they released a redacted. It was like 1 page.
The
12th
January.
Yeah.
Oh.
So
It's
it-
still on, it's pretty interesting, and,
Yeah.
It's out.
yeah,
yeah, if you could just, let's see the reference, I'd love to, because that's my.
That basically said, we've known it helps all along.
check my search history because I was looking at it the other night.
That'll do.
I guess it's just been
Right.
Yeah.
Yeah.
Oh, you did good. Yeah, you did a good job.
But
So are you?
yeah, and that's why it's
Peer review, but you know what? That's not before, trying to find the actual.
The actual-
Oh, yeah.
Maybe it's not.
no, it's on a Dropbox, but
Yeah. You're doing a good job.
hold on. No, I can do it a little bit differently. You can just scan the QR code.
Oh, excellent, okay.
So don't worry, we can still manage.
It wasn't as exciting as work, but then again, this is their.
Yeah.
It-
Oh, so you're not yet.
They're doing the exact same.
And then they're not exactly.
Yeah.
So then.
Maybe.
Yeah.
Players.
Layers.
Yeah, you need me to turn down my brightness?
Whoops. Once you actually hold it, and then it did pick up a moment, but also that.
There we go.
Okay, what it was the blurry.
Okay.
That would get too close.
Yeah, that happens sometimes. You on the Wi-Fi?
No, I'm not on the one. Oh, that's true. I'm not. Okay,
Yeah.
it's stuff about the data. I don't know why it isn't going to the Wi-Fi. It used to. I've lived here for a long time. But
That's why.
No, it's gotta be.
Your next bill.
Yes.
Okay, so we're.
Yeah.
usually you don't have to tell it to join up when you're already denied, but I have to tell it, yeah. But probably it's because I haven't used it for a long time.
Every 7 years,
Yeah, so I just think that's, okay, but, okay, it's actually trying to get me to.
Yeah, just hit accept all, and then underneath it'll say exit out of the fund rate.
Okay, oh, I said that, I couldn't see that, but it's blocked. So
Yeah, you have to.
well, I'll just go to that.
It's changed.
And then you're good to go.
And I've got the
Definitely
little sheet, and I
changed.
think it
Yes.
save
Yeah,
this
of
to
course,
my-
no problem.
To my favorites. Hey, it's nice to meet you. I saw your name, I'm like, who's this guy? So.
Yeah, well, the town,
Oh,
actually.
you're in, okay.
Yeah, so I'm.
I was late, so.
Oh, okay, yeah.
Late, I was married to us, I forgot to say four.
Yeah.
I'm used to kind of looking around and extract four, that was the district.
Yeah, well, no, that is the district, it's Stratford and Barrington, but
Oh, okay.
merchant's going to get yours. 30% chance it's going to be merchant. How are you doing? You know, but it's really not my clothing match. So I'm probably too attractive. I don't know what to do. You guys are in a yeah. Yeah. I think that's the area. Banquet time, real time. That's all they do. When you get down to the south, it's been pretty good. There's only not a block around the world. Yeah. Big. All the time. I try to. We need no, it's exhibition chips by deep. Yeah. Zodiac. Yeah. The last cruise of the season, because all of a sudden it gets very busy. When across the great passage, just like on the way over to all the great things. Yeah. Great 75.
Did you see all sorts of things?
The polar bears don't just stand. All in there. Whale and seal. Yeah. Great time. Down. Down sub. Down. 600. Yeah. Make sure that you came back up. Oh, you mean on? Oh, so.
Okay, I'd like to call us back. I'd like to reconvene the meeting. We are now in executive session on several bills. Under House rules, if the chairman and the ranking member of the committee are in agreement, bills that were heard today can also be considered in executive session. So the committee will be considering at this time House Bill 1278. Representative McLean, do you have a motion?
Thank you, Mr. Chair. I move ought to pass.
Okay, Representative McLean moves ought to pass on 1278. Do I have a second?
Second.
Okay, Representative Cannon seconds. Representative McLean, do you want to speak to your motion?
Well, I think we heard some, thank you, Mr. Chair. I think we heard some pretty compelling testimony today. I had some of the same questions that Representative Shapiro said, why do we need to kind of maintain the old system? Why not just kind of broom it? But I think the testimony really kind of underscored the value of maintaining the current system that we have to give some kind of clarity for those who are less familiar, while bringing in the second tier for those that have knowledge to allow for more discretion and hopefully expand access for those people who need it. So I thought it was a well-crafted bill, and there seemed to be a lot of consensus and support behind it. So I'd like to go with ought to pass.
Thank you. Representative Shapiro.
Yes, thank you, Mr. Chairman. I'm going to also vote in support of this. I think, judging from what we've heard over the years, when the therapeutic cannabis program was first conceived of and first became a law, it had to be done in the most conservative way possible to get people's support and to try it out and to see whether it was going to be a useful statute, a useful program. And I think over time, it seems to have proved its use, and people seem to be less, not everyone, but I think in general, people seem to be less concerned with it creating a disaster. And so we've seen, this is my third term, and each year we've seen other bills with new qualifying conditions. And I think patients are more familiar, medical people are more familiar, and it's time to give medical personnel more discretion in the way this program plays out. So I think this is a really good bill, and I think we should support it.
Okay, thank you. Representative Nagel.
Thank you. I'm supporting it also. We had a very entertaining and important discussion this in the Cannabis Commission. I just wanted to share one very brief story of somebody I think of every day. She was a woman dying of cancer who moved to New Hampshire, had therapeutic cannabis where she was coming from, and she didn't quite meet the criteria here, and so she couldn't get it here. And the woman was doing well where she came from and was suffering needlessly here. And I think bills like this are really important to help people like that and help people like me do what I think is right to help them at the end of life and whatever. But
Okay,
thanks.
thank you. Representative McKay.
As chairman of the marijuana advisory committee for 5 years, I strongly support this.
Okay, thank you. Anyone else? Any other comments?
Who,
Go
Mr.
ahead,
Chair,
Representative Merchant.
who seconded the,
Representative Cannon.
thank you.
Did you want to speak to your seconding?
Okay. Seeing no other comments, so we'll go, I'll ask the clerk to call the roll. Motion is ought to pass on House Bill 1278 FN.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Sellers,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Bogert,
Yes.
Representative Cannon,
Yes.
Representative Priest,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Macon Phillips,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Manos, or Manos,
Yes.
Representative Palmer,
Yes.
Representative Tellez,
Yes.
and Representative McDonald,
Yes,
20-0.
those are the kind we like. Yes, if there's no objection, we'll put that on the consent calendar. And Representative McLean, you can please write a report for me and get it in. Next up is House Bill 1520 FNA. I'll recognize Representative Cushman.
Thank you, Mr. Chairman. I would move that this bill be an expedient to legislate.
Is there a second to that motion?
I'll second that.
Okay, Representative Cushman, do you want to speak to your motion?
Sure. So there's several reasons. There were some logistical issues with the bill, some concerns about fraud and the ability to sell the vehicle, issues with, who owns the title and how maintenance is going to be dealt with. While I do very much sympathize with the struggles of obtaining and maintaining a vehicle, I don't believe that it is the state's place to step in and be the main foundation of a charitable organization. I think that should be done through private donations primarily. And I just see a lot of issues with actually putting this bill into place and enacting it. Thank you.
Okay, Representative Cushman, you want to speak to your second? Oh, I'm sorry, Representative Leon, I'm sorry.
Yes. Thank you, Mr. Chairman.
Somebody else.
I have to say that the work that the Good News Garage and other people like that do is absolutely amazing and is something that absolutely should be supported. The reason why I don't think that this is something that should be done through the government is you have some questions around the issue of the title. I recognize that in the past there hasn't been much of an issue with people selling cars, but quite frankly, the economic condition we're in is quickly approaching something we haven't seen in a long time, and people will be under pressures that they haven't been under economically. That could increase the chance that somebody may not keep the car as long, because at that point they may be choosing between making their rent payment, paying for something for food for their kids, and you're looking at different needs and different conflicts. The fact that the economy is worsening means that it's more important that people do step up to help people obtain reliable transportation. But if we were to make it so that the state held title in order to keep these cars from being sold too quickly, then if there's an accident, as the title holder, the state would then be liable. You have all of these different issues and all of these complexities that really only exist when you're doing this at the state level. And I want to encourage as many people as possible to donate to people like Good News Garage and others who are getting these cars roadworthy in their town. I know we have a used car dealership in Derry that does a lot of this, and they make sure that they find cars that are affordable and they help match them to people who need them. It's not through a charity, but just through something they do in their normal routine work of getting these roadworthy cars that can get people over the gap. I think that we should encourage that through voluntary help. And unfortunately, I think I see way too many problems bringing the state in that would create new complexities. So unfortunately, I feel that this needs to be ITL, but I do want to thank the sponsor for all of his really hard work on this, because I know that his intentions are pure and good. It's just a matter of the challenges of executing on the plan in the state.
Other comments? Representative Shapiro.
Yes, thank you. I will certainly vote against ITL, and I'll try to address some of the issues that have been brought up. I think we all have been through many, many discussions about to what degree federal benefits create dependence, and to what degree federal benefits create resilience, and, in the case of Medicaid, wellness, so that people can go on with their lives. But I think we're all in agreement that we want people to be self-sufficient and self-reliant, and not to be on federal benefits, not to be on TANF in this case, because I don't think that's any picnic for anybody. People who are on TANF are still impoverished. And so we all want people to move on with their lives and to be more successful. And as I mentioned in my original testimony, there's a working group within DHHS called the Benefits Cliff Effect Work Group that's been focusing on what are the systemic issues that keep people from going off of these benefits. And the one challenge that they came up with, and there are numerous challenges, I don't know if anybody looked at that on the DHHS website, there are many challenges they came up with, and they paired each challenge with a pilot project to see if they could make progress in helping people get off benefits. And the one thing that they didn't come up with that they didn't pair with a pilot project was transportation challenges. And we know that cars are very expensive. They become increasingly expensive. And without an automobile, it is very hard to get not only a job, but a good job, and then to be able to maintain that job. So that was my original intent in bringing this up. When we did have our hearing, there were some concerns about, would this be really a sustainable program? And with the worst case example being that someone gets a car and turns around and sells it. So one thing is that we heard from the people here from Good News Garage who ran this program in conjunction with the state. It was just anecdotal, there wasn't data, but that had not been an issue. After the original hearing, I had several discussions with Karen Hebert, who is the director of the Division of Economic Stability. So, within DHHS, TANF comes under economic stability. In other words, the intention of this program is to really create economic stability for people. It's not to have them be on TANF. And so given that, she explained to me how they would develop criteria for who gets these cars to try to ensure that they actually led to sustained self-sufficiency and self-reliance. And she talked about several things. But the importance of identifying who are the good candidates to get these cars, because they're really invested in the success of their clients. And success does not just mean getting off TANF. It means really moving towards a middle-class life where they can support their kids, because these are all families with kids. So they talked about some of the she was certainly not telling me specifically what the criteria, but some of the broad strokes of what the criteria would involve would be obviously people without cars, but also people who were work ready, who had participated within the New Hampshire Employment Program, Career Counseling Program, and taken courses in workforce development, education, employment readiness, and financial literacy. I think financial literacy was key because that not only leads to getting a job and a better job, but it also includes being able to manage your money so that you can maintain a car, because we all know you don't just get a car and that's it. You have to have money for maintenance, you have to have money for, hopefully you have money for insurance and for inspections and the like. And she said that they would also be targeting people who are not only ready to work, and all these people are already in a work program, so there's a work requirement, but they would be targeting people who are not just looking for the next job, but targeting people who've made advances in terms of developing a career. So through the career counseling program, there have been opportunities for people to get certified in various things so that they're not only on towards the next job, but they're on towards a career. And so these are some of the factors that would be taken into consideration in deciding who is eligible for getting one of these automobiles. And these are the factors that she felt would ensure, or you can't ensure, but decrease the likelihood that people are not going to sustain this effort towards independence through getting a car. So, obviously I think it's a great idea. So I'm going to vote against ITL.
Thank you. Representative Palmer.
Thank you, Mr. Chair. I also co-sponsored this bill, and I co-sponsored it for one main reason, which is that I donated a car to Good News Garage in Vermont. And the anecdote part of this is like almost a year later, I got a letter from the people who'd gotten the car saying how grateful they were and how much it had helped their lives and that they were going on exactly the result you'd want. And as far as the concern that it might be abused, this is a pilot program, so it's a perfect time just to do a pilot program, see if it works, see if there are problems. If the problems aren't fixable, then end the program, and if they're fixable, fix them. So I'm also going to vote against the ITL.
Thank you. Representative Merchant.
Thank you, Mr. Chair. I'm going to take a different tack on this. We have many people in our society, unfortunately, or fortunately, how you look at it, that are really dependent upon the state, whether it be a TANF program, whether it be SNAP programs and so forth, for various reasons. Many times not any fault of their own. I went back and looked at the documentation that was provided to us from the Department of Health and Human Services. And what it showed in there, that this was a bridge to get people off the state and on their own. So this, in a lot of ways, is helping the state do exactly what we're trying to do, is turning them into tax-paying citizens. So therefore, if you look in the Department of Health and Human Services back in 2017, every single person, the cash payments going to TANF was $1,500 less. Less, folks. So the state has a vested interest economically to support sort of this program. Because if we can find a way to get people from TANF, from SNAP, off those programs and fend for themselves, we're helping ourselves and helping the state treasury. Secondly, when you deal with the car ownership, which I don't disagree with, it's a concern. But that's why this is a pilot. If we do see evidence through the pilot that that behavior is in fact occurring, then you can deal with it by not having the pilot go forward. So I'll stress to you folks here, this is in the state's best economic benefit to support this program, to help people get off social programs that cost us money to become self-sufficient and become a tax-paying citizen of the state versus a consumer. Thank you.
Thank you. Other comments? Yes, Representative Seth King.
Thank you, Mr. Chair. I've got a few reasons outlined why I'll be voting in favor of ITL. Number one, gratitude versus entitlement. Representative Palmer here gave an example of how he had donated a car and somebody was extremely grateful for that. And I find that when there's voluntary charity involved, people are genuinely grateful and there is real gratitude. But when they get something from the government, they feel a sense of entitlement, like, well, I pay my taxes, so therefore I'm just getting something that I'm just getting a little bit of my tax money back. And I'm very much against the entitlement mentality. I don't want to increase that. And I think that, yes, there are going to be a lot of people that would take advantage of this and they would have the entitlement mentality, like they're owed a car instead of the gratitude of thank you somebody for voluntarily donating a car. Number two, this is just a little bit of socialism that I don't agree with. Number three, it was mentioned in public hearing that few are known to turn around and sell their cars, but how many are unknown? Because they don't keep track of all these cars. They don't keep track of very many. I mean, unless you know personally the people you're giving these cars to, how are you going to know if they turn around? So there could be a lot of cars that are turned around and sold they don't know of. Next, how many are simply abandoned due to lack of upkeep? How many people turn around and they've got great intentions, they want to keep that car, and then 3 months later, boom, there's a $3,000 maintenance bill that they can't afford, and then it just ends up sitting and rotting in their driveway, or they give it away, or who knows what happens. Next is the costs are actually much higher to fuel, insure, and maintain a vehicle than just getting a cheap vehicle. I recently a few years ago, I bought a truck for $6,000. Last year, I put $5,000 in just to keep it on the road. And that's just for this year. Every year, I'm spending more money on the truck than I do in the truck. So if somebody is incapable of getting, quite frankly, the cheaper part of keeping a vehicle, the cheapest part is getting the vehicle, unless you buy a brand new one. But if you get a used vehicle that only has a couple years of life left on anyways, the cheapest part is getting the vehicle. The most expensive part is the upkeep. If they're not capable of maintaining it, then you're just wasting money. So I'd like to give you one example, also a personal example. Many years ago, we had a female dog that had some puppies. We weren't a puppy mill, but happenstance. We had some puppies, and we always made sure that we sold our puppies for like $100 because we didn't want to give them to anybody who couldn't pay at least $100 for a puppy. It's like you're going to spend so much money on this animal throughout the course of its life. If you can't even afford $100 for a puppy, we're not giving you a puppy. And there were even times where people would come by and maybe they did have $100, but you could just tell this person is not capable of treating that puppy well. And we would reject some people from having a dog because you could just tell these people they can't even take care of themselves. They're not going to take care of a puppy. Now, let me ask you, when it comes to transportation, what if we didn't have cars? What if they were horses? Would you feel comfortable giving a majestic beast like a horse to somebody who's incapable of taking care of that horse? That would be animal cruelty. So when it comes to automobiles, okay, you're giving an automobile to somebody who has shown that they don't have the credit. I mean, why can't they go out and get a car on credit? So you're saying they have no credit. They don't have any family or friends that could give them a vehicle. They don't have a church. They don't have any community that's willing to give them a few $1,000s for a vehicle. But we, the taxpayers, are going to give that to them. And then what are they going to do with that vehicle? If they don't even have the capability of getting a few $1,000s to get the vehicle, they definitely don't have the ability to maintain the vehicle. So this whole program, I'm just against 100%. Thank you.
Thank you. Other comments? Representative Shapiro.
Yes, it's a choice that I make, that to believe that people who are low income, people who can't afford to have a car, people who've maybe had some trauma in their life that's led them to this situation, that they're motivated by the same things that I'm motivated by, and that they would be, given the right situation, they would behave in a way that's similar to me. And so I choose to not think of these people as those kinds of people and myself and us as other kinds of people, which is why I would do anything I could to help people get a step up and become self-sufficient, as I've been lucky to be in my life. And the other thing I would say is that I would just say to Representative King that perhaps if he had gotten his truck from Good News Garage, he would have had better luck with the truck because they check them out before they give them to people.
Thank you. Other comments? Representative Leon.
Thank you. Just really quickly, I guess the one thing that I want to say is that there are people that are very capable and there's people who are incapable. There's people who are honest. There are people who are dishonest. And that cuts across all income levels. Just because somebody has a lot of money doesn't mean that they'd be somebody who would be a good faith actor in a program like this. And just because somebody is lower income doesn't mean that they're automatically a good faith actor. I just want to assume that everybody in every category of people is just as flawed and just as good as any one of us. And so it's not a judgment on any of the individuals based on their income level. It's more a note about human nature and about the flaws that we all share. So, and I think that as a voluntary thing, there's more benefit. So that's the reason for my seconding in my motion. But I just wanted to clarify that so that we don't get on each other's toes a little bit too much. So thank you.
Representative Freitas. Oh, there you go.
I'm feeling confident about the safety net that's around this, that these are not just somebody getting a car. They're in the department's temporary assistance program. They're participating in the employment program. They have a valid license. They have an individualized work plan. So I think there are some safeguards that this program could be successful, and I am in favor of it. Thank you.
Thank you. Representative Tellez.
Thank you, Mr. Chairman. So for me, the issue
in addition to what's been stated already, is we live in a state where we don't have the kind of transportation infrastructure that other places have. And so it's a huge barrier for many people for many reasons and many domains. And being able to get to a job, right, for self-sufficiency purposes, if this is all that would really be a limiting factor, and there's a proven program that was successful here for 15 years, and right now we're the only state that isn't offering it. I actually donated my car to Good Nose Garage a few years ago. I think it was one of the older ones that probably just, they sold for parts. I feel like we heard a lot of really great information about how they make sure the cars are gonna be pretty good for a while, and a lot of information about how people are successful because of the guardrails that exist for a defined population. And I really don't think that making assumptions about the worst possible behavior is the way to make a decision about something that actually is proven and will be beneficial both to our interest as public funds, but also because we want to invest in the economic opportunity of our constituents so that they can be prosperous and so they can be thriving members. And let's remember, a lot of people end up on TANF because they had some kind of health thing, right? All sorts of things are reasons for why people end up on TANF. And the goal is that it be temporary. So I'll vote against ITL.
Thank you. Other questions? Other comments? Seeing none? At this point, I'll ask the clerk to call the roll. Motion is inexpedient to legislate on HB 1520 FNA.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Sellers,
Yes.
Representative McLean,
Yes.
Representative Seth King.
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Bogert,
Yes.
Representative Cannon,
No.
Representative Macon Phillips,
No.
Representative Shapiro,
No.
Representative Manos,
No.
Representative Palmer,
Representative Palmer.
No.
seem to have missed you.
Yeah, you
Up.
surely did.
Wait,
David Priest?
yeah. Representative Merchant is who I missed.
Maybe.
Sorry.
Yeah. No.
Representative Priest,
No.
Representative McKay,
No.
Representative Freitas,
No.
Representative Palmer,
No.
Representative Tejas,
No.
and Representative McDonald,
Yes.
10-10.
Okay, I sense another motion is forthcoming. Representative Shapiro?
I move ought to pass.
Second.
Motion's been made by Representative Shapiro and seconded by Representative Merchant for ought to pass. Do either one of you want to speak to your motions, or have we already said what we need? Everything been said?
I think we're all set.
Okay. When the clerk is ready, I'll ask him to call the roll. Motion is ought to pass on HB 1520 FNA.
Representative Leon,
No.
Representative Cushman,
No.
Representative Bill King, no. Representative Sellers,
No.
Representative McLean,
No.
Representative Seth King,
No.
Representative Mazur,
No.
Representative Nagel,
No.
Representative Bogert,
No.
Representative Cannon,
Yes.
Representative Priest,
Yes.
Representative McKay. Representative Freitas.
Yes.
Representative Macon Phillips.
Yes.
Representative Shapiro.
Yes.
Representative Merchant.
Yes.
Representative Manos.
Yes.
Representative Palmer.
Yes.
Representative Tejas.
Yes.
And Representative McDonald.
No.
10 to 10. No recommendation.
Okay, that'll go, obviously on the regular calendar with no other recommendation. And Representative Cushman and Representative Shapiro, you could get me those reports, that'd be great. Okay, moving on, House Bill 1593 FN.
Shapiro and who else was it?
Cushman, Representative Cushman. 1593 FN relative to funding for developmental services, community integration, Representative Nagel.
I make a motion, ITL.
Okay, Representative Representative Leon.
And I'll second that.
Okay, would you like to speak to your motion, Representative Nagel?
Reluctantly, yeah. This was, sometimes we go home at night after bills here and feel somewhat tortured. I suppose this is one of those. But I'm speaking as somebody who's worked with people with disabilities his entire life, somebody whose mother was disabled, somebody whose son has a developmental disability, someone who was actually recruited to come to New Hampshire by Easter Seals, and I wouldn't be here if it wasn't for Easter Seals, and somebody that volunteered with Special Olympics. So it's an issue that's very important to me in a lot of different ways. However, as I listened to the testimony, I was actually surprised that I came to oppose this bill because superficially I actually supported it. And the reason why was, as I was listening to people talk, I have one non-developmentally disabled child and one who is, and I know the terminology is not accurate, but that's what I use. And I was thinking about how important, out of school, out of work experiences were for both of them, and made them who they are today. They're both in their 30s now, but when I looked at it, all the services that they receive were provided by non-governmental sources, Boy Scouts, Best Buddies, things like that, and I paid for both able-bodied and non-able-bodied, and that's where I started to struggle with this, is what makes us need to support one versus the other, and then I thought we were starting to go down a slippery slope that really concerned me. I really think that nonprofits do an absolutely wonderful job providing a lot of these services already, and I was struggling with the concept that we would do this in this manner. With that said, as I've already stated, this is important. I know these experiences are extremely important, and relating to many of the comments that are made during the testimony, I totally accept and acknowledge the role of folks with all sorts of disabilities and non-disabilities as part of the fabric of our community. With that, that's my reasoning.
Representative Land, did you want to speak to your second?
Yes, thank you, Mr. Chairman. This is a really hard bill to look at and to see, especially because the whole, basically the whole landscape is shifting around this community right now. I absolutely feel for everybody impacted, but I'm also trying to figure out how any changes we do now are going to ripple through in the future. We've seen with other programs how what seems like just a short-term change in order to get over a challenge ends up creating yet another ripple that then follows through and then has other consequences later on. I struggled with the idea of maybe figuring out how we could just grant out the amount of money that previously were spent by the area agencies in order to say that, last year through this budget cycle, how much would have otherwise been covered under Medicaid in order to fund these services that previously were allowed and now are not. But that's a really complex thing to figure out how we would be able to draft that. And if there'd even be an appetite to say, here's some money that is simply a grant, that we're going to trust you that you're going to do this, because we don't want to we need to consider this under the larger scheme of how New Hampshire addresses the developmental disabilities community under the shifting landscape of what comes down from CMS. I'd feel a lot more comfortable, quite honestly, with almost an unrestricted grant to the area agencies to allow that to fill that gap this year. But I'm not sure that that's actually something that would be supported by everybody here. And in the absence of that, trying to figure out how to carve through this, trying to figure out if we'd be able to get to an idea of having these unrestricted grants simply to patch these holes right now through this transition would be palatable. My assumption was no, which is why I've seconded the ITL motion. But if people want to convince me that we want to do an amendment in order to do a block grant just to get over this hurdle, not tying it in and not binding, not setting any precedent for future legislation, then that would be something I'd be look into. But right now we're on shifting sands, and we're going to need to look at the program as a whole. That's part of why we have that subcommittee that's looking at this whole transition process as well, which I do need to notice and have us meet. But we just want to make sure that we can come through with a holistic approach to this, because I agree. At what point does this become something that is part of the government's responsibility, and when does it not? And that's a big discussion we need to have, especially with the developmentally disabilities community and people whose services are provided through local taxpayers when they're school age, but are part of the department when they are not school age. I think that we need to really sit down and figure out how to make sure that we best benefit this community over their entire lifespan instead of carving it out into these different programs. And I just don't think that the way that it's been presented to us is the best path forward, which is why I've seconded the ITL.
Representative Shapiro, you had your hand up. Was this the amendment, one you had an amendment on, or is that something else?
I didn't have my hand up yet, but I'd be glad to
Well,
speak.
you had your hand up initially, so I wasn't sure
Okay.
if this was the one.
So I did have an amendment written to just decrease the amount of money, but even before we got to this discussion, I decided that that was probably not the best way to go. And what I was hoping for today was that we would put off executing this bill for a couple of weeks, because there have been ongoing discussions with some people, with stakeholders and people in DHHS to solve some issues that I think are real issues in this bill. However, I don't think those discussions would address the concerns that the people who've spoken so far. So it's kind of an impasse here, and I'm trying to figure out what I think here. I will say what some of those discussions involved. They involved the total amount of money, which I think was not, probably pretty random when it was first written into the bill, and that that further discussions about the full amount of money that this would take to put in this fund, which would be an ongoing fund, which is what Representative Leon seems to be in disagreement with. So one concern that I thought we could address if we had more time was the amount of money. Also, I don't know if everyone got it, but the original bill didn't have a fiscal note, and then we got a fiscal note. So there's also a part-time position within DHHS that would result as would be a result of this program, and there needed to be further discussions about that, how that position would actually be funded. And also there's been talk about how to develop further guardrails in this bill in terms of what activities are legitimate activities for this program, and how it's decided who gets them funded, and is there a cap on the funding of individual a cap on, for the individual's amount of activities that are funded. So these are all like questions that I think if we had a few more weeks, we could improve the bill. But I'm not sure they would address the issues that we've been speaking about in here. So unless there's some appetite for continuing this exec session, I would vote in favor of the bill. I would vote ought to pass as is. It's not my preference, but that's what I would do.
Representative Leon.
Thank you, Mr. Chairman. I'd be willing to serve on a subcommittee to try and look at this and try and figure out if we can find a solution that satisfies everybody, or at least get closer to a solution that satisfies everybody. And I know I didn't make the initial motion, but if the chair wanted to put that together and then maybe move this to the 14th when we move the other early bills, which is the hard deadline since it is an early bill, I'd be willing to withdraw my second if that was the case.
Representative Nagel.
I totally agree with that. I think this is a really important issue, and I'm more than happy to withdraw my motion in favor of.
Okay, so you're withdrawing your motion?
What's that?
You moved ITL, so you're removing, you're
removing it.
withdrawing your motion?
Yes.
And Representative Leon is withdrawing her second. So at this point, we will continue this bill to February 14th, when we've already continued one bill to that point also, and we will have an executive session that day. So we won't we'll take no action on 1593 FN at this time. All right, moving on. HB 1612, Representative Leon.
Thank you, Mr. Chairman. I'd move ITL on this bill.
Okay, is there a second?
Second.
Representative Missouri, I think, beat Representative Merchant to it. Okay, do you want to speak to your motion, Representative Leon?
Yes, thank you, Mr. Chairman. I think that being aware of the status of our air and any radioactivity is highly crucial. But I think that with the existence of the C10 network and the ability that people are already doing this, I think that the more important way to do this would be to plug into the work that is already being done as opposed to trying to reinvent the wheel. I reached out to the department to see if they needed any authorization to participate in something like this. And I was referred back to the testimony from C10 that said that they're working to figure out how they would work with the state of New Hampshire in order to do this. Generally, we're not in the business of micromanaging departmental decisions, and I don't see any indications that they would necessarily need any legislative approval to work in a contract with them. As far as I believe most of the contracts, if they're large enough, go through the executive council because it is an executive agency. And so for that reason, I encourage the department to work with C10 or anybody else who is trying to get alerts on the radioactivity in that area so that we can know when there's a real response and know when there's just somebody who hit the wrong button. And as somebody who hit the wrong button and lost $80,000 when I was trading for my company, I recognize the harm in that. But I'd say the harm of everybody thinking there was a leak at Seabrook was far worse than my mistake on the trading floor. But I'd like us to just go ITL on this bill and encourage the department to work towards a collaboration and then come back to us with anything they need if it's needed.
Okay, Representative Missouri, did you want to speak to your second, or no? Okay. Anyone else want to speak? Representative Nagel and then Representative Shapiro.
I just have a quick comment. I mean, I was struck when the person was giving the testimony from C10, was giving a beautiful, eloquent testimony that was going on, and somebody asked her, well, what do you think about the bill? And she said, I think it's dead on arrival. And that totally swayed me. That was all I needed to hear.
Representative Shapiro.
Thank you, Mr. Chairman. First of all, I would love to hear the story about pushing the wrong button at some point. I just want to, I will vote for ITL. I think that it's not clear to me that there's not a problem that could be addressed through some changes, but likewise, it's not clear to me that there is a problem. And I think the fact that the sponsor of the bill wasn't able to come or didn't come to the hearing, and there was a letter by the person who did inspire this bill and they didn't come to the hearing, I think that we're left without any specificity about why the added monitoring is needed and what the added monitoring means. And the financial note was quite hefty. And so I don't know if there's a problem, but if there is a problem, it doesn't seem like this bill is the way to solve that problem.
Any other discussion? Seeing none? Okay, the motion is an expedient to legislate on HB 1612 FN. I'll ask the clerk to call the roll.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Sellers,
Yes.
Representative McLean,
Yes.
Representative Seth King.
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Bogert,
Yes.
Representative Cannon,
Yes.
Representative Priest, Yes. Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Macon Phillips,
I'm sorry, did you say Representative Hacken Phillips?
yes.
Is that me? Okay. I vote yes, thank you.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Manos,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20-0.
There's no objection. We'll put that on the consent calendar. And Representative Leon, I know you'll get me a report. Okay, last bill for our consideration under executive session is HB 1662 FN. I recognize Representative Leon.
Thank you, Mr. Chairman. I move that we adopt or vote ought to pass on amendment 0191H to House Bill 1662 FN.
Do we have a copy of that?
Yes, I just distributed that when I came back into the room. I know I had misplaced mine, so I'll give you all a moment to find where the bill that I gave you is. Here.
Oh, okay. So a second to the motion to adopt this amendment? Representative Cushman. She moves to second.
Yes.
Has everybody had a chance to read it? Okay.
so-
Does everybody have a copy of it?
Mm-hmm.
Okay.
If I may just start by introducing what the change is so that everybody can read it, I'll then pause. So the first sentence in section 8 is inserted was already in the bill. The addition of the line, this prohibition shall not restrict the ability of employees of said department from serving as foster parents for children for whom they had no involvement in the removal and placement process, was what I believe to be consistent with the discussion and clarification between the sponsor and the concerns of the department. So I'll let everybody read through that again and sort of signal to me when you're ready for us to move into the discussion. And I want to apologize for not distributing this earlier. I was waiting so much for the OLS to get it drafted that I forgot to mention that this was coming, and I apologize for this last minute. It was not intended as trying to pull anything off. I was just trying to get the amendment drafted, and it was my oversight to not mention it before we broke before.
Less of an issue than the $80,000 for sure. Mr. Chair?
Yes.
What was the second on this, please?
Representative Cushman.
Cushman, thank you.
Do we have any discussion on the amendment? Seeing none. Okay, are we ready for a vote? I'll ask the clerk to call the roll. The motion is ought to pass on amendment 2024-0191H to House Bills 1662 FN.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Sellers,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Bogert,
Yes.
Representative Cannon,
Yes.
Representative Priest,
Yes.
Representative McKay,
Yes.
Representative Freitas, Representative Macon Phillips,
Yes.
Representative Shapiro,
No.
Representative Merchant,
Yes.
Representative Manos,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
19-1.
Okay, the amendment passes. I don't know if, does this qualify for consent or?
no, we have to just ought to pass as amended.
Right. Okay. Okay,
Yeah, but-
Representative Cushman?
I would move ought to pass as amended as by the previous amendment.
Okay. Do I have a second?
I'll second.
Representative Leon seconds. Discussion.
Sure.
If I may.
Go ahead, Representative Leon, Representative Cushman.
So we'll recall from the committee, this is a pretty simple bill. Just to keep any conflict of interest out of these very important situations where we're placing kids, where we are involved in removing them from the home. We just want to make sure that there's no competing interests that would put the well-being of children and families secondary to a financial interest. Thank you.
Representative Leon.
Thank you, Mr. Chairman. I know that this bill has a very hefty fiscal note, but this fiscal note appears to be entirely related to the concern that the employees of the departments would be removed from consideration in foster care, and then the cost of filling the gap of those 10 employees, the 1.8% of foster families in the state being removed from that system. I believe that this amendment makes that clear, and this bill is a second committee bill that I'm pretty certain it's a second committee bill. And if not, we can request that it be referred to finance. But we can ask for, there's already been a request for a new fiscal analysis without including the change to the foster families. I don't see any fiscal language surrounding anything other than the removal of those employees from the foster family pool. And as such, I don't think that there's actually a fiscal impact. I'll check my notes to see if this is an early bill or not, but I think that's why we heard it so quickly. And with that, I'll yield to anybody else.
Representative Seth King.
Thank you, Mr. Chair. I support the ought to pass motion. I agree that we don't want the fox guarding the hen house. And one thing to consider is that if this were private ecosystem, this would potentially be considered a monopoly. The idea of the same company, I mean, we're not dealing with a company here, but if we had a company that was in the process of taking children from families and the same company involved in redistributing those children, that would probably be a monopoly that would be broken up by us. So if you don't support that sort of monopolistic private venture, then I would say you probably shouldn't support the idea that, in this case, the same people that are involved in the breaking up of families are also involved in the redistribution of children. It just seems like a conflict of interest, and we wouldn't tolerate it in other aspects of society. We probably shouldn't do it here either. Thank you.
This is an early bill, by the way, and will be going to finance should the House pass it. Representative Shapiro.
Yes, I'm adamantly opposed to this bill, and so I'll vote against OTPA. When the sponsor presented the bill, he said he was aware of no problems that he knew of, and that where this had actually occurred. So this seems to be a bill that is a solution looking for a problem. And secondly, when we're talking about children being removed from their families by DCYF in particular, they're not available to be adopted because they've been put in foster care or quotes removed from their family. But if they become eligible for adoption because the parents' rights have been terminated in court or voluntarily, they would be adopted directly through DCYF. They wouldn't be adopted through a licensed adoption and child placing agency. So I think the conflict that is alluded to with people being incentivized to take children and make them available for adoption, and then switching job roles and then adopting them out for some kind of profit is not really real. We're talking about something that's not really real. I think this is a slippery slope in terms of saying what kinds of jobs people can hold as well as their 9-to-5 job. And I think this is kind of a cynical view of humanity that we shouldn't support. That people are going to be incentivized to essentially steal people's children so they can make a few bucks by adopting them out to someone. I think that's a view of humanity that I don't want to support. I also think that this is just more big government of like making, I'm always amazed that there are 1,000 bills put forward in our legislature. And frequently people on both sides of the aisle, depending on what the bill is, say, we have too many laws. Well, I think this is one too many laws. So I'm going to vote against this.
Okay, thank you, Representative Leon.
Thank you, Mr. Chairman. There are many lines of work in which there are employment restrictions about what other jobs and what other secondary jobs would be a conflict with the current or main employment. As the state of New Hampshire is the employer for people at the Department of Health and Human Services and the Department of Children and Family Services. Because of that, the only way to change the terms, one of the ways to change the terms of employment is through changing the laws surrounding what is permissible for those employees. So this isn't growing government. This is putting a check on government. And I would be quite thankful to hear that this is not needed. But, we're always told, what do we need to do if it can save just one child? This is one of those areas where it just simply would remove people's concern that this is an issue. This is something that is limiting the state. And as such, I think that it is reasonable to move on to the next step of the process.
Representative Merchant and then Representative Seth King.
Thank you, Mr. Chair. First, I want to commend the author of the amendment for drafting the amendment. I think it's a step in the right direction, but unfortunately, it's not far enough. When I thought about the issue of someone trying to cook the books, if you will, to try to get a child away from their parents to put them up for adoption, what I have to realize is that can't be done without a court. So there's a court involved here, folks. That court is the one who decides to take parents' rights away, not the DCYF or anyone else. So even if they wanted to do this, it could not happen without the blessing of a court. So therefore, I think, to Representative Shapiro's point of view, we have a solution looking for a problem. There is no evidence in the state of New Hampshire that this actually exists. So why are we penalizing a group of employees and putting restrictions on their employment when A, there's been no evidence that we need it, and B, if there was, you still have to go to court. The judge still has to weigh in on it. You cannot take parents' rights away without the blessing of the court. So therefore, I will not support the bill as amended.
Thank you. Representative Seth King, and then
Thank-
Representative Cushman.
Thank you again, Mr. Chair. To address Representative Merchant's concerns that the court would be the arbiter here, that's true, but let's not forget that the information that the court gets is from employees of DCYF, and if their judgment is tainted by ulterior motives, then the court is going to get bad information from DCYF. So the court may help prevent some things like that, and that's nice. But the problem is lots of times when it comes to children, it's a he said, she said thing, and it's just extremely powerful, the amount of power the DCYF employees have. And then also I wanted to just piggyback a little bit on Representative Leon said. There are a lot of positions when you work for the government, you're not allowed to simultaneously work for those you regulate. You know, we wouldn't want people that work for the DoD to also work for Raytheon. We wouldn't want the people that work for the SEC to also work for Goldman Sachs. Matter of fact, there's a lot of talk on both sides of the aisle, not just Republicans, both sides of the aisle, that we're even starting to say, hey, you know what? Not only can you not work simultaneously, you shouldn't be allowed to work 10 years after. If you leave the SEC, you don't get to work for Goldman Sachs because there could be pro quid, quote, I always mess up the Latin, quid pro quo going on where, you are the regulator, but behind the scenes, you're going to regulate in favor of the big corporations, and then you're going to turn around and work for them after you quit. I mean, that does happen all of the time, and both sides of the aisle are not happy about that. So, yes, it is a cynical view of humanity, and I'm a cynic. Okay, people are that corrupt. So that's why I'm supporting this bill. Thank you.
Representative Cushman.
Thank you, Mr. Chairman. So I have been experiencing a crash course in DCYF and family court over the last several months. I watched all of the hearings on the special committee on the family court division of circuit court. And there were many meetings, and much of the testimony was about the fact that DCYF and the family courts do not operate in a fair or non-arbitrary manner. There are many reasons for that. I won't get into all the details, but the judges have full discretion to accept evidence or not. So if you bring affidavits from all your friends that you're a good mom, and DCYF brings a finding of abuse, the judge will throw out your affidavits or not even look at them, and they will take DCYF's orders as sacrosanct and rubber stamp it. And it's not all the judges, and some of it's incompetence, but some of it, there's really a lot of evidence that there's a lot of very deep corruption. And I'm treading carefully, but just the assumption that everybody is good and will do the right thing is it's understandable why we'd want to assume that. But as I grow older, I find more and more that it can be the other way, especially when you have people in positions of authority and you give them power. Power corrupts.
Representative Merchant, and then Representative Leon.
Thank you, Mr. Chair. If the issue is the courts, and the courts being not true neutral arbitrators, is that not where we need to go versus doing something of this nature and talk about where the problem is versus trying to solve something without getting to the root problem? And that's what I'm trying to get to. So therefore, again, back to you comment, if in fact the courts are not being neutral, the courts are taking one-sided in leaning one way or the other, I think the appropriate place to go in a legislative process is dealing with the issue, which is the courts, not here.
Representative Cushman.
Thank you, Mr. Chairman. I'm assuming the question was directed toward me. I agree, we do need, definitely, there's like massive overhaul that needs to take place in the courts, but there's also massive overhaul that needs to take place within DCYF processes as well. And this bill is the first step, the first, place that we've unearthed an issue, and that we want to get ahead of and make sure that it can happen. Thank you.
Representative Leon.
Thank you, Mr. Chairman. Right now, the standards to remove a child from the home are what they are, but there is a bill that is active in the other body that would include something like somebody disagreeing with the level of cleanliness in your house. I'm sorry, but I have 3 boys. The whole saying is your house will be clean when the kids leave the house. And that's the potential subjectivity about the state of somebody's housekeeping or disagreeing with the education that's provided to other children. The bill that's pending in the other body could make things so much more subjective within the department that actually would give us more reasons why it's more important to, as employers, set this condition of employment. Hopefully that'll be addressed, and if it comes our way, we'll deal with it as well. But I just wanted to raise people's awareness that this may be moving into a more subjective way. So if we do end up enabling to have more subjective choices in which children are removed, in wake of the absolute horrors that we witnessed in recent years, that we also have this safeguard too, that we don't potentially experience some of the horrors within the departments that have happened in other states. Now, I'd love to think the best of my fellow Granite Staters, but sometimes we need to figure out where to draw that line.
Other discussion. Representative Haken Phillips.
Thank you, Mr. Chair. I just wanted to take a moment to address some allegations that were made in testimony just now from our own members, and just to remind this body that I am a member of the New Hampshire Bar Association. I am a licensed and practicing attorney in this state, and that the allegations that I just heard of without any factual evidence that our New Hampshire court system, or perhaps our family court system, by a non-practicing, non-licensed layperson who is also a member of our general court, I find to be very disturbing. I would just like to make mention of the honorable work that our court system staff and judges do for our state, and that they are held to very high standards of constitutional practice and professional practice, codes of conduct that I believe are held here in our state, and that I would just like to say the substance of this bill does not seem to address the concerns that we've just heard. It sounds like there's a procedural evidentiary complaint that someone may have with the court system, but I'll remind this body that our House did in fact just vote on that matter this month and shot it down. So this particular concern does not get addressed by the language of this bill. And I would just like to say that, it's our duty here in the Health and Human Services Committee, which I am substituting on today, to try to work on these healthcare issues. And I don't believe that those allegations appropriately align with the substance of this bill, and for that reason, I will be voting against it.
Representative Palmer.
So my only additional point would be that normally a conflict of interest kind of thing would be dealt with by the company or the agency. So I would much rather see this addressed by HHS as an internal policy rather than adding more legislation that takes more legislation to change if it needs to be changed.
Representative McLean.
Thank you, Mr. Chair. The only thing I would say is that we are seeing in this state, in this country, a real decline in the trust of our institutions in general. And in this state in particular, there is a huge amount of distrust in the family court. And it's not enough that the system be fair and the system be just. It may very well be. But in addition to that, there also has to be the perception that the system is fair and just. And so I think that this bill goes a long way towards accomplishing that. This is about also reestablishing trust in the systems. And so I will be supporting the bill.
Representative Palmer?
And I guess what I would say is that part of the reason that trust is slipping is because of the kinds of things we do. And I think we need to be very careful that we don't accelerate anything beyond appropriate skepticism of what government is doing. Because I think we certainly can make it worse along with the media.
Representative Shapiro, then Representative Seth King, then Representative Tellez, I think it was.
Yes, as I'm hesitant to say this, but as someone who's actually worked as a protective services social worker, briefly and earlier in my career, and not in New Hampshire, in Vermont, but who's actually had that job of working with families to assess abuse and neglect, and then to get families the help that they need to keep their kids. And in the worst of circumstances, having to remove kids at times. Having done that job briefly, also having worked with adolescents for a great deal of my career, and therefore been in court a great deal with kids who were involved in that system. And even having participated in one case in being a witness in a termination of parental rights case, which was incredibly painful. As someone who's done those things, I would be the first one to say that these systems are imperfect, and sometimes there are really bad things that happen. But in my experience, and it's not current experience in New Hampshire, in my experience, most of the time, people do the best that they can and they work pretty well. And I guess I would just like to kind of piggyback on what Representative Palmer said, is that in that, number one, we should be very careful about not amplifying that distrust through bills that we bring, and speeches that we make, and bills that we pass. But also, as people know, we have had a shortage of DCYF workers in this state, which have led to some unfortunate situations in our protective services ecosystem in New Hampshire. And, at various times, there have been efforts to hire more people. And it's difficult to hire people to do an incredibly difficult job. And I think bills like this will be seen as kind of disrespecting people in those jobs, assuming the worst about people in those jobs, and make it more difficult to get people to want to do that kind of work. And so for all those reasons, once again, I will say that I will vote against this. And I think this is this will be really unfortunate if we pass this bill.
Representative Seth King.
Thank you again, Mr. Chair. I just want to piggyback on what Representative McLean said. I really liked what he had to say. It's not just about the trust, it's also about being seen as trustful. And when it comes to different departments, there are very few departments that I think people get as emotional about as this one. I mean, people might be upset about a certain hunting rule with Fish and Game or something, but when it comes to losing your children, there's nothing that's going to make somebody go crazy more than that, And if they think that there's anything about the system that is corrupt or rigged against them, it just makes the matter that much worse. And to respond to what Representative Palmer said. He said, well, we don't want to do anything that could upset people. And a lot of what we do to upset people is in the legislature, and I agree. But I really don't think there's going to be anybody at home that is going to be bummed out about this bill passing. I think there are people, though, that are seriously unhappy with the way DCYF is run today and certain things about it. But I don't think anybody at home, I don't think the average person is going to be bummed that DCYF employees cannot simultaneously work for child adoption services. Nobody's thinking that. But there are a lot of people that would not be happy about the reverse. So that's why I favor this bill. Thank you.
Representative Tellez, did you have your hand up?
Yeah, I just wanted to say that, I am freshman, but this makes me wonder about, does this mean now we're going to be facing all sorts of other bills for specific laws to be put in place for specific types of situations where, as Representative Palmer pointed out, this could be handled at a rule level, other kind of policy level, not necessarily requiring legislation. And again, fundamentally, we heard no evidence that this actually is a real, that there's any kind of problem. And I also doubt that there's anyone really, spending time thinking about it, because we've had no evidence that this actually is a real problem.
Thank you. Representative Leon.
Thank you, Mr. Chairman. I've noticed tensions rise a lot during this discussion, and I just want to remind everybody about Article 30 of our Constitution. Unfortunately, another heated discussion in a previous year in the legislature led to somebody having legal action taken against them for defamation. It's currently going through the court process, so I can't speak to it too much. So I do want to remind us of the Constitution, which states, "The freedom of deliberation, speech, and debate in either house of the legislature is so essential to the rights of the people that it cannot be the foundation of any action, complaint, or prosecution in any other court or place whatsoever." So I just want to remind everybody of that, and also realize we're all just trying to look out for the best interests of kids and families. We just may disagree on how to do this, but let's not let our emotions on that override how we're acting today. So thank you.
Other discussion? I'm seeing none, and certainly I think we've covered it pretty thoroughly. I'll ask the clerks to call the roll at this time. The motion is ought to pass as amended on House Bill 1662 FN.
Before I begin, I have an apology for Representative Haken Phillips.
Sorry, it's Hacken Phillips.
Hacken?
Hacken like a
Well,
computer hack.
Even further apologies.
Me too.
Hacken. This looked like an M. I'm sorry. Representative Leon.
Yes.
Representative Cushman.
Yes.
Representative Bill King, yes. Representative Sellers.
Yes.
Representative McLean.
Yes.
Representative Seth King.
Yes.
Representative Mazur.
Yes.
Representative Nagel.
Yes.
Representative Bogert.
Yes.
Representative Cannon.
No.
Representative Priest.
No.
Representative McKay.
No.
Representative Freitas.
No.
Representative Hacken Phillips.
No.
Representative Shapiro.
No.
Representative Merchant.
No.
Representative Manos.
No.
Representative Palmer.
No.
Representative Tellez.
No.
Representative McDonald.
Yes.
10 to 10.
Okay, no recommendation. I sense another motion is forthcoming. Is there another motion forthcoming? Representative Cannon.
ITL.
Motion's been made for ITL. Is there a second?
Second.
Representative Merchant seconds. Any discussion, and I think we've covered it, but any discussion? Seeing none, when the clerk is ready, I'll ask him to call the roll. Motion is inexpedient to legislate on House Bill 1662 FN.
Representative Leon,
No.
Representative Cushman,
No.
Representative Bill King, no. Representative Seller,
No.
Representative McLean,
No.
Representative Seth King,
No.
Representative Mazur,
No.
Representative Nagel,
No.
Representative Bogert,
No.
Representative Cannon,
Yes.
Representative Priest,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Hacken Phillips,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Manos,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
No.
10 to 10.
Okay, these will go to, obviously, no recommendation to the calendar. Representative Cannon, you're doing the report on ITL? Okay. Okay, that concludes all of the business for the executive session this afternoon. So I am going to adjourn the executive session. The hour is currently 1:05. My recommendation of the committee, unless there's objection, would be people take lunch at their leisure during the course of the afternoon, rather than delay proceedings, considerably. Any opposition to that idea? Oh, okay. All right, do we have?
Can we do 5 minutes just to hit the bathroom?
Sure, yeah, we'll take a quick break, 5, maybe 10 minutes. We'll take it, what's that? 7 minutes?
Start at 1:15.
1:15 is fine, sure.
When do we need these reports in?
really just, we're going through the motion. That's exactly.
Yeah, all right.
If you sit there, you'll be on the camera whenever anybody testifies, which
I'm probably just gonna 1633, which has a 4-ounce possession limit. The purpose of this bill would be to change the medical purchase limit from 2 ounces to 4 ounces. That's because it doesn't really make a whole lot of sense for patients to be able to go into a medical dispensary and purchase 2 ounces of cannabis when they could go to a recreational facility and purchase 4. So there are also a number of other reasons why we should allow patients to purchase 4 ounces, because patients may be in need of different dosages. So they could use more than and require them to go to the dispensary more frequently. We only have 7 dispensaries across the entire state, and people with mobility problems or people with limited transportation have sometimes difficulty getting to their dispensary that they use to be able to purchase their medicinal cannabis. So if you'd help me support this bill and kind of fix a potential upcoming problem that we're going to see in our legislation, that'd be great. Thank you.
Thank you. Any questions? Representative Leon.
Thank you, Mr. Chairman, and thank you for bringing this forward. I think that it's great to look prospectively about what's happening in the larger environment. My question is actually in section 2. That's in subparagraph 7 there. It increases the amount of obtaining more than 2 ounces, changing it to 4 of cannabis in any 10-day period in violation of the RSAs. My question would be if I guess I also don't want to doom this in the other body, but if it might make sense that if there is somebody who has a higher need, that those that are writing that certification may want to allow more within that time period. And perhaps it's better to defer that question to somebody else, but I just wanted to make sure that we're not limiting people.
Yeah, I mean, that would make a lot of sense, and I would definitely be open to some changes there.
Thank you.
Other questions? Seeing none, thank you.
Thank you.
Also signed up to speak is Representative Wendy Thomas.
Hi, everyone. Representative Wendy Thomas, Town of Merrimack. I come before you in support of this bill. There are several reasons to support it, besides the fact that it would match the legal recreational bills that are being proposed. One is that cannabis works differently for each person. And so we use different strains, we use different amounts. I recently went up to Maine to talk to a cannabis grower who grows for recreation as well as creates therapeutic products. And she was telling me of a cancer patient that uses 1,200 milligrams a day of cannabis, and they're functioning. That's a ton. If I took 1,200, I would be out like a light. But that's for cancer, and it was actually for brain cancer. I've also talked to people that have worked in dispensaries that their average dose, their daily dose is 100 milligrams at a time. And again, if I took something like that, I would be out. As a patient, my comfort dose is between 5 and 10 milligrams at a time. That's what I take. I don't need a lot, but thankfully I don't need a lot. There's a lot of people that just metabolize it differently and they need a lot. I will tell you that one of the products that I use now is a very concentrated product with cannabis, and it is actually 50% THC in this product. But when I use it, it's an oil, and I only use a tiny, tiny amount, and it's compared to a grain of rice. It's about 10 milligrams for that dosage for me to take that product. I'm taking it for cancer, I'm taking it for pain, but if I wanted to make that product on my own, and there are ways to make it, I would need a lot of cannabis. Keeping patients to 2 ounces, for me, that's fine. 2 ounces, I don't think I've ever in my lifetime hit the maximum level of 2 ounces. However, I know many, many cancer patients, many, many patients with terminal illnesses that need a lot more. They burn through the 2 ounce, I didn't mean to say that. They use the 2 ounces that they're allowed to get, and then they augment it by buying stuff on the street because they just don't have enough. And lastly, transportation is a big problem. As the previous speaker mentioned, we have 7 dispensaries in the state of New Hampshire. That means that some people have to travel a long way to get to these dispensaries. If we increased the amount to match what we're talking about recreationally, these people may not have to do that travel every 10 days. I'm open for any questions if you'd like.
Are there any questions for Representative Thomas? Okay, seeing none. Thank you. I'm going to skip out for lunch and turn the chair over to Vice Chairman Leon for a while. So, Representative Leon.
Thank you. And next, we'd like to call Matt Simon from Greenleaf Cannabis. Thank you.
Thank you, Madam Chair. Again, for the record, it's Matt Simon. I work for Granite Leaf Cannabis.
Sorry.
No problem at all. If that name is unfamiliar to folks, last time I was in this committee, we had a different company name. We changed our name in September, so we're still the same New Hampshire-focused nonprofit with the 2 dispensaries, but we are Granite Leaf Cannabis. And the previous speakers have made most of the points I intended to make. I think the main reason this bill came up is because the House, both last year and the year before, passed 2 totally different adult use legalization bills, but they had one thing in common. They both had a 4-ounce possession limit, and if either of them had passed into law, we would have had a 4-ounce possession limit for adults 21 and older, but a 2-ounce possession limit for registered patients, and that didn't make sense. So this bill would put the therapeutic program on the same footing with adults who would become legal consumers if the other bill were to pass. As others have mentioned, we do have only 7 dispensaries in the state, so a lot of patients do have a drive of more than an hour. And if they're purchasing cannabis every 10 days, not a math whiz, but that's like 36 and a half trips to the dispensary in a year. And for a lot of people, that's far from ideal. So this would make it so that people could make fewer trips and stock up a little more when they do it. So please support this bill. I'd be happy to take any questions.
Are there any questions? I actually have one for you. Would you advise people that are involved in those adult use bills to perhaps change the language so that the therapeutic cannabis is in addition to whatever the limit for other adult use would be? So that you're not saying that. I guess my question is, do you want to basically block somebody off from that other access, or would it make more sense for the therapeutic cannabis to be on top of the adult use limits?
Thank you for the question. I don't think I have an answer on that. I think that would be a policy choice for the general court. My biggest concern is that we not create a standard for adult use that is twice as high as the standard for patients. So that makes sense.
I recognize that, and thank you for noticing the oversight in our legislation. Thank you. With that, I don't see any more questions.
Cool.
Thank you for your testimony.
Thank you.
Looks like we're supposed to get back to you. And with that, I will call Jim Riddle. Thank you. And so we're trying to keep testimony to 3 minutes. This buzzer will go off, and if you keep going beyond that, we'll remind you. So just to let everyone know this afternoon. So
Thank you, Madam Chair, members of the committee. My name is Jim Riddle, Hillsborough. I have a New Hampshire medical cannabis card. I also hold a USDA hemp grower license. And I'm on the advisory board of the New Hampshire Cannabis Association. I'm here to speak on my own behalf. And I'm here to support HB 1350 and to increase that possession limit from 2 to 4 ounce to be consistent with the adult use market that's being proposed. But I do want to just challenge the whole notion of a possession limit. I mean, I can go to the state liquor store and fill my car with wine or whiskey. I can throw in some bottles of Everclear, even pure grain alcohol. There's absolutely no possession limits on alcohol, and we know it kills you. You know it's bad for you, but yet a person can buy, transport, consume, have in storage as much alcohol as they possibly could want. So it's like, I think it's a transition, but it does seem to me like a bit of a nanny state of looking over my shoulder to control, to make sure that I don't have too much in my possession. And, there just haven't been problems with medical card holders buying up and then reselling. I mean, it just has not been a problem in all the years that the program has existed. So I support the bill, but I do just have a problem in general. We don't limit other medications. It's placing limits on people's healthcare choices and their preferred treatments. But thank you.
Thank you. Are there any questions from the committee? Seeing none, thank you very much for the testimony. Sorry, I'm doing a bad job handing these off. Next, I will call the Honorable Jerry Knirk to the microphone.
Thank you very much, Madam Chair. And my testimony I distributed, everybody has it along with the bill, a couple beyond this too. Once again, for the record, Jerry Knirk, Chair of the Therapeutic Cannabis Medical Oversight Board. And the board voted unanimously to support HB 1350. The discussion, some of this will be slightly redundant, but I want to tell you what we said at our meeting, that specifically it will help our patients because edibles that are sold at ATCs are expensive. So in order to save money, many of our patients make their own batches of edibles. They'll get the plant, they'll make an edible that they can then use over many months. But most of the recipes take a kind of large amount of cannabis to make the batches, so the 2-ounce limit makes that difficult. And that's particularly true for oncology patients who may be using higher doses. And you could say, well, they just go back to ATC and buy another couple ounces 10 days later. Well, that puts them in violation of the possession limit. That's why how often you can buy would need to be changed, and how much you can buy every 10 days. I mean, do we have to be changed in order to still make this work? One of the main things, though, again, is that distance. If you live in a rural area, trip to an ATC can be a very long issue. And this is particularly difficult for older patients who don't like driving long distances, particularly maybe at night or whatever, patients in pain, oncology patients. And I always like to think through analogies. I live about an hour and a half round trip from my pharmacy. When I go refill my prescription for lisinopril for my hypertension, I get a 3-month supply. I don't have to go back every 10 days. So I think the 10-day part is already a little bit of a nuisance. But allowing people to buy 4 ounces every 10 days might mean they only have to go once a month or something rather than having to go more frequently. So it's really going to make a big difference. And we also recognize the issue that the recreational cannabis bills have talked about 4 ounces, but we've also talked about recreational cannabis for a decade or more, and it hasn't passed yet. So even if that doesn't pass, this still is a good thing to do. So we urge you to pass this bill. It'll save money for patients. It'll also save a lot of time, particularly those who live a long ways from an ATC, and I'll be glad to take questions.
Thank you. Are there any questions from the committee? Representative Palmer?
This may be a little bit of a silly question, but we're talking about 2 and 4 ounce limits, but then most doses are in grams. And how many people translate all of that well? And how does that work? I mean, you go to the dispensary and you get 2 ounces or 4 ounces, and then you make gram doses. I mean, maybe people who do this all the time.
Yeah, I think. I don't have a card. I don't use this stuff, so I can't answer exactly all those details. But I'm pretty sure that most people would have a recipe. It would say, use 2 ounces or whatever of something which contains perhaps 30% THC or 10% THC or something like that. So you'd have an idea what you're going to do. Because you're right, if you make a batch with 1 ounce of cannabis and it's a 10% THC, it's going to be a lot different than if it's a 50% THC. Because the strains do have different THC, CBD, or cannabinoid concentrations, yeah.
Thank you. Are there, we can call you back after we have the other people testify, Representative Thomas? Okay.
Yeah, she would know more than I
Okay.
probably about that.
And then I guess my other question is that a lot of this stuff is dispensed in milligrams, and there's no real consistency in translation between that and and ounces of plant form cannabis. If you were to have a low potency, 10% THC content cannabis versus one of the I think they're trying to push 30% out in California in some places, but I'm not sure if they've actually broken that level. How does that translate, or are we just simply stuck in some of the echoes of the drug war?
I think we're actually stuck in the echoes because you're right. It would be kind of weird to say, hey, you can have 4 ounces of a highly concentrated, and you can only have 2. It doesn't make a lot of sense. But this is just modifying what's currently in statute. I think it might be a little more complicated to have a nomogram that would say how many ounces you can have of what percentage, although that would certainly be another way to do it. But to remember that there's such variability in what patients need is the main issue, is that an oncology patient, as was mentioned earlier, may require a very large dose, and a person using it for social anxiety or, well, it's not approved yet, sorry, or using it for, yeah, oh, well, for something else, may use a tiny dose. I mean, even though I could never prescribe this stuff because it didn't come into being, I couldn't certify for this stuff because it didn't come into being until after I left practice. I kept up with a couple of patients who live in the same town. And the one guy's, he just uses a little bit of a brownie each night before he goes to bed, and that's all he needs, and then he doesn't need any opioids. It's as simple as that. So some people use really very small amounts. Yeah, it's hugely variable.
Thank you. Any other questions from the committee? Seeing none, thank you very much.
Sure thing. Thank you.
And next, I'll call Dr. Joe Hannon. This is the last card I have, so if anybody else had anything to testify. So Representative Thomas, will have you come back after. Thank you.
Good afternoon, Madam Chairwoman. My name is Joe Hannon. I was limping up here. My foot fell asleep, so it kind of goes into what I was going to start with, was mobility issues. I'm not saying that this is an indication. I'm not pushing for sleeping legs to be qualified under this, but anyway, up until this past summer, I'm in my 50s now, and I didn't really give much consideration, even though I was a practicing doctor for many years and I was in the legislature. I had a lot of experience with people with health conditions and mobility issues. It didn't really hit home to me until the summer when I had serious back problems and I really couldn't walk for well over a month, almost 6 weeks. And I had to get medicine. And since I'm in recovery, I'm hesitant to take most things. And my wife is like, hey, you need a muscle relaxer just to help you sleep or at least get some of the edge off. And I was out of town in some state, and I got a script called in for 5 days of muscle relaxer, just a little bit. And I had to walk from a hotel about 3 city blocks to get there. And I could barely brush my teeth. So just the fact that I had to do that, it boggles my mind to think that we're forcing people that have a medical treatment that they have to go very frequently to get filled. Most medications, if doctors prescribe them, they usually give, if it's something that people aren't consistently, they're usually 30-day supplies or sometimes 60 or 90 days or more. And they can give refills, but you can't do that. We can't prescribe doses and stuff. And I understand that's why they came out with these limits initially, but they really don't make any sense whatsoever when we're surrounded by the recreational adult use market. If someone wants more, they're going to get it. If someone's going to the medical place to get their medication, there's no reason not to allow them to get whatever they want. We've heard alcohol and other things. 2 ounces, you said, does anyone know what that is? It's 56 point some grams. So yeah, some people know. And that's not, I learned that from medicine, not from my past. But anyway, the other thing is, we know about mobility issues, weather, there can be power outages, travel distances. I travel 30 minutes to get my teeth cleaned. And, I'm not in the middle of nowhere. I live in the seacoast. It shouldn't be that, but that's what people travel in New Hampshire for, to get basic things. I mean, I've lived many places. I've been here well over a decade. I've never been able to not get Chinese food delivered to my house. While I live somewhere, I can't get Chinese food delivered. I have to drive 20 minutes. Imagine someone with a disability or mobility condition and they have to go back 36 whatever times a year. It's just uncalled for. And also, if there's a power outage or a storm or something, or there's a closure of a store, a lot of pharmacies right now are having problems staffing. And some are restricting their hours, some are closed more frequently, or if they have to close because they can't even get a pharmacist to show up. Now, I know this is pharmacy and not other pharmacy. But if a pharmacy is closed or they can't, for some reason you can't get there or it's after hours, there are 24-hour pharmacies. I may have to drive 40 minutes or, 35 minutes to get there. But if you need to get a 24-hour pharmacy, you'll be able to eventually get there. There are no 24-hour cannabis places anywhere yet. Sorry, didn't mean to spill that. Anyway, so I think this is really important, and I'd be happy to take any questions, and please pass this bill.
Thank you. Are there any questions from the committee? Seeing none, thank you very much, and I'll call back Representative Thomas.
Thank you. Yeah, I just wanted to explain a little bit more about edibles, the question about edibles. Most, if not all, dispensaries have syringes of concentrate, and each syringe is about 100 milligrams. So if you're like me and I want to know exactly how much I'm taking because I'm very sensitive to cannabis, and I don't want to be high. I don't like that feeling. So what I can do is I can take that syringe, make a plate of brownies. We all heard about that in college, right? And if you cut it into 20 pieces, then each piece is 5 milligrams. More or less, depending on how well you stir it. Another way to use cannabis in edibles is to decarboxylate it, which means to heat the flower up. Because once you heat the flower, that's what activates the THC. That's why people smoke cannabis. If you eat raw cannabis, you're not going to get inebriated. You might get a little calm from the CBD, but you're not going to get inebriated. So you decarboxylate the flour, and then you can use the flour in food. Some people sprinkle it on top. Again, I don't do that because I want to know exactly how much I'm taking. And lastly, when you are smoking the flour, a healthy bowl, and that's, typically what you see in on screen in movies and stuff. A healthy bowl is about 20 milligrams of cannabis in it. Way, way, way too much for me. So I use something called a one hitter that has a bowl that is about the size of the eraser on a pencil. That's how much I use. And it does the job. So people use this in different ways, and you need the product to make edibles.
Yes, a question from
So I guess
Representative Palmer.
sort of the gist of my question was you sort of, the 100 milligram syringe that's 100 milligrams is close to 4 ounces. Would that be the kind of limit of what somebody could buy? Or
No,
so the 4 grams is the raw.
100 milligrams. So it's not 100 milligrams is
sorry,
not
grams. Never mind.
Yeah, milligrams. No, we're talking milligrams. You could get a lot of syringes.
Right.
Yeah.
I'm off by a factor of 100.
Yeah.
Math. I was just, and it was just sounding like very little in grams, but now I got it. Good.
No, it's been a long day, and getting those different orders of magnitude. When you're converting between all of these, it's hard to keep straight unless you're writing it down. So. Okay.
Well, and if you're not a patient, this may not make sense to you because you don't have to do this. But as patients, this is what we do so that we can go to work. We can raise our families. We can go buy groceries and cook. This is what we have to do to be well enough to participate.
Thank you. That was very helpful. If there are no other cards, I will close the public hearing on House Bill 1350. And since we've already moved into the time frame for House Bill 1231, sorry, no, we're not there yet. We've moved in the time frame for House Bill 1581. I'm not sure if we have any cards for that one yet, but I'd love to get those pink cards. They didn't get them? Oh, she's got painting. Thank you. And with that, I will open the hearing on House Bill 1581 and call prime sponsor, Representative Suzanne Bale, to speak.
Thank you, Madam Chair, and thank you to the committee for spending this day listening to some of the bills that we've been working on and really exploring the program. Just as I mentioned, that I sent out to you, all of you, something that was shared with me, which was a presentation by and about the therapeutic cannabis program, and that was presented to the 611 Commission on legalizing for adult recreational use. So that information about the therapeutic cannabis program is a really good backdrop to what we're working on today, and just to urge your committee to continue to protect the therapeutic cannabis program for the patients as we move ahead with our state's ideas about what will be their non-therapeutic cannabis program. So thank you for keeping us in the context, and please understand that we really fiercely defend our program. The bill that I have before you now, which is House Bill 1581, is very simple. If you look at the analysis on the front page, it says this bill allows a second cultivation center to be considered for alternative treatment centers. That really should say this bill allows additional cultivation centers, because if you flip the bill over and you look at the other side, the paper over, and you look at the first page of the bill, it basically tells you that the department may authorize an alternative treatment center to operate additional cultivation locations, which may be a greenhouse, and which shall be subject to the rules adopted by the department under RSA 126X:6, Section 3, and all applicable provisions of this chapter that are already in there apply to having the greenhouse. So in terms of what we do now and what this would change, what we do now is we have a grow house. It is completely enclosed. There is no sunlight interacting with the therapeutic cannabis planting material that's being grown there. And in this facility, there is high pressure lighting and items that are used to raise the cannabis plants, but in an unnatural situation. With a greenhouse, you would not only curtail the carbon footprint of the alternative treatment centers, but you would be using natural sunlight to grow the cannabis plants, and all of the things that go with doing this the natural way also come under the same exact applicable provisions that the grow house is under right now. So in terms of security, interfacing with the town in which the cultivation center is located, the application of the rules by the department and by the program should not be, there should be no impact to this. The local governing town or body of this city or town where the additional cultivation location would be located, we would be soliciting input from qualifying patients, designated caregivers, and residents of the town or city, just as we would if we were opening up a new dispensary in the area. But this is simply restricting the cultivation. Actually, it's loosening it up by adding a greenhouse and allowing the greenhouse would be just for cultivation. So before I mumble on a little longer, I just want to open it up to questions. There's people that have more salient information about the amount of utilities that the way we do it now requires versus the way this would be helpful to them particularly. Thank you.
Thank you. Are there any questions from Representative Mazur? And then Representative McLean after Mazur.
Thank you, Madam Chair. Thank you for taking my question. It's actually a point of clarity. So you mentioned that the analysis should read, this bill allows, instead of that word second, additional. So to me, those are two very different words. So if we're allowing a second cultivation center, and if you're, and correct me if I'm wrong, if you said that should say this bill allows additional cultivation centers, those are different things. So can you clarify what you meant by that?
Yes, I can. And thanks. That's a good question. I'm just noticing that when exactly what you're noticing, this line in the analysis doesn't match the text in the bill. And so I made reference to it as an error because I would hope that if we move ahead with this, that goes over to the next body without that kind of an error.
Do you have a follow-up or no? So what happens with that then? How do we fix that before it moves on?
May I ask you to send an email to OLS and let us know what you find out? Because I think it'd be a great idea for us to be able to correct these when necessary on that.
Sorry, is that me or
Yes,
is
Representative Mazur.
Okay,
Yes.
not
If you
Representative
don't mind.
Vale.
No.
No, not at all. If you want me to comment, I can, but if you don't need me to, that's fine. I just, this is a mistake in the drafting. That's the way I see that. And so, yes, clarifying that, my understanding is that the bill text takes all precedence over any analysis statement, but that I could be wrong about that. And it would be judicious to get the information directly from Office of Legislative Services.
Yep, thank you.
Representative McLean and then Representative Shapiro.
Thank you, Madam Chair, and thank you for taking my question. So I remember when we first brought in an ATC into Manchester, we had the public hearings, and one of the things that everybody was reassured about at the time that that center came in is, in fact, it was brought in with great secrecy. We knew it was in the district, but nobody knew where. And they said it's going to be nondescript. Nobody's going to know it's there. It's not going to, present, any interest to the community at all because it's boom. And this is going to be changing all that. It's going to be a greenhouse. It's going to be much more visible. So is there was any of that taken into account? I mean, I understand the argument that, hey, it's going to be more energy efficient and things of this nature. But the other concerns that were kind of brought up when the ETCs were first brought in, is there any reason that we're comfortable moving beyond that at this point? Do you know?
I think that's a really good question. I think that we can be comfortable moving beyond that at this point because we're giving the opportunity to the ATC to lower patient cost and to find a better way to make the products, and that helps the program all the way around. But each and every step of the way, there's been a public hearing before any kind of structure has been allowed to impact a community. And I'm the nondescript type of location and the whole discrete and health protected information is certainly going to be taken and considered by the ATCs. And if it's not, the public is going to make them aware of any concerns and any kind of discretionary approaches they would take.
Thank you. So, and for any new installations, it's enabling. It allows you to put in, and it would go through the whole public hearing process kind of thing that talks about that. But for existing facilities, if you wanted to convert them, would that conversion go through the same process? They would have to come back and go back to the community again and engage them. We want to convert it from the state it's in now to, like, for example, a greenhouse state. With the existing facilities, would they also have to go through that same process? Is that the intention?
If they wanted to change from having the grow house that they have right now, which I didn't hear, I heard that what would be helpful is if they were to, because they want to be able to increase their production and we want to make more access to the products for the public. We wanted them to be able to get the certification, but we also want them to have the benefit of the price points. And right now, so what we're asking, would the ATCs move away from having a grow house that's, probably costing like $20,000 a month to put these high intensity lights and build up the heat and then try to take that heat and cool the place back down? So they have to think about what I wasn't under the understanding that people would convert what they have now, but that this would be additional grow houses. cultivation centers really. And if it were to be a greenhouse, I just don't see how that would be really different in terms of like, it can be discreet, it can be, it's just as secure in my mind.
Thank you.
Thank you.
Representative Shapiro?
Thank you, Madam Chair. What is the main impetus for bringing this bill or making this change? Is it financial? Is it ecological? Is it somehow the quality of the cannabis that will be grown? Is it all the, what is the motivating factor towards making this change?
I can say as a legislator and a patient of the therapeutic cannabis program that I think this will be helpful for a lot of the things that where they just want to grow and perhaps bring some of what their results are just from cultivation standpoint and not necessarily be working on the synthesis of products in any additional facilities. So they would still need to have a facility where they use energy and they convert the products from raw plant into the different products that they have on their menu. But at the same time, they would be able to grow more economically. They would be able to have an additional location. I think when you think about the carbon footprint, that's another argument in favor of this, because really what we do right now is we don't have any natural sunlight coming in. We just have grow lights and we have the air circulation system, and that's what we're working with. So I think the impetus is to help the dispensaries to grow more product at a better price, but the other things are very hard to tease out, because there are benefits absolutely, to the environment. And
Follow-up?
Follow-up. I don't really know about this, but so this is just what I've read. But I've read about the odor that comes from the growing of cannabis. And I mostly read articles about California where there were some, those were illegal growing, but that in some neighborhoods where a lot of marijuana was grown, that the neighborhoods were so affected by the smell in a negative way. And so I've never heard that brought up in terms of New Hampshire and the grow houses that exist here. Is that an issue? And if it is an issue, would it be more of an issue if it was done in a more, in a greenhouse rather than a self-contained building? And maybe you don't know about this, or maybe I'm off the mark. I don't know.
not at all. No, Representative Shapiro, thank you for the question. And no, I think that's a really good question. I'm at this point right now not on the property of the grow house that they have right now, but there are people in the room who are, and who can perhaps help all of us have more firsthand knowledge about the therapeutic cannabis program, including like myself being able to go to the grow house and find out. But following my testimony, there are a couple people here that can probably take that question and swiftly deal with it better than me.
And I'll actually interject here as chair. In conjunction with the adult use bill, there have been some cultivators who have offered to provide tours for people who want to understand this more. I don't know if those who are growing with the ATCs will be able to make a similar offer, but that's something so that we can be more knowledgeable about what we are increasing access to. Anybody on this committee who's interested in learning more about the actual process, I could help coordinate that, either through those in Maine who have offered up the opportunity, or if the ATCs are interested in doing that here. So I think that would answer a lot of the questions that you have, because I did take a tour of one, and it's not what I read on in the newspapers or see on TV. So.
And I can just, if you don't mind, Madam Chair, I can just reiterate that with that, there's a lot of interest in finding out more about about what we're doing, and there are more opportunities for the House and House members and the Health and Human Services Committee to engage and find out what exactly we're doing so that you know where we're going with the program and what our vision is. Because we come in, and as Representative Thomas said, we come in and we're looking at things piecemeal, a little bit at a time, and it's a big picture.
Thank you for that. Are there other questions from the committee? Okay. Seeing none, thank you very much. Representative Thomas?
Hi again. Representative Wendy Thomas, Town of Merrimack. A few things I wanted to clarify from the previous statement. I think there's some confusion because they do not grow at the ATCs. At the ATC proper, it is a storefront where they sell the flower, the products. They grow in a cultivation facility that is off-site. So in your hypothetical situation, the ATC, to the best of my knowledge anyway, would not be setting up a greenhouse like out back or anything like that. Right. So I was going to say it has nothing to do with the ATCs, but the ATC is a storefront. The growing happens off property. Correct. They work in conjunction. And to answer the question of why we would need a bill like this, we've just spent the whole day talking about adding different symptoms, anxiety, eating disorders, a bill that you just passed, 20-0, thank you very much, that would allow physicians to recommend for any condition. So what we're talking about is opening up this program, making it bigger. If we're going to do that, we need more product. Allowing the ATCs to have a greenhouse means they don't have to set up a whole building. It's sort of a faster way to get this done. It's not, so I mean, it's just, it increases the floor space for creating more product, for planting. The other thing is that I will tell you that with the release of this HHS report descheduling, or rescheduling, I should say, cannabis from 1 to 3 or 3 to 1, so many people have already contacted me because they know that this is in my wheelhouse. They know that I'm a real advocate. There's going to be tremendous increase in interest in people trying this program because now our federal government is saying, hey, you know what? It's been medicine all along and it's helped a lot of people. So I've had so many people contact me and ask me questions. How do I get started? What do I use? What strain? You know, how do you do this? So the ATCs, as long as we don't have recreation, the ATCs are going to have to bump up their production to accommodate these needs. Oh, and the other thing about the smell, there was a question about smell. So here's the thing, you harvest cannabis before it flowers. So you're not going to get any kind of a flower smell. You're going, well, we use the word flower. You're going to get an organic smell, a very sort of like cut grass smell or something. To some of us, it is a lovely, lovely smell. I mean, I just adore the smell of cannabis. I know, it's a little weird, but it's not, you know, I mean, sometimes when you smoke, and especially if you're smoking the skunky strains, it can be a little overpowering, but the plant itself is no more, it smells no more worse than tomato plants, I think.
Thank you. Are there other questions from the committee? Seeing none, thank you very much. Next, I'll call Matt Simon from Granite Leaf Cannabis. Thank you.
Thank you again, Madam Chair. Again, for the record, Matt Simon, Granite Leaf Cannabis. We support this bill. I'll begin by answering Representative Shapiro's question. The main driving force behind this bill is cost, affordability for patients. When this law first passed in 2013, it was at the end of a 4-year ordeal. We had bills passed the House and Senate and vetoed in 2009 and 2012. There was strong opposition from the Police Chiefs Association and many others. There was a climate of fear around this issue. So as the law was being implemented, there were a number of policy decisions that had to be made that could roughly be described on a spectrum from prioritizing patient care, the patient experience, low costs, high quality. And over here, there was a concern about security, diversion. Some people were very afraid that the licensed businesses would simply be selling cannabis at the high school and shoving it out the side door and everything. So during that implementation period, I would describe it charitably as an abundance of caution that led the general court to adopt a law and rules that were very restrictive and not for the benefit of patients. So patients are aware that prices are lower in neighboring states. They wonder why that is. And the number one complaint about New Hampshire's therapeutic cannabis program far and away has been cost from the very beginning. Why is it cheaper in Maine than in New Hampshire? And there are a number of reasons for that, but one of the basic reasons is that neighboring states allow greenhouse cultivation. Neighboring states also allow outdoor cultivation that doesn't have to be in a greenhouse. They have regulations, they have security requirements, but they have options for cultivators. So this is something that's contributed to the high cost of cannabis all along. And this would be a way that we could make cannabis somewhat more affordable for patients in New Hampshire while reducing our carbon footprint, which our production facility is made up of people who grow and process plants. They tend to love the environment and nature and would prefer to be operating as environmentally friendly as we can. So Representative Vale's description is correct. There are no windows in our production facility. One clarification, it's a little funny the way the law is written, but the companies are ATCs. As an ATC, we have a licensed production facility. Ours happens to be in Peterborough. You could spend hours driving around Peterborough and you would never find it, but it is there in a very nondescript location. I will admit that there is a slight cannabis smell as you approach that facility. It is not a strong smell, and the key is that nobody gets near our facility except for the people that work there and contractors who come in. We would love to host a tour, and we're very open to that. Touring any ATC location does require approval in writing from the Commissioner of the Department of Health and Human Services. So if this committee, for example, would like to tour our production facility, we would be happy to have you. We would just have to formally request that through the appropriate channels, and we could pick a date and walk you through it. I'm sure that would be very educational, and happy to have you. So in discussing this bill, how to bring it in, we actually considered whether to put outdoor in there. I assume that the adult use bill will allow outdoor cultivation. We don't have a long growing season in New Hampshire, but you can get one good season out of a New Hampshire summer. And that will be the most cost-effective and environmentally friendly product that you can have. So the committee could choose to add outdoor to this sentence, but we wanted to get it passed. And speaking for Granite Leaf, we would really like to have a greenhouse. That's what we would very much like to pursue for the above mentioned reasons. And so just adding a greenhouse would be great. Adding greenhouse or outdoor, that would be great too. I'll leave that all to you, but more than happy to answer any questions.
Thank you. Questions from the committee? Representative Nagel and then Representative Mazur.
Thank you, Ms. Chairman. Madam Chairman, I'm sorry. Thank you for taking my question. I'm just curious. So I used to be on one of the dispensary boards, and I actually did tour the facility. And what I was struck with was just the sophistication of the growth process, and every variable was controlled, the humidity, the temperature, and to a square foot. I mean, that amazed me. And they said to me very specifically that that was necessary to create a reproducible product, which a pharmaceutical product should be. I'm confused when you start going outdoors and into greenhouses, how do you accomplish that and create a reproducible product so that we make sure people are getting something that they think they're getting?
Yeah. So thank you for that question. It's a good question. There are advantages and disadvantages to indoor cultivation versus outdoor cultivation. Indoors, you can control every aspect of the environment. You're basically recreating nature indoors and tricking a plant into thinking it's summer and then fall, and you can control every variable, assuming you don't have power outages, which we've had some issues over the years, some complications. I would say that some cannabis will always be grown indoors. We're not proposing to move all of our cultivation outdoors. The highest and most high quality flower will always be produced indoors under lights. This would enable more cultivation of products that most of which will be made into other products. So this is where the independent lab testing comes in. Every batch of cannabis that we grow has to be tested by an independent lab for the cannabinoids. We also test for the terpene content and for a wide range of contaminants as required by state law. So there's actually more risk of contamination with outdoor cultivation. That's one of the reasons I'm personally so concerned about Maine's medical cannabis program, where there are hundreds of caregivers growing outdoor cannabis and selling it in caregiver storefronts with no lab testing requirement. And the price is very appealing to patients, and patients, particularly New Hampshire patients, may not have any idea that those products are not lab tested. So in our case, we'd be testing the flower that we grew outdoors, and then we'd be making products out of that flower, and then we would have to have those products tested as well. So it would be a controlled product. It would have to be controlled to get through the testing.
So building on that, is that one of the reasons why I know there's a lot of reasons for cost difference, but is that one of them? That the level of oversight that we have here in terms of the final product versus there, does that dramatically increase cost?
It significantly increased costs. That is one area of cost increase that I have never complained about because obvious reasons. Patients or even adult consumers, we've heard a lot recently about cannabis being adulterated with fentanyl, for example. I think there have been very few confirmed cases of that actually happening. But what I've been saying for 17 years as an advocate for responsible regulation of cannabis is that there's a tremendous amount of cannabis on the illicit market that is tainted with mold and pesticides and fungicides and heavy metals. The cannabis that we produce within the therapeutic cannabis program does not have those contaminants, and that would be the only concern introduced by outdoor or greenhouse cultivation, but we have a testing system that would prevent that from negatively impacting patients.
Thank you. And before I recognize Representative Mazur, I did want to recognize that having any sort of field trip of the committee is going to run into all sorts of challenges. So anybody who wants to learn about it, I suggest reach out to Mr. Simon. But this won't be any sort of mileage approved sort of official tours. So Representative Mazur.
Thank you, Madam Chair. Thank you for taking my question. You mentioned law enforcement. Have they come out in support or opposition of this? Has there been any discussions? Maybe they're here. Is someone here to testify today? I don't know. But I'd be curious to see what their stance would be on it.
Yeah. Thank you for the question. I have not spoken to the Chiefs of Police Association. I don't see them here today, so.
Thank you. Any other questions from the committee? And I will ask one. I do know that the largest complaint has been the cost, and that some oncologists in the state in the past have just suggested that their patients seek out their grandchildren to reach that market. But I think that was in the early days. But the cost is still significant. Will this allow an increased scale that then will allow you to bring down prices to a point where more patients do access it and sort of have a have a more market stabilizing function by allowing more canopy space?
I believe so. There are a number of factors that impact cost, but this is certainly one of them. It would enable us to cultivate more cheaply and to pass that savings along.
Thank you. And with that, I will call, oh, sorry, Representative Merchant has a question.
Thank you, Madam Chair, and thank you for the question. I'm looking at the bill at this point in time on line 7 about compliance with local zoning laws. Then it goes on and says the department shall, in conjunction with local governing body and so forth, consult with them. Are we saying that the local zoning law, if they decide not to allow for this, will trump the department? Or is it just one of those things where it's a courtesy from the department to talk to local people, but ultimately they can do as they wish?
Okay, thank you for the question. I think it may be two questions. We would have to comply with local zoning laws. I don't think there's any ambiguity there. And the department separately shall solicit input from patients, caregivers, and residents of the town. And that goes back to what Representative McLean was saying. When each of the dispensaries and production facilities opened, there had to be a public meeting in that town to discuss concerns. It was not an approval process, but they did have to be consistent with zoning. We couldn't violate zoning laws.
Thank you. In regards to the zoning laws, help with the clarification, what happens if the town does not have zoning laws?
I don't know.
Thank you. Any other questions? Thank you very much.
Thank you, Madam Chair.
And I'll call Mr. Jim Riddle. I've been a little lax on this. I'm going to make sure that I do, in fact, make it ding and let you know if you've gone too far past. So just for everybody in general, not for you specifically.
Okay, thank you, ma'am. I was worried that you were singling me out. Do I have a reputation?
No, not at all. I just want to make sure that I'm not letting things
No,
sort
no.
of extend for everybody.
Yeah,
too
before I
much.
start, how long are you setting
Up
that
for 3 minutes.
Oh, okay.
So
great.
less than you've actually requested, which is a good reason to ask
Perfect.
to remind you.
Okay, thank you, Madam Chair, members of the committee. My name is Jim Riddle, and Hillsborough. I mentioned before, some of you weren't in the room yet, I do have a New Hampshire medical card, as well as a USDA hemp grower license. I grew up on a farm and have been involved in agriculture my whole life, and specifically in organic production. And, you know, the way that the current medical cannabis is produced was described by Mr. Simon as indoors, total artificial environment, you know, dependent on electricity, high inputs of light and ventilation, etc. And yeah, that's producing good, predictable products. But I'm very excited to see this bill before you to get some of that production at least into a greenhouse. And I would certainly encourage amending to add the words "or outdoors" to the sentence where the greenhouse is mentioned in line 5, because I think that provides a totally different product. If you think about tomatoes you grow in your garden in the summer, the flavor versus the ones you're buying right now in the grocery store, they look nice, they look like tomatoes, but they just don't have flavor. But things that are grown in healthy living soils, I mean, we've had a saying in the organic world forever that healthy soil leads to healthy plants, healthy animals, healthy people, and a healthy planet. It's all about soil health. And you can extract the chemicals and give that plant what it needs to produce the cannabinoids and good flower, etc. But there's nothing like that, the ecology of soil. The organisms that release nutrients to the plants lead to much more complex phytochemicals in that plant. And with cannabis medicine, it's not just the cannabinoids. It's not just the THC level that everybody's focusing on potency. It's also the terpenes, these secondary plant phytochemicals that when really can be produced under those artificial conditions, definitely. But they also can be produced with healthy living soil and plants that are exposed to the sunlight, but also to the wind, to pests. They develop different chemicals depending on the stresses that a plant experiences during its life. So I don't want to endanger the bill by adding or outdoors if that would make too many red flags go up, but in reality that would allow three types of production, really: the total artificial indoors that we have now, the greenhouse, which is intermediary, and then the outdoors, and that will be the most environmentally sound, but also produce the broadest range of products to serve the needs of patients. Thank you.
Thank you. Are there any questions from the committee? Representative McLean?
Thank you, Madam Chair. So just for informational purposes, because I don't know, when you go to buy a nice juicy tomato and you get it from, the outside, it's nice and it's juicy and it's delicious, but there's also a lot of variety. One of the things when I go and I buy like a Tylenol pill, I want the Tylenol to be consistent pill to pill to pill. So, so there was some testimony earlier that maybe questioned that maybe we would be giving up some of that repeatability, though, if we went to outdoor growing. So how significant would that be?
Yeah, well, I come back to Matt Simon's response, which that's really the business model, the choice of the ATC here. But and yes, they want that predictability. It has to be on the label. They need to meet their quality standards. So what I heard him say is if they could do greenhouse or outdoor, that would be to produce plants that then would be used for processed products, not so much for the raw flower. But if it could meet the quality standards and the predictability in either outdoor or greenhouse production, there's no reason why they should be prohibited from doing that. But if there's any uncertainty about either the cannabinoid levels or the terpene levels, then that can be formulated by breaking down that product and putting it into an edible where it's gone through a lab testing and the dosage is exactly controlled.
Representative Merchant?
Thank you, Madam Chair. And also I want to follow up on the comment about consistency. If the final product, regardless of where it starts, but where it ends up, we're going through the analysis to show and demonstrate through the lab analysis that the product is basically the same regardless of its source, is that not kind of the gatekeeper? Is that it's the stamp of approval saying this product is the same as that product because we've gone through the lab analysis?
Yeah, thank you for your question. I think any product that's put on the market needs to meet all the basic minimums for safety as well as predictability. That if it says it has a certain cannabinoid content, it needs to have that. But there are people in the marketplace looking for outdoor grown, and I mentioned that I've been involved in the organic. I was an organic inspector for 20 years and served on the National Organic Standards Board. And the regulatory, because cannabis is federally prohibited and because the word organic is federally regulated, there cannot be certified organic cannabis. There can be hemp, which is the cousin, same species, but yet, you see that word organic used all over the place in the cannabis trade, but it's an unregulated claim that's being made. I want to see regulated claims that have meaning, but there is a market for, and now we're talking more in the adult use recreational side, but people are looking for outdoor grown. They're looking for specific strains, specific genetics, in addition to the numbers on a label.
Questions, Representative Nagel?
Thank you, Madam Chair. Thanks for taking my question. We're about to hear another bill that has to do with homegrown functionally. I mean, this is, cost and access are huge issues we've already talked about today. What I'm looking at is you're going to be limited in terms of dispensaries, in terms of having to grow indoors where they can grow it outdoors. That doesn't seem to be fair. Is some of this creating some sense of fairness and equality of product? Because
Yeah, thank you for your question. And yeah, I have to agree with where you're going with that. Is if there is the outdoor grow option for patients to grow a few plants, hopefully that will be allowed to be up to their choice, not be micromanaged by the state of whether it has to be in a closet, in a grow tent, or it could be outdoors so long as it's secure and meets whatever rules accompany it. But yeah, I think the ATCs who have invested, who've carried this market, made it what it is, should be able to play on the same level playing field that the patients hopefully will be able to when the next bill is passed.
Thank you. Any other questions? Seeing none, thank you very much for your testimony. Next, I'd like to call Dr. Riley Kirk.
Thank you, Madam Chair, and the rest of the committee. My name is Dr. Riley Kirk. I have a PhD in pharmaceutical sciences, specializing in the chemistry and pharmacology of the cannabis plant. I want to highlight a fact that Jim Riddle just made earlier about greenhouse and outdoor cultivation practices enhancing the flavor of the flower. Flavor is a result of terpenes and other smelly molecules present in this plant. In indoor cultivation, the plant has less of a need to produce these smelly molecules because the purpose of producing these molecules for the plant is to protect itself from sunlight, microbes, and other environmental stressors. Without these stressors, there's no need for the plant to produce them, so it produces less. We have peer-reviewed scientific studies that greenhouse and outdoor-grown cannabis produce unique, therapeutically relevant compounds compared to strictly indoor cultivation, including a significant increase in terpenes and cannabinoids, and actually less degraded molecules compared to indoor grow. Indoor cultivation, greenhouse cultivation, and outdoor cultivation can all be used as tools to provide the greatest diversity and medicinally relevant compounds from this bioactive plant. I understand the need for consistency in cannabis products, but the efficacy of outdoor and greenhouse grown cannabis is an undeniable effect, especially for medical patients. Greenhouse cultivation also makes the growing process of cultivation makes the growing process of cannabis more green, aka more eco-friendly, as mentioned earlier, meaning it limits the amount of artificial lighting and the associated light bills and heat costs of those cultivation practices. It is also going to allow for faster and more robust cultivation to accommodate our potentially upcoming adult use industry in the state, which will hopefully allow us to meet the demand and keep the cost of the products as low as possible. As far as the smell of cannabis, I will remind everyone that manure from farms smells pretty strongly, and some old paper mills also smells pretty strongly, but we did not stop these industries because of smell alone. There are also some smell remediation technologies that could be implemented to reduce the smell of greenhouses, as Matt Simon mentioned earlier. These greenhouses are not going to be put in the middle of dog parks or next to the mall. They're often very far off the beaten path and hard to find if you don't know what you're looking for. I also understand the argument that some people don't want to see a greenhouse, but alternatively, I would say that myself and many other people in the state would love to see more greenhouse cultivating cannabis. We should not feel the need to hide in secretive, nondescript buildings, as this portrays our industry in the wrong light, and this is exactly what our industry has been forced to do for decades. One of the benefits of an expanding legal industry in New Hampshire is we can be proud of it and showcase the amazing cultivators in our state and the flowers that they cultivate to heal our citizens. Thank you. I'll take any questions.
Thank you. Representative Nagel?
Thank you, Madam Chair. Thanks for taking my question. You said something that really struck me. You said the undeniable efficacy of homegrown. Do you have any data to support that? Because I've never heard that.
Of outdoor grown.
Of outdoor grown.
Of outdoor. I would refer back to the paper that I'm happy to send you from the University of Colorado that was comparing indoor versus outdoor versus greenhouse, showing that there is substantially higher amounts of these bioactive compounds produced in outdoor and greenhouse cultivation compared to indoor. And to me, that's synonymous with efficacy because you have more of the medicinal compounds present in those flowers and unique compounds as well.
Thank you. Other questions? Or did you have a follow-up to that?
Well, isn't a follow-up as a separate question?
Yes, another question.
So one of the things I was struck on my tour is that the place smelled like grapefruit, which is what the terpenes smell like. That's not an obnoxious smell. It's not till you burn the actual product that you get the obnoxious smell. And that can be controlled. Am I correct?
Absolutely, yeah. And I agree. I think that grapefruit smell is amazing. And people, I mean, these cultivation facilities aren't, burning a bunch of cannabis and that's, causing the whole area to smell. They're just cultivating plants that are producing relatively low levels of these organic compounds called terpenes, which are also present in every single other plant that exists in the world.
Representative Merchant?
Thank you, Madam Chair, and thank you for taking my question. When we're talking about the clinical efficacy of the product grown outdoors versus grown in a greenhouse, are we talking about a product that's consumed orally in the sense it's edible and it's going through the GI tract? Are we talking about a product that's going through the lungs through something that's inhaled? Because there are fundamentally two different ways to get the drug into the body.
That's a very good question. I'm just really referring to what the plant is producing for those molecules. And then I think it would be up to that business to decide what to do with it after. But it exists in that plant when oftentimes it does not exist in indoor cultivation because those genes are never activated to actually transcribe and produce those molecules.
So, thank you. Follow-up question to Representative Nagel as well. It's nice to talk about the plant itself and what we find from analyzing the plant. Can we somehow tie that to some sort of studies, evidence that change in the plant per se causes a change in the efficacy of the product in the body?
I will bring up an example of the study that I'm referencing that there was an increase in the amount of beta-caryophyllene, which is a terpene produced by the cannabis plant. Beta-caryophyllene directly binds to the cannabinoid 2 receptor in the gut, and it has been shown to be efficacious for people with Crohn's disease, ulcerative colitis, and many other gut conditions. So in this instance, the plants that produce more of this medicinal compound would be more medicinally relevant and often efficacious for this population compared to a plant that was grown indoors that might not be producing that molecule.
Thank you. Representative Nagel?
Sorry, thank you, Madam Chair. I just have a quickie. If you could send me the paper from University of Colorado, and do you by any chance know who the authors were of that paper?
Not off the top of my head.
But you can get
sorry.
it for us.
I'm happy to send it though.
Thank you.
Thank you. Actually, if you send it to the chairman, we probably all want to have it. So if you send it to the chairman, he can distribute it to the committee. Thank you very much for your testimony and your study of this subject. Next, I'll call Dr. Joe Hannon, and he's the last card I have for this bill. Thank you.
Thank you all. You can start the timer anytime. I'm ready. Thank you. My name is Joe Hannon. I've talked to you already several times, so I won't be too wordy like I usually am. But I was also on the study commission, not the recent one, but the one that had a quorum and a report years ago. And we took tours. I also took tours with people on this committee at a grow facility. I drove past it 3 times before I could find it. I kept turning. I'm like, where is it? Where is it? I couldn't find the place. It was it was a huge building, but it was very easy to miss. I didn't even really smell it as I was approaching it. In fact, the place that I could say it's safe to say that I smelled a stronger, I wouldn't say overwhelming. I was whelmed by the smell of cannabis in the back of the house anteroom more than I was walking past any of these grow facilities. For some that know history, you might know what I'm talking about. But it was in the paper. Look it up. So Anyway, we've already heard building costs, the higher energy costs that we have in New Hampshire. That's one reason why things are more expensive. Anything indoors is more expensive. Building costs, limitations of materials. I tried to put in a new little renovation in my house. I couldn't get plywood for 2 years. You know, what do you have if you can't, you know, there's cars in the market that were there without transistors. There are, I heard Governor Sununu last night talking about the housing crisis. They have several building projects have been held up because of like a transformer of some kind they can't get. There are very large projects that can't be done because of things in the market. It also, from my learning experiences with the different growers and stuff, it takes many months, maybe up to 9, 11 months or more, once you have a building to actually get a crop and a ready for market. So they don't just say, oh, we're going to have a grow facility, and then like, you know, one sun cycle later, they're ready. You know, they can't really do it that fast. It takes many months and millions of dollars to get these places up and running. So if we're going to have an expanded patient population, which thank you for pushing that, you're going to need expanded supply for the patients, and this is absolutely necessary. Utility costs, we talked about meeting the needs of the patients by decreased costs, but it was also mentioned by someone, I'd like to reiterate, it's important for the purposes of diversity of product. You know, you're going to see if you only can have so much and you can only grow one area or one crop, you're not going to have as much diversity, and people really have different needs for medical products, not just in cannabis, but anything. You know, I guess if we polled everyone here, what's your favorite soft drink, there would be many different, you know, options. It's the same with cannabis. People have different flavors, different choices, and there's different things we heard about medicinal properties that you're going to have increased benefits from growing outdoors. You know, and lastly, I'd like to say that, you know, having one grow facility is really having a business with all of their eggs in one basket. If something happens to that place, if there's a roof collapse from snow, if there's a power outage or a transformer gets hit, that place is out of commission. It could ruin a crop or delay it. That can drastically affect the patient's, you know, ability to get what they need. It can affect costs and all kinds of things. So please pass this. This one just makes sense. And I'd really appreciate it if you could also support this to be in line with expanding the medical patient population. Thank you.
Thank you. Are there questions from the committee? Seeing none, thank you very much. And since I don't have any other cards, I will close the hearing on House Bill 1581 and hand the role of chair back to the chairman of the committee.
Thank you, Representative Leon. Okay, I'm going to open the public hearing on House Bill 1231 at this time and recognize the prime sponsor, Representative Wendy Thomas. Representative Thomas, we need to give you a seat at this table, I think, or at least in this committee.
It's me again, Representative Wendy Thomas, Town of Merrimack. I am pleased to present this bill once again to this committee. It is the exact same bill as amended that you passed last year, 19-1 from this committee, and it passed on the consent calendar. It was put on the table in the Senate. So I'm here to introduce House Bill 2170, which is permitting qualifying patients and designated caregivers to cultivate cannabis for therapeutic use. Most people call this the home grow bill. So I'm going to walk you through this argument. So why do we need this bill? First reason is cost. Cannabis is not covered by insurance. If you are a patient who uses a lot to keep your symptoms under control, it can be expensive. And remember, this is a vulnerable population. Many of us are unable to hold jobs. This bill helps low-income, immobile, or homebound patients who need medicinal cannabis to be able to grow their own medicine and get help doing so. Dispensary location. There are 7 dispensaries in all of New Hampshire. Not all patients have cars or an affordable way to get to them. Just to put that into perspective, in my town of Merrimack, we have 5 pharmacies. Strains. Everyone reacts differently to cannabis strains. What may work right for one person might not be as effective for another person. Sometimes the strain that works best for you might be discontinued. Growing it would be a good option. The New Hampshire Therapeutic Cannabis Program began in 2013. It's 10 years old. Since we began, we have learned about the program and patients' needs. Dispensaries have been added along with more qualifications to get into the program, and the program has been modified to better suit patients' needs. Since 2009, the New Hampshire House has consistently supported bills allowing patients with qualifying medical conditions and their caregivers to cultivate a limited supply of cannabis. In 2012 and 2019, the Senate agreed. Advancing homegrown legislation went to the governor's desk. Both bills were vetoed, and the override efforts fell short in the Senate. In 2020, the Senate passed a home grow bill in a voice vote, but the outbreak of COVID-19 prevented it from being considered in the House. What this bill does. This bill allows New Hampshire therapeutic cannabis patients or caregivers to grow their own cannabis plants at their place of residence within guardrails set forward by this bill. Patients are still bound by the guidelines of the program as identified when you submit or renew your application. If grown outside, the plants cannot be viewed from another private property. It would allow New Hampshire therapeutic cannabis patients to have and grow 3 mature, which are flowering plants, 3 immature or non-flowering plants, and 12 seedlings, which are identified at 6 inches or less. Patients can grow the plants from seeds, and some of the dispensaries have said that they will be able to provide seedlings. The plants must be kept in a locked and secured location that is reported to the state. The patient must ensure that the plants are secured from unauthorized access. Patients would have access to state labs for testing of cannabinoids and possible contamination, which is usually mold or mites. What this bill does not do. This bill does not mean that every therapeutic cannabis patient will start growing plants. Some patients will try and then realize it's too much work and they'll stop. Some patients will be interested and will simply gather information on how to grow cannabis plants. And some patients will simply say, I'd rather buy the flower. It does not create dealers or suppliers. The therapeutic cannabis program is self-regulating. To be in this program, you must sign a contract that stipulates limitations on how much cannabis we can have, where we can keep it, and how and where we can use it. We know that if we disregard these conditions, we can be kicked out of the program or we can be penalized at a higher rate than others. No patient is going to risk that. Again, this is not recreation. This is a medical program for very sick patients. It does not create hidden stashes of cannabis. Growth locations must be reported to the state. Reasons for allowing home cultivation. Secure home cultivation is not causing any problems. 14 of the 18 states that have legalized adult use cannabis and about half of the medical cannabis states allow for personal cultivation. In the states that have reasonable safeguards, home cultivation has not been a problem. No state has repealed home cultivation. Home cultivation is important for patients. About 6% of Americans use cannabis for therapeutic reasons. Insurance does not cover cannabis. For many people with serious medical conditions, medical expenses and a reduced ability to work make getting cannabis difficult. By allowing home cultivation, you are giving the therapeutic patients financial relief for their non-insurance covered medicine. Home cultivation helps to displace the illicit market. Some patients need more. Some patients don't have the financial means to purchase tested and measured cannabis from the dispensaries. Home cultivation would allow those patients access to cannabis without having to use the illicit market. Home cultivation is consistent with our commitment to freedom and equality. In a free society and a state with the motto of live free or die, adults should be allowed to grow cannabis plants in their homes for therapeutic use. What's happening in the other states? Connecticut allows up to 3 mature plants and 3 immature plants. Maine allows up to 6 flowering plants, 6 immature plants, and unlimited seedlings. Massachusetts allows up to 6 plants per person or patient, no more than 12. Rhode Island, up to 12 mature plants and 12 immature plants per patient. Vermont, up to 2 mature plants and 7 immature plants per patient. So who supports this bill? This is a bipartisan bill that originally came out of the committee with a vote of 19-1, and it passed in the House in 2023 on the consent calendar. The dispensaries support home grow and are ready to roll out classes on how to grow and may even offer some equipment that could be used to grow. The Therapeutic Cannabis Board voted unanimously to support this bill. It is seen as an economical way to support therapeutic cannabis patients. In summary, the New Hampshire Therapeutic Program has been alive and well since 2016, and it is only getting stronger as we listen to patients' needs. House Bill 2170 is a compassionate, humane bill that also encourages business growth. It's time to let patients take more control of their health and wallets by allowing for home growth in the therapeutic program. And I'd like to point out that there's 2 edits to this bill on page 2, line 7. Page 2, line 7, I'm sorry. The word with should be within, and it's really just a typo. And then on page 4, line 27, the OLS didn't catch that there was a date change, so the date should be changed from the year 2023 to 2024. So I don't know if that requires an amendment. These are really 2 typos, so I'm going to leave that in your hands. But I'm happy to take any questions.
Representative Leon.
Thank you, Mr. Chairman, and thank you for bringing this bill. I actually see that it's not bipartisan. I had wanted to be a sponsor, but I'd be happy to bring forward the amendment to change those issues.
When I said it was bipartisan, it passed on the floor.
Oh, yes.
And it passed in this committee.
Thank you.
But I'd be very happy to have you on an amendment for this.
Okay, thank you. And then the other part is you had said that the seedlings were up to 6 inches, but the definition says up to 12 inches.
Oh, okay.
So, thank
This
you.
was last year's testimony. Yeah, okay. Thank you.
No, I appreciate the improvements, and I was going to ask the question before I looked it up, so I figured I'd inform everybody else. So thank you for doing this.
Thank you.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So
Sure.
I remember this bill because it was 19-1 last year, but you said it died in the Senate. Do you know what their objections were, and have you spoken to them, and are they okay with it this go around, or what's the status, I guess is the question.
I am never going to take the responsibility of speaking for the Senate. However, this bill passed. This bill was seen as having merit coming out of committee, and it was during a time when the governor was indicating that he would not sign any cannabis bills at all. While this bill was being heard and put on the floor, the governor said that if you put a cannabis bill on my desk, I will sign it. But it was too late for this. But because in my estimation, because they found there was merit to this, they didn't kill it in the Senate, they tabled it, which is why you are seeing the exact same wording as you saw last year.
Thank you.
Other Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. In full disclosure, I was the one of the 19-1.
I'm aware.
Sometimes it's a good thing to be the 19-1. But anyways, I was on the board of one of the dispensaries for I think 6 years. I know way more than I should know about the business aspects of the nonprofit thing. I also sent 2 kids to college in Colorado, so I know how bad a system can be. My concern is this, and I didn't really ask it very well of the last witness from the previous bill, but what I'm concerned about is this: when we created this law in this state, we went to great lengths to not make the same mistakes that other states made.
I'm sorry, can you clarify which bill? You said when we created
When we
this
created
bill.
the statute that created the alternative.
program.
Yeah, the
Okay,
program, exactly. and I was very proud the way that our state did that. My concern is this: these dispensaries, as was noted, have really, borne the lion's share of creating a really responsible program, but their profit margins aren't that great, and little things can make huge negative differences for them. And what I'm concerned about is you're creating competition here that could undermine them financially, and I'm just curious what your thoughts are about that.
That's a great question. The ATCs are behind this because, yes, people will grow product at home, so they're not going to be buying it from the ATCs, but the ATCs will be providing, some of them will be providing seedlings. They sell those. They don't just give those away. They're going to perhaps be providing seeds. Again, that's something you buy. If you're serious about growing at home, you need equipment. And I talked to a fellow from Maine who is growing in his home, and we went through the equipment. And for him to do a startup, a 4-foot tent is about $1,000 worth of equipment to buy. So, the dispensaries could sell the equipment. I mean, that's another whole avenue. This doesn't shut down business. This opens up another whole avenue of potential business for the ATCs. Plus, there's education, and we're going to need private consultants that are going to work with people to show them how to grow. So that's going to open up businesses for private consultants. So I don't see it as harming. I see it as enhancing. You going to vote for it now? I said, you're going to vote for it now? No, don't answer.
Representative Shapiro.
Thank you, Mr. Chairman.
Thank you.
What is the thinking behind the 3 mature plants, the 3 immature plants, and 12 seedlings? What happens to the other 9 seedlings when they're ready to be immature plants?
Not all seedlings make it to adulthood.
Just that they
Yeah.
won't all be viable.
Yeah, I mean, it's kind of sad, but not all of them.
Yeah, really.
Not all of them make it.
They have
So
to be
so
snuffed
if
out or given to somebody else.
they
or
would have to be snuffed out or taken care of
Set.
humanely.
Other questions? Seeing none? Okay, thank you.
Thank you. And this is my last one, so
Oh, okay.
thank you very
We're
much.
going to miss you.
It's been a pleasure.
Also signed up to speak is Michael Holt from the Department of Health and Human Services.
Thank you, Mr. Chair, members of the committee. Thanks for the opportunity to testify on this bill. My name is Michael Holt. I'm the administrator of the Therapeutic Cannabis Program within the Department of Health and Human Services. The department doesn't have a position, doesn't take a position on this bill, but it unquestionably will benefit patients due to increased access, increased strain availability, and lower costs. The expressed concern about home cultivation generally is about the increased potential for diversion. However, this bill has been circulating for years. It has been improved every year to try to accommodate those concerns. This is a modest proposal, especially in the terms of the number of plants, and has many, many safeguards and guardrails. Representative Thomas mentioned many of them. I'd just like to highlight them again in a short list so that we can hear altogether the guardrails in place with regard to this legislation. It allows a small number of plants. Either the patient or their caregiver can cultivate, but not both. If the caregiver cultivates, then that caregiver can have only one patient instead of the typical 5 that they are allowed. So there's no business model here. The location must be at the person's residence. It can't be in a separate location in a warehouse or an industrial space. It has to be at their residence. The location must be reported to and registered with the department. The location must be out of public view in a locked and enclosed space with a size limitation. A landlord can prohibit cultivation on leased property. The department is authorized to share the registered location with local and state law enforcement upon receipt of a sworn affidavit. The ATCs are allowed in this bill to provide seeds and seedlings to patients, so there is an easy, accessible source for this. Independent testing labs are allowed under this bill to accept samples from patients and caregivers for testing for cannabinoid profile contaminants. And the department has the authority under this bill to revoke the cultivation privilege for any person for violation of the law or the rules. In addition to all those safeguards in this bill, the current law establishes strict, severe penalties for any diversion by patients or caregivers to any unauthorized persons. Up to 7 years in prison and up to $300,000 in fines. As Representative Thomas said, there's no incentive for a patient in this program to divert their cannabis. Lastly, I would say that the department has no problems operationalizing this bill. I'm happy to take any questions.
Representative Cushman.
Thank you, Mr. Chairman, and thank you, Mr. Holt, for being here. I just wanted to kind of understand the ability to disclose the location to law enforcement upon a presentation of a sworn affidavit. Can you delve into that a little bit more for me?
Yes, this program is a medical program. The information that the department has with regard to patients and ATCs is protected by HIPAA. We're not allowed to share any information from our confidential registry with external parties outside of a court order. However, there's one provision that does allow the state, the Therapeutic Cannabis Program, to release limited information to local and state law enforcement, not federal law enforcement, but local and state law enforcement under certain conditions. One of those conditions is so that local and state law enforcement can verify that a patient is in fact a patient. If there's a law enforcement encounter and the patient the person claims therapeutic use of cannabis, local and state law enforcement officers are allowed to contact the program, and under those certain circumstances and an intake sheet, we are allowed to verify whether or not that patient is in fact a patient or whether they're on the registry or not. There's the second provision with regard to our release of information is that upon receipt of a sworn affidavit affirming probable cause that cannabis is possessed by a certain person or at a certain location, again, the department is allowed to confirm whether or not that person or location is a registered patient. And the additions in this bill would extend that allowance for us to provide information to local and state law enforcement if that registered location for cultivation is in fact a registered location for cultivation reported to the department.
Thank you very much.
Other questions? Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. Just to be clear, my concern always has been reliability of product. So if I understand correctly from testimony we've heard for the previous bill, that if I own or I have a dispensary, I have to submit my product for reliability of product. But if I have my own homegrown thing, I can, but I don't have to. Is that correct?
That is correct.
So why
Currently, patients are not allowed under state law to go to the single independent testing lab in the state to have product tested. The state law does not allow that lab to accept those samples from any entity except the 3 licensed ATCs in the state. Under this bill, that provision would be expanded so that the testing laboratories can accept those samples from patients who are interested to know the cannabinoid profile, how strong, how potent their products are, and whether or not they have been grown with any contaminants in them. But you are correct to say that there's not a requirement for them to do so, and that would be I think that would be a difficult provision to enforce.
Follow up.
I totally understand that, but we're talking about a medicinal product, not a recreational product. And in medicinal products, we expect some amount of reproducibility of what the substance is, and we are expecting that of the dispensaries, but we're not expecting that of the people that are going to grow it at home. Is that correct? So in other words, they don't have to test it if they don't want to.
That's correct.
So we don't have the same level of expectations for them that we do of every other pharmaceutical product in this country.
Is that a question? I mean, I think you're
Yeah,
right.
functionally it is. So I'm just asking, am I wrong when I say that?
I don't think you're wrong. No.
Okay. Thanks.
The issue is related to strain availability. The ATCs are only growing so many strains. The cost certainly, which is a huge barrier as we've heard all day. And the relative merits of those issues compared to the reproducibility of a specific strain, time after time after time, is one that is a consideration before this committee. So.
I'm not being mean. I like you. I like you too.
Okay. Representative Merchant and then Representative Shapiro.
Thank you, Mr. Chairman, and also thank you for taking my question, Mr. Holt. We've talked a couple of times about the ATCs and the profit margins they have are relatively thin. Can you speak or give me some guidance here how this may impact the ATCs themselves? Are we in one way saying that we're allowing people to home grow because it's cost effective, which I understand? Can you speak to at least the possible impact that's going to have on the ATCs themselves for the people who decide not to home grow? Or if they don't have ATCs, does that force everybody to become a home grower?
Well, that question would be better directed to representatives of the ATCs themselves. However, I will share that historically, starting last year, all three of the ATCs were publicly in support of this legislation. Secondly, it is assumed that most patients don't have extraction laboratories in their homes. And so there's a wide variety of products that the ATCs sell, cannabis-infused products, that would not be reproducible at a home level. And so while it may impact the ATCs somewhat, it is not expected that everyone will grow their own. It is not expected that those who do grow their own don't go to the ATCs to purchase products that they can't make themselves.
Thank you.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. In terms of individuals who are growing their own plants, then having it tested, not knowing anything about this modern agriculture of cannabis and not knowing anything about testing, given that these are a limited number of plants, which I assume would be a somewhat limited amount of cannabis or product, as it's called. I don't really like using that term, product, but that it would be a limited amount of product. Is the amount needed for testing, would that de-incentivize testing? Would it be a significant amount that you had to give to a lab?
No.
Okay.
It's a very small amount that the lab requires to test potency.
So that, there'd probably be some cost, but it wouldn't, the amount that you were having to not use but give to a lab wouldn't be
The sample size required by a laboratory to test for potency and contaminants should not serve as a barrier if someone was interested in having their product tested.
Thank you.
Did I see a hand up here? Representative McLean, did you have your hand up earlier? No? Okay. Anyone else? Okay. Thank you.
Thank you.
Also signed up to speak is former Representative Jerry Knirk.
Okay, sorry. And you do have my testimony. I distributed it before we started this session. So once again, for the record, Jerry Knurk, Chair of the Therapeutic Cannabis Medical Oversight Board, and I'm here to report what TCMOB feels about this particular bill. TCMOB does support HB 1231. We do that because we think it will help our patients and caregivers with affordability, accessibility, and the availability of specific strains. Excuse me. I would actually expect that only a few patients will actually do home cultivation because it is somewhat complicated and takes space. Going back 2 years ago, TCMOB held a listening session for feedback from patients about the program, and the primary concerns were affordability of product, accessibility of ATCs, and availability of specific strains needed by a patient to treat their symptoms. The reason the strain matters is because different cannabis strains have different cannabinoid and terpene profiles, and that they therefore have different effects upon the person's symptoms. Several patients felt that allowing home cultivation would at least partly address these concerns. At its January 2023 meeting, TCMOB reviewed the prior bill, HB 431, and voted unanimously that it agrees with the concept of home cultivation of cannabis, both by therapeutic cannabis patients and by caregivers. Then we revisited it in October of 2023 to review the bill for this year, and we agreed to continue our support for the bill. We did note that there were some concerns voiced last year that home cultivation would somewhat diminish the knowledge of the cannabinoid content, as we've just been discussing, compared to the products that are available in ATCs. We agree that this is likely to some degree, but we note that the bill does allow, again, a home cultivator to submit their cannabis to a lab for testing. And this, again, is important to know the cannabinoid profile and to make sure there's no contaminants. But again, a person growing their own can also be very careful about contaminants by using proper soil and so on and so forth. The bill also allows ATCs to provide seedlings with known relative cannabinoid content to assist patients in growing their specific strain they need for their condition, and seeds with known target cannabinoid content are available and federally legal. Now, the other thing I think is that if, in terms of safety, if somebody is growing their own and they're going to start using from their first part of a batch, they'll probably drop their dose just a little bit, just to kind of see how it affects them, to make sure in case it perhaps has a little higher THC than they expect. But it's also important to realize, and Representative Merchant did talk about testing, or I think you're the one, about pharmaceuticals. Very true, but if we think about it, generics have a plus minus 20% window of acceptability. And, with some people, is that not correct?
That was a few years ago. They've changed it now to plus 10%.
Okay, but even then, that means you could get one batch here, and the next time you refill, it might be 20% more because one was 10% down, the other's 10% up. And I think some of us may have noticed occasionally a little bit of difference in the response to a medication. Anyway, I do have a couple of specific points I want to express. At this point, I'm now speaking for myself, not for TCMOB, because we voted on the concept of home cultivation, but we did not really go into the weeds to look at the specific language of the bill. This bill really has robust protections with respect to limitations in the number of cannabis plants and the registration of cultivation sites that have to be enclosed and locked. And these protections should make home cultivation safe, controlled, and should satisfy the concerns of law enforcement. I disagree with one issue. On page 5, lines 13 to 18, it allows home cultivation for potential qualifying patients who have not yet been granted a card. This could be an enforcement nightmare, and I really feel a patient can wait for the very short time until they have their card.
Could start wrapping up.
Yep, I'm just about at the end. In fact, only one thing now to respond to something earlier, and that was the fate of HB 431. I must say that it went to a Senate committee which has historically been hostile to therapeutic cannabis, and I think that's why it was moved to die on the table. So we urge you to pass 1231 and allow home cultivation, the reason being, again, to help patients with affordability, accessibility, and availability of specific strains. Thank you.
Thank you. Questions? Representative Shapiro.
Yes, I know there's been, thank you, Mr. Chairman. I know there's been a lot of talk about testing and analyzing whether the amount of therapeutic chemicals And there's also talk about contaminants. And I'm wondering if there's something specific about cannabis that makes the issue of contaminants extra important. Because I know you're a serious home gardener, as am I, and we might do soil testing once in a while, but we don't test every vegetable we grow before we eat some of it.
Yeah. Well,
So is there something specific about the way we would ingest cannabis that would make the contaminants a more significant issue?
Well, first of all, there's the issue of heavy metals. And so, for example, when we do a soil test, we usually, they automatically do a lead test, and you can also do a heavy metal panel for cadmium and other things as well. So if somebody is using just soil from their garden and they happen to be in a place where there's a bunch of lead, that could be a problem. But again, if you use your brain a little bit and you're a gardener, you know not to do that. The other thing is mold. Mold can be a problem because this is a plant, and that's actually something that can occur even more in terms of it can occur in how you grow it. I don't know about any of you, but I have a greenhouse, and I do sometimes have problems with mold because of humidity and so on and so forth. So one has to be cautious about that. You can often see it, but sometimes that may be a little bit difficult to see. If storage, of course, you could still get mold if you're storing it in a moist fashion. But there are basic issues about primarily heavy metals, and mold are the major things that we look at as far as contaminants. So those are nothing unusual. And as far as, we don't test every plant. We sort of do. We take a bite of that tomato and go, ugh, that didn't turn out so well. And with this one, because you are either inhaling it or taking it, it is important that you have a rough idea. But again, you can get a seedling with known cannabinoid contents, or you can get seeds which have at least a range that will tell you what it's going to grow.
Other questions? Representative Nagel.
Thank you, Mr. Chairman. Thank you, Honorable Dr. Knirk. I just have a quick question that I don't know if you know the answer, maybe a dispensary person does, but I mean, to visit one of these dispensaries is eye-opening. I mean, it was pretty amazing. And I'm just curious, it would be totally difficult for everybody here to go visit one, but I would assume somebody must have a video or something about cultivation, the process, what did they go through in the dispensary setting? Do you know if that exists?
I'm sure there probably are a lot of videos. I know when I've looked up specific issues about lighting for growing greenhouse or whatever, you get lots of hits that have to do with cannabis growing for some reason. But I mean, I think people would be able to find issues. And again, if you remember, these plants are kind of big too, so it's going to be a little bit tricky for a lot of people to grow them, and they have to be enclosed, and they can't be out in your garden. So. But they could perhaps give you more, but I'm sure there's some videos. I haven't done a Google search, but I bet you there's some.
Other questions? Okay, seeing none.
All right, thank you very much.
Also signed up to speak is Dr. Joe Hannon.
Hello again. Thank you. Last time today, I promise. So I try not to repeat things that were already said. We heard a lot of great testimony so far. When I was here, I was on the Commerce Committee. We did a lot of the alcohol bills. I sat on a commission to study that and some other commissions. I was also, like I said, the study commission for cannabis. And home grow was always a topic that came up when on the first commission, and even this one it got mentioned but didn't really get looked at. We're talking about home grow for medicine. We're not just, this isn't recreational, nothing else. We all know that. But we allow home brew, and I'm sure most of you are aware, for beer and wine of less than 6% alcohol by volume. A single individual can have 100 gallons a year, every year, and stockpile it. So there's no possession limit. You can have, after 10 years, you can have, 1,000 gallons of it. If you have a spouse or another adult in the house over 21, you can grow up to 200 gallons maximum per household. That's equivalent to 6 beers a day. So I can have if my wife and I wanted to brew it, and we don't, but if we did, we could have a 6-pack every night just from home brew. Now the regulations are 0. There is a limit on how much alcohol you're allowed to have and how many gallons. There is no license. No one has to be notified. There is no testing requirement to make sure it's only 6% or less. I mean, it could be 7% accidentally. There's never been a reported problem. you just can't sell it. And I haven't seen anything in the news. If it's happened, I'd love to hear about it because I've testified about this before. It's a non-issue. Allowing a small amount and 50, 100-foot canopy, that is a very small space if you've ever seen some of these grow facilities. I've killed cactus. I don't plan on doing this. It's not easy to do for everybody, but we're also not talking about manufacturing a complex pharmaceutical product necessarily. I mean, there are complexities in the cannabis, field, and they can vary, but you're getting cannabis of some form. You're not having to worry about, getting insulin from a dog, all this other stuff. There's so many things you need to do. Also, I'm legally allowed to grow any number of poisonous substances in New Hampshire in my garden. Legally, no regulations whatsoever. There's mainly 2 poisonous plants in New Hampshire, poison hemlock and pokeweed. They are indigenous to New Hampshire. You go and you can probably find them somewhere. They're here. But I can grow black cherries. Apple seeds contain cyanide. Too many can kill a horse. When horses eat lots of them on the ground, they can cause problems there. But, foxgloves, we get digitalis, which is a heart medication from foxglove. I can grow that if I wanted to. No regulations, no license whatsoever. Don't have to tell anybody at the state. No offense. So the lily of the valleys, angel's trumpets, morning glories, there's any number of plants, oleander, some beautiful plants. Many of you probably have had them in your gardens or seen them in gardens or at flower shows. They could kill you. Cannabis will not kill you. I mean, it's possible if a bale of it falls on your head, there may be a death related to it. When it happens, I'm sure it'll be news. But like I said, there's no requirements for testing in that. And if we're looking at, we keep hearing in other, I don't want to talk about other bills and committees, but they talk about legalization like alcohol. If you're going to do it like alcohol, this is nothing like alcohol. Alcohol will be if this was like that, you'd be able to have home grow for any reason. So I think I just want you to legalize gardening, fully legalize gardening. That's it. It's very simple. It's the only thing you really can't legally grow, except you can even grow other really poisonous, narcotic things, but you can't do this.
If you could wrap up, please.
Yes. Last thing, the physical and mental benefits of gardening. We talked about anxiety earlier being a big thing. Thank you. Sorry. I didn't tell you I was ready for 3 minutes this time. Sorry. But the benefits of the mental health and the physical benefits of gardening are well known. They're well documented in research. Just being outside or the act of gardening has been beneficial. And if anxiety is one of the leading reported reasons that people are using this, get outside, enjoy yourself, have it more therapeutic just by doing that. So there are health benefits other than environmental and cost. So please pass this bill, and then we can stop hearing about it for the next 12 years or so, 15 years. Thank you.
Questions? Seeing none? Okay, thank you. Also signed up to speak is Bill Bright from the New Hampshire State Police.
Good afternoon, Chairman. Good afternoon, members of the committee. Thank you for hearing my testimony. My name is Bill Bright. I am a major with the New Hampshire State Police. I currently oversee the Investigative Services Bureau, which includes all detectives for state police. I came to speak to you today in opposition of this bill, mostly because I just would like the committee to consider the effects that it may have on law enforcement to enforce some of the regulations that are in this bill. The difficulty that we may have determining who is legally able to grow. I know there's a portion carved out in this bill that says that we could submit a sworn affidavit to get some of that information, as well as who is, if they are legally able to grow, are they within the regulations? And if they're not, does that then turn into a criminal investigation, or who is regulating that part of that determination in this law? The example I would give to you is that if we receive a complaint that somebody who is opposed to growing marijuana complains that they believe that somebody is illegally growing marijuana, we're obligated to go investigate that complaint. Once we get there, we may or may not be able to determine in a short period of time whether the person is allowed to be able to grow, which will cause some further steps for law enforcement to take, eating up resources that could be better used in other places. we would then have to determine whether or not, if they were legally able to grow, if they were within the proper regulations, and as I mentioned, if they are not, does that then turn into you have a patient who we are now criminally investigating for the possession of marijuana outside of what they are allowed to have. So I just think it is a difficult situation to put law enforcement in, to allow the home grow in this instance, where patients are able to get what they need from the therapeutic grow, authorized therapeutic grow facilities now. That is just much cleaner for law enforcement.
Okay, thank you. Questions? Representative Leon.
Thank you, Mr. Chairman, and thank you for coming with constructive feedback on this. I would be interested in trying to figure out specifically what you would need in order to make that determination ahead of time, because I know that typically when you're dealing with drug grows, those are probably the more dynamic situations as opposed to more of a wellness check. So I don't know if there's anything with checking with the department or if there's anything else that we can do to streamline this so that we're not denying patients this ability when it's appropriate, but we're also not putting law enforcement in a bad situation.
Yeah, so I think that in order to get the information, what the bill says, that we would need a sworn affidavit that we have probable cause to believe that somebody is growing marijuana. Just the word that we get from somebody that they think their neighbor is growing is not necessarily probable cause. So it would take some legwork to be able to develop probable cause to determine that, which is going to present some problems and some investigative work on law enforcement standpoint.
So as a
Follow-up?
sorry, as a follow-up, then would that make sense if we put into process that prior to pursuing a sworn affidavit, that you would cross-check with I believe we said that we already know the locations within the whole Therapeutic Cannabis Commission to make sure that if you were pursuing one of these, that you could confirm whether or not there was an allowed home grow operation at that address before pursuing further.
Well, I believe from previous testimony, I mean, this would fall under HIPAA regulations, which my understanding is that we would need to supply a supporting affidavit with probable cause.
I'll pursue that further with you because HIPAA allows a lot of movement of information.
I don't claim
between
to be an
police and
expert,
that.
so I probably won't be able to answer your questions intelligently.
Thank you.
Other questions? Representative Merchant.
And thank you, Mr. Chair. And also thank you, Mr. Bright, for taking my question. I hear the concern about law enforcement being sort of in a bind. You've got call to residents. You don't know whether the resident has the authority to grow, if I understand it correctly. If the department was to provide to the resident a document that's notarized and so forth that they could give to law enforcement that authorized them to do that, would that minimize some of the concern you have?
Well, I don't know that I can think of every situation that would be difficult for law enforcement based on, the result of this bill. So it's hard for me to, come up with a suggestion for what would alleviate. I think that it leaves open the ability to abuse the right to grow marijuana in a home grow situation, which I think is going to create problems for law enforcement, kind of no matter how it is set up in the framework of this bill.
Follow-up?
Thank you. And following up on the HIPAA concern, my understanding within HIPAA, law enforcement actually has some limited authority to the information within HIPAA. So therefore, you may have, as law enforcement, some limited access to that database to begin with. So I don't know if that solves the problem, but something you may want to consider.
Well, I don't know if finding this information would fall under those regulations and the allowances that we would have.
Other questions? Seeing none? Okay, thank you.
Thank you.
Next up, I believe it's Jim Riddle. from Hillsborough.
Thank you, Mr. Chair, members of the committee, Jim Riddle, Hillsborough. And I mentioned earlier that I do have a USDA hemp grower license. And in order to get that license, the first thing I needed to do was go to my local police station and be fingerprinted. Then I had to pay to have an FBI background check. Then I had to take online training from USDA. I had to set up a farm number with the Farm Service Agency and then do annual reports. And hemp and cannabis, it's the same species, Cannabis sativa. And before harvest, any crop has to be tested if it's over 0.3% THC, then it falls under cannabis regulations. Under my hemp, it gets destroyed, goes into the compost pile. But in case you don't know, the DEA officially ruled that any cannabis seeds and seedlings are technically hemp because they contain no THC. They don't meet that 0.3%. So DEA has officially determined that any cannabis seed, regardless of its genetic potential, is hemp. So just to be clear on that. I did also mention earlier that I'm on the advisory board of the New Hampshire Cannabis Association. I just wanted to let you know I led an effort working with the New Hampshire Farm Bureau and the Northeast Organic Farmers Association of New Hampshire to do a survey last fall of farmers in the Granite State to see, and this was more about legalization, but of the farmers that responded, 87% supported legalization and 78% of the respondents were interested in becoming licensed growers. But as it relates to our discussion right now, the most surprising result, the question we asked about support for homegrown, that was the strongest response we got. 89% of the respondents support allowing New Hampshire residents to grow 6 to 8 plants for home use. And that wasn't, specifically only limited to medical, but there is certainly an interest and support in the agricultural community for allowing home grow. I think something here that's really an advantage of focusing on the people with medical cards, and that's the first thing I would do if as an officer was making an inquiry, is show my card. And then if I have gotten a permit to have a few plants, I would probably have an additional paperwork showing that I can have these plants. But these are registered registered people. All the people that have medical cards are already in the system. You know who we are, and we would have to apply further to grow a few plants. Like it was mentioned, seeds are hemp. They can be sold through the mail right now, interstate. Anyone in New Hampshire can have access to thousands of strains through online companies. So they can tailor that, and yeah, they may send it to a lab for analysis, but they might just try it and adjust their dose to what they've grown. But it will really help both reduce costs, improve access and availability. And I just close by echoing something that Dr. Hannon said. Just growing cannabis, growing hemp, growing plants in and of itself is therapeutic. You develop a relationship, you're caring for something. And that alone, I think, should be taken into consideration. Thank you.
Thank you. Any questions? Seeing none, thank you. Also signed up to speak is Dr. Riley Kirk.
Thank you to the chair and the rest of the committee. My name is Dr. Riley Kirk. I have a PhD in pharmaceutical sciences, and I specialize in the chemistry and pharmacology of cannabis. I also hold a USDA hemp grower license, and I am an advisory board member for NHCAN. I'm here to express my overwhelming support for HB 1231 to allow medical cannabis patients to home cultivate the plant, cannabis sativa. I believe cultivating a plant medicine like cannabis should be a right, not a luxury, especially for the safety and efficacy of cannabis for dozens of medical conditions. Kissack's iron triangle of healthcare consists of 3 pillars: access, cost, and quality. This is a well-studied phenomenon in healthcare because no system has ever been able to improve all 3 of these simultaneously. There is always a trade-off of at least one of these factors. The ability to homegrow medicinal cannabis is one of the only examples of a tool that effectively can provide all 3 of these in healthcare simultaneously. For access, yes, we currently have a medical program in the state, but for everyone who lives in the largest county, Coos County, like myself, we are over 1 hour from the nearest New Hampshire dispensary, some people as far as 2 hours away. This is not accessible, and this is not practical for residents of New Hampshire. The cost of cannabis at a dispensary is often far outside of what many disabled medical patients can afford, making it again inaccessible as the medicine is not currently covered by health insurance here in New Hampshire and many other states with medical programs. The quality of the medicine also matters. Many cannabis patients prefer specific strains with unique chemical profiles that can be difficult to lock down in dispensaries as the strains are often being rotated to fit consumer demand, and the available options may not fill the niche of what they're looking for their desired therapeutic benefits, or they prefer specific metrics like height and moisture content that aren't allowed to be variable via dispensary avenues. Some examples of this strain preference that we discussed earlier include people with ADHD preferring terpinolene-dominant strains, people with Crohn's disease favoring strains dominant in the terpene caryophyllene, and people with metabolic conditions preferring strains high in THCV, and the list goes on. Patients can have access to consistent, personalized, and effective medicine when cultivating at home and have the spiritual connection to their medicine as well. I know this isn't important to everyone in this room, but for people like me who prefer to use natural products and find value in cultivating their medicine, the spirituality component is an undeniable and core value for our community and greatly contributes to the healing process and intention while medicating. In my opinion, it is difficult to see negatives to the ability to grow this medicinal plant. It does not come down to the safety of New Hampshire residents. It comes down to control of where we get our medicine and who financially benefits from us using this medicine. This contradicts everything about the live free or die mentality that emphasizes, and it does emphasize everything wrong with the current healthcare landscape. And if we continue to restrict home grow, we should reconsider the slogan live free or die, or I guess we're all supposed to die. To Dr. Joe Hannon's point, I'm a natural product chemist, and I'm allowed to
Please
legally
start
grow.
wrapping up.
What was that?
Please start wrapping up your testimony.
Okay, I'll wrap up. To Dr. Joe Hannon's point, I'm a natural product chemist, and I'm allowed to legally grow dozens of plants that are toxic in small doses, including the opium poppy that produces codeine and morphine, the castor plant, which produces ricin, Atropa belladonna, foxglove, and so many more. I have yet to hear a solid argument against home grow other than the fact that some people just don't like cannabis. I don't think this is a just answer, and it should be a right to cultivate the medicinal plant and to be in control of the medicine that we're using. Lastly, and continuing the conversation about the level of expectations for consistency of products, a reminder that medical patients will still have access to medical dispensaries and indoor cultivated products if they choose that, or if they want extremely consistent products, they can also choose to cultivate cannabis indoors in their home to have that consistent profile. Thank you, and I will take any additional questions.
Any questions? Okay, thank you. Also signed up to speak is Alicia Bennett.
Right. Thank you for having me. I know it's been a long day for us all, but I will breeze through this. So my name is Alicia Bennett. I am fully supportive of Bill 1231, which would permit qualifying patients and designated caregivers to cultivate cannabis for therapeutic use. We've heard a lot of great testimonies in support of this bill today, and I think one thing that makes mine unique is that I am a patient of the program, and this is something that I've wanted for a long time, and if this bill were to pass, I do plan on cultivating at home. Currently, I work as the education supervisor for Granite Leaf Cannabis. However, today I'm here speaking as a patient. Just to give you some quick background, my experience with medical cannabis began when I was a student at Texas A&M University, studying horticulture with a focus on medicinal plants and education. While I was a student, I was battling a rare form of cancer that led to the amputation of my right arm and part of my chest wall. Cannabis was more effective for treating my severe pain and the side effects of chemotherapy than any of the other medications I had been on. In 2018, when I was finally in remission, I moved back to New Hampshire to have access to therapeutic cannabis. And I've been on the therapeutic cannabis program for over 5 years. And in that time, I've used it to manage my chronic pain, phantom limb sensation, insomnia, nausea, PTSD, anxiety, and depression. I believe that this bill will benefit therapeutic cannabis patients like me in New Hampshire. I have several other points that other people had brought up already, that legalizing home cultivation will help people like me with affordability. It will give people that do not have easy access to dispensaries more opportunity to grow from home and to not have to travel as far to get access to products. And although the dispensaries do offer a wide selection of products, there are certain cultivars that work well for certain conditions. I know there's a few that work well for me that none of the dispensaries in New Hampshire currently offer. It's kind of like you think of apples. There's some apples that I really like you can't always find in the store, and I would grow them at home. I'm a very avid gardener. I love horticulture. I love plants, and I did love that the point was already brought up that I do actually have a couple of plants that are in my garden, and I know that they are deadly and they can be used in certain ways that could be harmful or kill someone. However, cannabis has never been reported to kill anyone, and it has so many therapeutic benefits, which I think we've all heard enough about today. Cannabis is one of my favorite flowers, and as a gardener, I would really love to grow it at home. This is something that I think can be done safely and responsibly, and legalizing home grow will benefit the therapeutic cannabis patients in New Hampshire. Thank you for listening, and I'm happy to answer any questions you have.
Thank you. Questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Matt Simon from Granite Leaf Cannabis. I got it right that time, right? Granite Leaf?
Very good. Okay, again, thank you, committee. For the record, Matt Simon, Granite Leaf Cannabis. We support this bill, and I will avoid repeating the many excellent points that have been made. I agree with them. I'll try to say something new. So 10 years ago, I and a lot of other folks were in this exact committee. We were wearing stickers that said, "Patients, not criminals, support HB 648, I think it was." We had the same stickers made several times for different bills, but the slogan, "Patients, not criminals," was the argument. At the time, it was a crime to possess or cultivate cannabis, and we were arguing that the legislature should make a narrow exception for qualified patients, which ended up happening in 2013. I would argue that this bill is consistent with that original sentiment. So we are sometimes talking about healthcare policy when we talk about therapeutic cannabis. We're sometimes talking about criminal justice policy and civil liberties and the intersection between those and healthcare policy. And I'll suggest, Representative Nagel, you're far from the first clinician who has found some tension and difficulty between those two concepts. If we were talking about approving homegrown cannabis through the FDA or some process like that, we wouldn't do it for all the reasons that have been brought up. But I would argue we are at the intersection between healthcare policy and criminal justice, civil liberties policy. If patients choose to grow their own, and I will tell you that I have known patients who choose to grow their own in New Hampshire since 2007-8 when I started doing this work. I know several patients who have moved to other states because they got tired of fearing law enforcement and cared so much about this, they were willing to move elsewhere. That includes my good friend Ted Wright, who was a co-sponsor of the bill in 2013. He went on to sponsor this bill several times, failed, and then moved to Maine out of frustration with our not very live free or die policies. So I would say from the perspective of the, I can't speak for all the ATCs, I'll speak for our leadership team. We all view this as a civil liberties issue. We are not looking at this at all as a bottom line issue. It is not going to help our bottom line. It may hurt it a little bit, I'm not sure. We could sell seedlings and make a little bit of money. Probably the biggest benefit would be that it would give patients who feel strongly about home grow an incentive to register for this program rather than moving to another state or simply growing on their own without being a registered patient. So I think it would be healthy for the program as a whole. But the way we look at it, the way I'm looking at it, current law is if you manufacture more than 1 ounce of marijuana, I say marijuana because I'm referring to 318B, the criminal code. If you manufacture more than 1 ounce of marijuana, that is a felony in this state. If you're familiar with the New Hampshire Constitution, Part 1, Article 18 says all penalties ought to be proportioned to the nature of the offense. In this case, the offense is gardening, and I would argue that it is inappropriate to have a felony penalty associated with cultivating cannabis based on everything we've heard today. I'll answer one question that came up. Somebody asked why 12 seedlings if you're only able to grow 3 plants. So I think that presumes that somebody's growing from seeds. If you buy seeds, okay, so you can buy seeds that have been feminized and you have pretty good certainty that they will come up as female plants.
Start wrapping up, please.
That's my last point, Mr.
Okay.
Chairman. But if the seeds are not feminized, they have a 50% chance of being male or female, and male plants are not particularly useful for therapeutic purposes. So the idea is at least some of your plants will be female, and you'll be able to select the seedlings that show female characteristics and grow those as your mature plants while destroying the others. Happy to take any questions.
Any questions? Seeing none, thank you very much.
Thank you.
Also signed up to speak is Tatiana White.
Can you push the button on your microphone?
Thank you so very much. Good afternoon, Chairman and members of the committee. My name is Tatiana White. I am an advisory board member of the New Hampshire Cannabis Association. I hold a USDA hemp grow license, and I'm a founder of the Rich Hemp Wellness Company based out of Littleton, New Hampshire. I stand before you today to voice my strong support for the home grow bill introduced by the Representative Thomas. The ability to cultivate cannabis for therapeutic purposes is more than just a matter of convenience. It's a fundamental aspect of compassionate healthcare. As a wellness business owner and a fibromyalgia patient myself, I meet many individuals with various chronic health issues. And speaking of myself, fibromyalgia comes with a bouquet of symptoms such as chronic fatigue syndrome, whole body pain, insomnia, anxiety, depression, chronic migraines, and many, many others. For many patients such as myself, access to dispensaries can be challenging due to geographical, financial, or physical limitations. There are times when my fibromyalgia symptoms are so severe that driving to a dispensary 1.5 hours away is simply not feasible. Home cultivation offers a viable alternative, ensuring that such individuals such as myself have uninterrupted access to this medication. Cannabis cultivation at home empowers patients and caregivers to have greater control over their treatment. It allows for the customization of cannabis strains to suit specific medical needs, potency, and personal preferences, which is often not possible with limited dispensary selections. This tailored approach can lead to a more effective symptom management and an overall better quality of life. Moreover, home cultivation can be a more cost-effective solution for those who cannot afford it. The costs associated with purchasing cannabis from dispensaries can be prohibitive to some. I personally met many patients who just simply cannot afford to purchase enough cannabis from dispensaries for themselves. And allowing at home can significantly reduce this financial strain for these individuals. So as others mentioned, that it makes it affordable, it makes it easier to access this medication. And also, I just want to add a personal note as well that as a USDA licensed hemp grower, when I received my license, I contacted our local police department to let them know that I have a license to grow hemp, and I told them where I'm going to grow it. Maybe therapeutic cannabis home growers could possibly do the same so that local police knows who legally grows under their jurisdiction. In conclusion, I urge the esteemed members of this legislative body to support Bill HB 1231. By passing this bill, you are not just legalizing an activity, you're providing relief, autonomy, and dignity to countless individuals who depend on therapeutic cannabis for their well-being and health. Thank you for your attention in this crucial matter. Do you have any questions?
Thank you. Any questions? I'm seeing none. Thank you.
Thank you.
Chair?
Oh, yes.
15 seconds to retract a statement I made that was an error in my testimony earlier. It'll only take 15 seconds.
Okay, I'm going to time you. 15
That's fine.
seconds.
I think those of you who know me know that I don't like making errors, and I sure don't want it to be out there when I made it. When TCMOB reviewed this bill, we reviewed the LSR version. My objection to the bill, which was stated in the second page of my testimony about page 5, lines 13 to 18, that is no longer, it does not have to do with cultivation. So what I said was incorrect, and I just wanted to retract that. Thank you.
Okay, thank you.
Exactly 15 seconds.
Wow, he's got an innate sense of timing. Okay. A professional testifier. Okay. Also signed up to speak is Heather Stockwell from Rad, New Hampshire.
All right, is this on this time? Somebody left it on for me. Thank you.
Yep, it's on.
Thanks so much for hearing from me. I do think that most of the people that have spoken already have spoken about a lot of the things that I was thinking about saying, but I've heard a lot from ATCs and or from that sort of perspective, if you will, and I'm really here about the caregiver perspective. My husband is a licensed caregiver in the state. He's also a USDA hemp license grower in the state, and we've testified about this many times in the past. I fully support this bill. I'd like to see anyone be able to grow their own, not just caregivers. I think this is really reasonable, and one of the things that Matt Simon said before was about the different policies in different states, and that's something that I've been really looking at. Because I also have a horticultural background. I've worked for organic farms, and I currently grow houseplants in my house, and hope to someday, and maybe in my retirement, have some sort of greenhouse business. It is very therapeutic for me. There's also other qualities about growing indoor plants where your air quality is better, et cetera, et cetera. Some of those differences, for instance, Massachusetts, if you are a licensed caregiver, their policy is that you can maintain a 60-day supply for each patient. It does not mention seedlings in the web page that I was on, and maybe that's because those seedlings are not counted on some level because they are considered hemp. And in Maine, also another bordering state, one that we have considered moving to, as we are also hearing people testify about, and I've lived here for over 50 years. I want to make that clear. You can grow 30 mature plants, 60 immature, and there's no limit on seedlings. So we're asking for a very small amount here. I think nationally the average is probably around 12. This is super, super reasonable. I'd like to see something a little bit different, but I think this is a great start. See how it goes. I sympathize with what the state police said, but on another level, I understand that there are provisions that allow them to check. So I feel like that's kind of a non-issue. And another grower just testified that they reached out to their local law enforcement to tell them. Not everybody wants to do that, maybe because they know how their law enforcement might respond to that call. Or they might be targeted in other ways. so I think that's up to individuals how they want to proceed. Um,
Please start wrapping up.
okay, yeah, I guess that's maybe really it. I think this is so reasonable that it doesn't seem like a really big lift for the committee to support this bill wholeheartedly. I think there's plenty of structure around it for patients and their caregivers. For me, it's really about economic freedom. Also, I know I talk to people about their health care all the time, and a lot of people can't even afford their health care, let alone being able to go to an ATC and afford the prices there. So this would allow people to grow this on their own or have their caregiver grow it for them for maybe a fee, but it would be a very nominal fee to get the medicine they need when it's something that is not supported by our current healthcare industry or insurance industry.
Thank you.
Thank you.
Any questions? Representative Merchant.
Thank you, Mr. Chair. During your testimony, you talked about the compensation as far as with patients and caregivers. If I look at page 2,
Yes, I read that.
on line 26, 27,
Mm-hmm.
it says not to exceed $500 per calendar year. Is that per patient? Or is that, no, what I'm trying to get to is that if I'm
I'm not
designated
sure because I
caregiver-
didn't write this bill. So,
Okay, so the way I read it, we could possibly have somebody taking care of 10 patients.
no. Our state and actually Massachusetts, Maine, and
Is 1 to 1?
and New Hampshire is five patients for a caregiver.
Where does
fi-
it say that?
It is where it says, let's see, page 11, line 11, says not to exceed 5 qualifying patients in the therapeutic use of cannabis unless you live more than 50 miles away from an ATC or the patient.
So if I'm in North Country, if I understand this correctly, I'm more than 50 miles away, that doesn't apply.
What are you saying doesn't apply?
If I'm more than 50 miles away,
Then are you a caregiver
Yes.
or a patient? You can have 9 patients if you are more than 50 miles away and your patients are.
thank you.
I think there are some things that could be clearer. I'm a little bit unclear about some of the wording too. So I'm happy to, go for it.
Representative Cushman.
Thank you, Mr. Chairman, for indulging me. In section 9 of the bill, it's on page 3. If you look at I on line 21, the designated caregiver's cultivation location where he or she may cultivate cannabis on behalf of a single qualifying patient who has not reported a cultivation location. So they can only, from what was said in the testimony earlier, I think this is where it's saying that only one, they can only have one patient.
Mr. Chair, if
So
I
they can only grow for one patient? Is that what you're saying?
That's what I understand. And I just want to try to get to is that for clarification, we heard from law enforcement the difficulty in trying to enforce this. I want to be sure that we don't add more difficulty to law enforcement to try to enforce it. That's all.
Other
Any-
questions?
Great, thank you.
Okay, thank you. No one else has signed up to testify on this bill. Representative Thomas.
Yeah, can I just add 2 points?
Sure.
Okay, thank you. Very quick. Not as quick as Jerry, but almost as quick. There was a question about educational material. I am actually going to be working this summer with some growers in Maine, and we're going to be videotaping and documenting exactly how to grow from seed or how to get from seed to use. So I'm working with somebody who we're going to do this for outside growing, as well as someone who is going to do this with me for inside growing. I would never put forward a bill that doesn't have educational material behind it. I'm a tech writer, a course developer, and an instructional designer. So education is my jam. And lastly, the other point that I wanted to add, in growing plants, you don't just use the bud for the flower. There's a lot of people that will take the leaves and put them in smoothies, just like you put spinach leaves in smoothies. There's a lot of nutrition in the leaves. There's cannabinoids in the leaves. It's a very beneficial plant. Thank you.
Thank you. Okay, with that, I have no one else signed up to testify, so I'm going to close the public hearing on House Bill 1231 and open the public hearing on House Bill 1171 and recognize Representative Murphy, the prime sponsor.
Sorry, did you put a card in?
No, Representative Murphy, we need a pink card from you also. Ah, you're hiding it. You're hiding it.
Thank you, Chairman McDonald, and good afternoon to honorable members of the committee. My name is Nancy Murphy. I represent the town of Merrimack, which is Hillsborough, District 12. Today, I come as vice chair of the commission to ask for your consideration and support for HB 1171, which will reestablish the currently existing Commission on Environmentally Triggered Chronic Illness. This commission has done great work since its inception, and as there remains a need, will hopefully be allowed to proceed uninterrupted so that it might continue that work. Though Representative Leon is a member, not every member here may be familiar with this commission. So I've handed out some documents for your review, which include a copy of the current commission statute created by SB 85 in 2019, the commission's most recent annual report, a bit of an overview about the composition, charge, and scope of the commission, and the most recent progress report from DHHS. As President Ronald Reagan said in his 1984 State of the Union address, preservation of our environment is not a liberal or conservative challenge. It's common sense. Over the years, we've learned that when we preserve and protect our environment, we protect human health and ecosystems. We've also discovered that when we fail to protect our environment, we compromise public health. Far too many New Hampshire citizens' lives have been altered due to a chronic illness diagnosis known to be associated with environmental triggers like PFAS, VOCs, MTBE, arsenic, lead, radon, cyanobacteria, pesticides, and other contaminants. Citizens are left to seek health care and incur costs for illnesses linked to such things as the products they use, jobs they do, air they breathe, water they drink, and soil in which their food is grown. In 2019, the SB 85 Statement of Intent read as follows. The General Court recognizes that nearly half of adults in the United States have at least one chronic health condition, and chronic diseases are responsible for increased healthcare costs. 70% of healthcare costs in the United States are for chronic diseases. Some chronic diseases are known or thought to be associated with environmental causes. According to the Centers for Disease Control, the state of New Hampshire has the highest rates of people with bladder, breast, esophageal, and pediatric cancer in the country. In addition, a double pediatric cancer cluster was identified in the seacoast of New Hampshire in 2014. Therefore, the General Court hereby establishes the Commission to study environmentally triggered chronic illness. It's one of New Hampshire's statutory environmental commissions, and though there's some overlap amongst the environmental commissions, each has a different and specific focus. You can see that on page 7 of the Environmentally Triggered Disease and Chronic Illness Commission handout. This commission is focused upon broad issues of environmental exposure, the systems necessary to identify and address environmentally triggered disease, and the work of the subcommittees within education, data, and the Coakley Superfund. The Environmentally Triggered Chronic Illness Commission is focused on conducting environmental health surveillance and improving coordination and collaboration between DES and DHHS to allow resources efficiently to reduce exposure to environmental contaminants and prevent disease. To that end, DES and DHHS have entered into a memorandum of understanding relative to data sharing and an operating procedure on how data layers can be shared between the two departments to identify linkages between environmental contaminants and health outcomes. Over time, it's hoped that the work of this commission can help lead to widespread public health benefits, including improvements in average life expectancy. When it was looking for a home a few years back, and on the advice of this committee, as to where to put it, the commission took on the task of creating a subcommittee focused upon providing education to clinicians relative to the PFAS exposure of their patients. Right now, that subcommittee consists of Dr. Patali, the New Hampshire DES toxicologist, Dr. Peg DiTullio, she's an advanced practice nurse practitioner, Geisel School of Medicine, Dartmouth epidemiologist, Dr. Megan Romano, and myself, a retired nurse, impacted community member, environmental public health advocate, and legislator. The Education Subcommittee continues to work collaboratively to provide education and training relative to PFAS and other environmental toxins to clinicians and other healthcare professionals with the goal to improve patient care. Going forward, the Commission still has work to do. We would like to further develop recommendations related to core topics: surveillance, reporting, communication, and capacity building. Members of the Health and Data Subcommittees have also determined a need to create a New Hampshire-centered database of environmental threats and environmentally triggered diseases based on the list maintained by the National Institute of Health until 2017. That work has just begun. Thank you for your time, attention, and consideration of HB 1171. I urge you to vote OTP to support and allow the Commission to continue its work. Thank you.
Okay, thank you. Any questions? Representative Palmer.
I have one. Last week, we looked at HB 1393, which is looking specifically at pediatric cancers and asking the State Health Improvement Plan to look into that as a bill. And I'm just wondering if this is a little redundant. I mean, so that's one part of this. The other part was I'm on that commission, and at our last meeting, I sort of brought up the idea that instead of having to have a bill for that, they would just do it. But I'm just wondering if, you know, to have two different commissions looking at the same thing, if that makes sense, or whether there should be a little more discussion there and or at least sharing of the data so neither one has to work as much.
Right, thank you for your question. The Commission on Environmentally Triggered Chronic Illness, when I talked about the overlap on the commissions, the difference between this commission and some of the others, and I think like the PFAS Commission, which is HB 737, and HB 485, which is the Seacoast Commission. This commission focuses on broad environmental issues and on systems needed to identify and address environmental diseases. Talking about the pediatric cancer, I mean, that's it's interesting that you bring that up, because one of a bill that we came before, I think it was HB 614, which was passed out of this committee and went to finance, was funded the kidney cancer study in Merrimack. That recommendation came from this commission. So it's widespread. It's not just about cancer. It's about natural contaminants. It's about particulate contaminants in the environment. And it's looking at, the whole state. It's not particular to, like, the PFAS Commission, the HB 737 is particular to Southern New Hampshire and St. Gobain. So there is some overlap, and I think possibly the State Health Improvement Plan. I mean, I think we often have presentations between commissions so that information is shared and we don't have to reinvent the wheel on some things. But we have presentations and ongoing collaboration with DES, DHHS. They're part of the commission, and when there is an overlap and there's information which would benefit any of the commissions, we join them or they join us, and I think it's been a great way to educate a larger group and move to make change where we can.
Thank you.
Sure.
Other questions? Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I just have a question because we were talking about the State Health Initiative Assessment Commission, and one of our big discussions the other day was, well, we're developing ideas, but how does this actually become real? I'm curious, like in your in this commission, whatever, how have you been able to make things become real besides just bringing attention to the problem that exists? So how do you bring change?
Thank you for that question. One of the things we do is, and I think it's in your handout, the charges of the commission are identified, and I think it's on this handout. It's got a list of the charges. On that, I think it's the second page of it. On part 3, it talks about the study that we're to look at, but also the things that the commission can do. And those are numbered. And what's listed there is the things that we have done. We've worked with DHHS around public health education, whether it was an issue of PFAS or lead or those things. Health provider education. We have so many health providers that we've seen being in Merrimack. We found that citizens had more knowledge of the issue than health providers, because years ago, that wasn't, environmental medicine wasn't the largest chunk of a medical education. And these are relatively new contaminants. So everybody's learning. And so the commission, the subcommittee has worked hard to educate, establish networking within the New Hampshire Hospital Association, specialty programs. We do presentations at, so we our third year in April, the Northern New England Nurse Practitioners Conference. And I think it's been very well received. There's been a lot of really good feedback, and it's alerted us to things that maybe we should be looking at. So I think there's a lot of changes that we can make when we know there's a problem exists, and in collaboration with DES and DHHS, we look to where we can address them, whether it's by legislation or the work of an individual subcommittee. And I think there might, actually, I don't have it with me, but we did have a list of all of the legislation, recommendations for legislation that came out of this committee.
Representative Shapiro.
Thank you, Mr. Chairman. Thank you for taking this question. I know that nationally, I've read that nationally, there's been an increase in lung cancer among young female non-smokers. And I wonder if that's been identified as an issue of study in New Hampshire through your commission.
Thank you for your question. Actually, it has not. But in that same packet, there's a page, says New Hampshire Centered Index of Environmental Exposures. And that's part of the work that we would like to be able to continue to do, is to identify areas of health concern, public health concerns. And, we have, I just use PFAS because it's an easy one and people are really familiar with it. But, we're looking at PFAS, how it affects our water, commerce, which parts of the state we know that wells all over New Hampshire are testing positive, private wells are testing positive for PFAS, but certain areas are certainly more impacted, southern New Hampshire and the seacoast. So we're looking at, making a list right now of what do we need to focus on? Are we saying, for example, in Merrimack, we hear anecdotal stories all the time about people say, I have this cancer. I can't tell you the number of calls I've got since that HB 614 passed, which funds the kidney cancer study. People that are living out of the state and said, hey, I'm not included in your numbers. Can you please connect me with DHHS? Those kinds of things happen. And we hear anecdotal stories from people that say, you know, I live there. Not only do I have kidney cancer, but I have thyroid disorders. That's one of the things that I certainly think needs to be looked into because we're hearing a lot. Do we have the data? No, we don't. But that's how, you know, I think I mentioned before when I came here before about HB 614, my goal originally was really for a full epidemiological health study for the Merrimack community. We have about 28,000 people, and we long believed that we had a higher incidence of cancer, and I also think thyroid disorders, but we have no data. There's nobody collecting the data, you know, for a number of reasons. And that was one of the things that I had hoped for, recognizing that we finally did see over time in 2018. We were told, no, you know, the cancer numbers are completely consistent with what we would expect. And then 5 years later, we have what we thought we were saying. So it's things like that rise to the top, and we're trying to create this index of exposures and health outcomes to sort of help drive what do we need to do. That drives legislation, it drives education, and so just some of the goals of the commission.
Okay, other questions? Seeing none, thank you.
Thank you.
Also signed up to speak is Representative Rosemary Rung.
Thank you, Mr. Chair, and thank you, members of the committee. For the record, my name is Rosemary Rung, and I represent the town of Merrimack, Hillsborough, District 12. I'm here to speak specifically about one aspect of the HB 85 or the SB 85 commission that makes it it's very important to keep that commission going. Some of you may be aware that over the past few years, I've been driving more attention on cyanobacteria blooms and the risk that they pose to granite staters. Back a few years ago, my bill HB 1066 was passed, which mandated that the Department of Environmental Services compile or develop a strategic plan to address the growing trend of cyanobacteria blooms in the state. They issued that report in November, and one of the major components of it is they have to educate granite staters more about the health threats posed by exposures to blooms. And in fact, tomorrow at the Senate, the SB 85 Commission meeting tomorrow afternoon, they're having a presentation by Dr. Elijah Stommel, who is a neurologist at Dartmouth-Hitchcock. He's also a neurology professor at the Geisel School of Medicine at Dartmouth. And he's been one of the global researchers leading research on the connection between cyanotoxins, specifically a chemical called BMAA, which is beta-methyl aminoalanine, and its role in, or its link to ALS, Alzheimer's, and now Parkinson's disease. So it's, from my corner of the cyanobacteria issue, education is extremely important, and the role that Senate Bill SB 85 Commission plays in gathering that information, not only to educate them and their membership, but also to be a conduit to how do we educate the public on exposure risks, is really critical. It's going to be critical to the success of this plan to drive that education component. But we need a group like the commission to be able to identify experts that can put everything in context as far as the risk and exposure goes, and also to work with DES and DHHS on delivering this information. So I do urge you to pass on HB 1171 so that this commission can continue its work, but importantly to me, to continue the work in cyanobacteria. So I would be happy to answer any questions you have.
Thank you. Any questions? Seeing none, thank you. And guess who's next? Representative Wendy Thomas. And you said you weren't going to testify again today.
I apologize. I am here again like a bad penny. Wendy Thomas, Town of Merrimack. As you know, I live in the town of Merrimack, and it is completely contaminated with PFAS chemicals. As you likely remember, following the discovery of a 42% higher rate of kidney and renal pelvis cancers in the town of Merrimack as compared to other New Hampshire communities, DHHS determined that a phase 3 kidney cancer feasibility study was appropriate and necessary. Merrimack is home to St. Gobain, Boo, a well-known industrial polluter, a heavily PFAS contaminated community, and has been identified by a former DES assistant commissioner, or has been identified as the site of the largest environmental industrial disaster in New Hampshire's history. We know that cancer can be environmentally triggered chronic illness, and that kidney cancer is linked to PFAS, and that PFOA, to which the Merrimack community has great exposure, causes cancer. This was just determined recently by a subcommittee of the WHO. A contract between Dartmouth College and DHHS was recently approved by the governor and council, and it allows this important health study to move forward. The recommendation for the Merrimack kidney cancer investigation came from this commission. Personally, my Dartmouth Hitchcock oncologist believes so strongly that PFAS chemicals caused my cancer, I have breast cancer, that they have coded my cancer as being environmentally triggered by environmental toxins. There is no code for PFAS poisoning right now, so that's the best they can do. This important commission, which will be extended by HB 1171, looks at the relationship between pollutants and the health impacts that they are known or suspected to cause. This very important commission should continue doing its very good work.
Thank you. Any questions? Seeing no questions, thank you. Representative Murphy?
Thank you for indulging me. I noticed a couple of edits that probably should be made. On page 2 of the original bill, it's
Are we talking about SB 85?
yeah, SB 85. Yep, and just because the 1171 just reestablished it, just extends the end date, but a couple of things have changed just in our last session. On page 2, we should delete number 11 because it references a pilot study program has ended. So if we could just delete number 11.
The one that says reviewing results of stage
Yes.
1. blah, blah,
Yes. And then on page 3, again, a reporting requirement has changed for DHHS. So on Roman numeral 3, where it says on the bottom, on or before September 1st, 2019, and at a minimum every 6 months, it should be changed to every 12 months.
Page 3, you said?
Yes. Under Roman numeral 3. Michelle, correct? Yes. And that's it. Thank you.
Oh, okay.
Thanks so much.
Right, this one right here. Yeah. So it's the whole line, the whole section?
No, change that every 12 months instead of
12
every 6 months.
Okay. Okay, no one else has signed up to testify on HB 1171, and that is all that we have noticed for today. So with that, I'm going to declare adjournment, and we will meet again next week, the 25th, right? Yeah.
Yes.
We'll be reconvening on the 25th. Have a good evening.